wanting to ask. Really, we want to encourage that as much as possible over the next 3 days. So as I said, this is really great to be here. It's like I said, it's been a while for many of us. This may be our first in-person meeting we've had in a couple of years. It's been a tough road, I think, for all of us, both personally and professionally. And so, I think coming together at this time is the right time. But we want to do it safely, so we want to be safe. And so I appreciate, first of all of you being fully vaccinated. And we want to, respect each other's social distance. And we have asked all of you to mask while you're indoors. And would appreciate, being respectful for that. At our banner university hospitals, we had 181 COVID patients that we were taking care of at the beginning of this week. So the pandemic is certainly not over yet. There's still some very sick people. And so, out of respect to our colleagues who are working in the hospital, our wonderful hotel staff who are taking such great care of us, we ask you to keep the masks on while you're inside, except for obviously when you're eating and drinking, or if you want, when you are speaking either up here or if you come up and ask a question at the mic, feel free to take your mask off for speaking. In any case, I think this is going to be a great meeting, and we have 126 registrants, which is among the highest we've ever had, which is really great. When we started planning this, we weren't really sure if people would still want to come to an in-person meeting, but that seems to definitely be the case. I want to especially thank all of our sponsors. It goes without saying that this meeting would not be possible without their generous support, and so I just want to acknowledge them directly now. Our diamond sponsors, Acclaron and Regeneron, our gold sponsor, Stryker, our silver sponsor, Medtronic Surgical Tech and Olympus, and our bronze sponsors, Aaron Medical, Bryan Medical, Cochlear America, Cook Medical, Dupuis Synthes, GSK, Hemostasis, Intersect ENT, KLS Martin, NeoMed, Optinose, and Tungsten Medical Network. Thank you so much for supporting this. Many of you actually have been asking us when we were going to hold this meeting, for the past year plus, and so appreciate you being here. And if you would please, visit our sponsors, thank them during the breaks. To kind of encourage a bit of interaction, you all received this little bingo card, and it's just for fun, but I think it'll be a great way to sort of, promote a lot of great interactions. And so the rules are on here, but just for fun, we have some really cool prizes to give people who are participating, including our grand prize, thanks to our hosts here at the Lowe's. We're offering a 2-night stay gift certificate at the resort. We're also going to be offering free registration for our next conference, and then we got some great University of Arizona Wildcat gear that we're also having as prizes. So enjoy this, have some fun, but I wanted to mention that as well. In terms of some highlights coming up beyond the great educational offerings, so we have a reception of which you're all welcome to this evening. The forecast high today is around 50 degrees, which probably for those of you from northern parts of the country sounds pretty good, but for those of us in Arizona, that's really cold. So we are going to move the reception inside. We were planning to have it outdoors in the back of the hotel, but we're going to host it in the exhibit hall next door, so another chance to interact with our great sponsors. But we can spread out, I think, pretty well through these 2 rooms, and so if you brought your winter coat in anticipation for tonight, that's still good, but we'll have the reception indoors. Tomorrow afternoon, we're going to let you have some time to enjoy the outdoors. As I said, it'll be a balmy 50 degrees, but no rain in the forecast, so great chance for you to get outdoors. We have a golf outing, which will be led by Dr. Eugene Chang. I think there still may be some spots open if anyone is interested in doing that tomorrow afternoon. We're going to have a hike going on up here in the beautiful Catalina foothills if you want to participate, or you can just do something on your own, and you can talk to any of our people at our registration desk for some ideas and suggestions on what you might like to do. But we're giving you the tomorrow afternoon off to kind of enjoy some of the great outdoors we have here. So we do have a Wi-Fi available for you. It's a Lowe's conference. There's a pin for it, and I think the sign for that pin is posted outdoors, and we'll try to put it up here on the screen between breaks if you need to, check your email or do other things like that. But in any case, again, welcome everyone, and we'll go ahead and get started with our very first session, which will be on pediatric otolaryngology. So I'm going to turn it over to our wonderful pediatric otolaryngology team here we have in Tucson, Drs. Skirko, Liu, and Perry.
All right, so I want to introduce Carrie Liu. She's going to be talking about pediatric obstructive sleep apnea and refractory obstructive sleep apnea. She is associate professor here at University of Arizona and at Banner. She trained University of Calgary and joined our crew after practice up there. And so we'll start with her didactic session, and then we'll have a panel thereafter.
Thanks a lot. Good morning, everyone. I'm Carrie Liu. I'm one of the pediatric otolaryngologists here at Banner University Medical Center and the University of Arizona. As Dr. Skirko said, I recently joined faculty from the University of Calgary, and it's my pleasure to be opening up this conference with my talk on pediatric OSA and refractory OSA. I have no disclosures. This is the overview of this morning's talk. First, we'll be reviewing some definitions, and then we'll go into the diagnosis of obstructive sleep apnea in kids, and then we'll discuss some approaches to refractory OSA in this population, including a discussion of some adjunctive procedures. Obstructive sleep-disordered breathing is a clinical diagnosis in children. It is a spectrum, and it ranges from primary snoring to obstructive sleep apnea. And the incidence of this is up to 12%. Obstructive sleep apnea is both clinical and a PSG diagnosis. It suggests that there's a history and you need abnormal PSG findings as well. And the incidence of this is 2 to 4%. Of course, this incidence is higher among specific populations of children, but in the general population is 2 to 4%. In children, the etiology can be manifold. There can be anatomic crowding from tonsillar and adenoid enlargement. And while adenoid and tonsil size alone is not predictive of the severity of OSA or outcomes after surgery, a combination of enlargement for both does seem to correlate. Other etiologies include decreased tone and craniofacial abnormalities. As I alluded to in the previous slide, pediatric OSA is both a clinical diagnosis and a diagnosis on polysomnography. Clinically, there should be a history of snoring, labored obstructive breathing, and daytime symptoms such as sleepiness, or in children more commonly, hyperactivity and inattention. On PSG, there should either be an apnea-hypopnea index of 1 or more, and that is based on normative studies that were done over 20 years ago where they did PSGs on healthy asymptomatic children and found that in an otherwise healthy asymptomatic children, there should not be any apneas or hypopneas, so that's where the 1 comes from. Alternatively, they can have an abnormal PSG if there is an obstructive hypoventilatory pattern with at least 25% of the total sleep time being hypercapnic with associated snoring, flattening of the nasal pressure waveform, or a paradoxical thoracoabdominal movement. The last set of guidelines for when to order a polysomnogram in children with sleep-disordered breathing was published from the Academy in 2011, but the 2019 tonsillar guidelines or tonsillectomy guidelines alluded or referred to these recommendations, suggesting that they have not changed from 2011. And the indications are children with specific comorbidities such as obesity, trisomy 21, craniofacial abnormalities, neuromuscular disorders, sickle cell disease, and mucopolysaccharidosis. In children who do not have these abnormalities, a PSG is advocated in the setting where the need for surgery is uncertain, or there is a discordance between tonsil size and physical exam and the reported severity of sleep disordered breathing. And in these kids, the goal of a PSG is to confirm the presence of OSA, to determine the severity, which then guides perioperative management, as well as assist or to obtain a baseline for comparison after surgery. Depending on the practice setting and the resources available, there can be many challenges in obtaining a PSG. Having just come from the Canadian system, our wait lists for a PSG were in the realm of months, only made worse by the pandemic. It's also challenging to obtain a PSG in children because a level 1 sleep study, you have all these leads and monitors, and depending on the neurodevelopmental age of a child, it can be incredibly challenging to keep the monitors on and to obtain an accurate exam. Because of that, there has been a lot of interest in home-based sleep tests on children, adults too, but in children as well. These home-based tests typically measure fewer physiologic variables. Some only do heart rate and pulse oximetry, while others measure CO2, but in general, there are fewer variables that are being monitored. And because of that, there can be a decrease in the sensitivity of the diagnosis of obstructive sleep apnea, and where OSA is identified, the severity can be underestimated. And because of that, currently the American Academy of Sleep does not recommend any home-based sleep testing for the diagnosis of OSA in children. So then that leaves a lot of us with having to diagnose these kids clinically. There are a lot of questionnaires out there. One of the most common ones is the Pediatric Sleep Questionnaire for Sleep-Related Breathing Disorders. It's a series of questions, yes or no, that is completed by the caregiver that pertains to the symptoms of the child's sleep and daytime behavior. Parents either answer yes, no, or don't know. The score is the number of yeses divided by the number of total answered questions. And this is a validated questionnaire, and with a score of 0.33 or more, there is an 85% sensitivity and 87% specificity for diagnosing moderate to severe obstructive sleep apnea. So this can be quite a helpful tool that assists in the clinical setting, but despite this, it seems to be underutilized. There was recently a consensus statement by the International Pediatric Otolaryngology Group where they surveyed the experts, and they found that about 85% of experts do not use any validated questionnaires in their practice setting for whatever reason. Once we reach the diagnosis of sleep disordered breathing or obstructive sleep apnea, we have a few options. It's an option to watch kids with mild and maybe moderate obstructive sleep apnea per the childhood adenotonsillectomy trial that was published a while ago. There can be a trial of anti-inflammatory treatment with nasal steroids or leukotriene inhibitors. Positive airway therapy is an option, although in children the compliance is quite low and can be very challenging. And then surgery, which typically involves adenotonsillectomy as the primary surgery. Most kids do well after adenotonsillectomy with improvement in nighttime symptoms and daytime symptoms, but depending on the study you read and the patient characteristics, the risk of persistent symptoms or an abnormal PSG can be as high as 75%. There are risk factors for this. Children who have severe OSA to begin with are at increased risk, children with specific comorbidities, and then children with small tonsils or a non-obstructive adenoid at initial surgery, suggesting that perhaps there are other sites of obstruction in these kids, and that's why they didn't get better with an adenotonsillectomy alone. These kids almost universally get a polysomnogram to identify any residual OSA, and then after that, the next challenge is to identify the site of obstruction, and that can be done with sleep endoscopy, cine MRI, or sleep fluoroscopy. I'm going to spend a bit of time talking about drug-induced sleep endoscopy. The goals of sleep endoscopy is to reproduce all stages of sleep, with particular attention to non-REM stages 1, 2, and REM sleep, because these are the stages of sleep that are the most prone to obstructive events. The other goal of using medications in terms of drug-induced sleep endoscopy is to maintain spontaneous ventilation with spontaneous rhythm and maintained upper airway muscle activity. In addition to reproducing sleep stages and maintaining spontaneous respirations, the ideal anesthetic should be quick in onset and have a short half-life, and that makes for more efficient use of operating time. In terms of the sleep endoscopy directed surgery and when to complete it, that is really up to the surgeon or parental preferences. It can be done under the same general anesthetic as the sleep endoscopy, in which case parents may need to be prepared for the whole host of possibilities prior to initiating surgery, or it can be done under a separate general anesthetic after the family has had a chance to have discussions with the surgeon and to think about their options. I think about indications for sleep endoscopy in terms of when during the treatment process that occurs. Most commonly, it is done for persistent or refractory OSA after adenotonsillectomy, and there was a systematic review published that looked at the utility of sleep endoscopy in site identification, and they found that sleep endoscopy was helpful in identifying the site that was the culprit in 100% of the patients. And in these patients, the sites of obstruction that were most commonly found were tongue base, adenoid regrowth, inferior turbinates, the velum, lateral pharyngeal walls, and the supraglottis. Sleep endoscopy may also be employed in the setting of prior to primary surgery in patients who are at high risk for persistent sleep apnea, including those with these comorbidities, as well as in patients where you suspect another site of obstruction, so either sleep state laryngomalacia or tongue-based obstruction. The technique is something that we should all be fairly familiar with. The patient is positioned supine with the head in neutral position. Typically, no topical medications are used, and the avoidance of a topical anesthetic is related to wanting to preserve any airway reflexes that might be in place. We start from the nasal cavity and advance to the level of the glottis, stopping at the nasopharynx, oropharynx, and larynx to assess the various areas that may cause obstruction. There are a couple of adjunctive procedures that can be done as well during sleep endoscopy to aid in a more thorough assessment of the airway. One is a chin lift, which simulates a closed mouth sleep state, and the second is a jaw thrust, which simulates what a mandibular repositioning device might do. Another area, or an area of uncertainty in sleep endoscopy, and one of the limitations is the lack of consensus regarding scoring systems. There are numerous scoring systems in the adult population. There are about 6 in the pediatric population, but only 2 that are validated to PSG findings. It's difficult to gauge from the literature which are more commonly used. I think a lot of this is institutional. I'm going to be discussing the 2 that have been correlated to preoperative PSG. The first is the Champerique scoring system from Seattle, where I did my fellowship. There are 5 sites that are graded: the adenoid, velum, lateral pharyngeal wall, tongue base, and the supraglottis. Each site is graded from 0 to 3, and the authors do offer a grading guide in the original paper. This score was found, or this scoring scheme was found to have high inter and intra-rater reliability, and they found that a total obstructive score, which equals the sum of all the individual scores, was associated with a lower oxygen nadir. They also found that patients who had multiple levels of obstruction were more likely to have severe obstructive sleep apnea. The second scoring system is the sleep endoscopy rating scale. Unlike the Champerique, this grading scheme also includes the nasal airway, specifically the patency between the inferior turbinates and the septum. So with these 6 sites, each is graded from 0 to 2, from no obstruction, partial obstruction, to complete obstruction, and they found that the total score strongly correlated with the apnea-hypopnea index. They also found that a score of 6 or more was predictive of severe obstructive sleep apnea with 82% sensitivity and 88% specificity. And finally, a score of 6 or more correctly classified 84% of patients. So there are a couple of good validated grading schemes that can be used to aid in standardized reporting. Excuse me. Despite that, currently there's no consensus on which scoring system should be used universally. So the next question is, does sleep endoscopy targeted surgery actually improve patient outcomes? And to that, we have to look to the literature. There isn't a ton published in this realm, and that's going to be a theme you'll see for the rest of the talk. But the first group, and what's summarized in this table, are DICE targeted surgery outcomes in surgically naive patients, so patients who have not had any surgery. Most of these studies were small and retrospective in nature, but they all did find a statistically significant improvement in the AHI after sleep endoscopy targeted surgery. I'm highlighting these two studies because they include general pediatric populations presenting for primary sleep surgery, whereas the other three looked at specific populations, whether that's patients with hypotonia, small tonsils, or at risk, or had other risk factors for persistent OSA. In the two studies that had general patients, despite having sleep endoscopy, the vast majority of them had an anal tonsillectomy. Whereas in the other three studies with more targeted populations, they were more likely to have a non-anal tonsillectomy surgery as their primary sleep surgery. So what this tells me is that in an otherwise general pediatric population presenting with OSA, sleep endoscopy is unlikely to be or to add significant value because you're probably just going to do an anal tonsillectomy and kids are going to get better. But in the specific populations as listed here, either small tonsils or adenoids or comorbidities, sleep endoscopy may be helpful at the time of initial surgery to guide more targeted surgery. The next population are the patients who have had an anal tonsillectomy but have refractory OSA. And there are, again, only a few studies that look at this. Most of the patients in the studies listed here had comorbidities like trisomy 21 or craniofacial abnormalities. The most common sleep endoscopy-directed surgeries reported in these studies were revision or primary adenoidectomy, revision or primary tonsillectomy, lingual tonsillectomy, and supraglottoplasty. There was also a high rate of multi-level surgery, up to 88% in one of the studies. And they all did find improvements in postoperative AHI, with the exception of the first study. And so what we can conclude from this is that children who present with refractory OSA would also benefit from sleep endoscopy-directed surgery. So to briefly summarize sleep endoscopy, because there were quite a few slides there, there is a role for it in persistent obstructive sleep apnea after adenal tonsillectomy. It also has a role in primary surgery if you suspect a different site of obstruction besides the adenoids and tonsils, or if the patient has risk factors for persistent OSA. For future direction, there needs to be more work done to standardize reporting and scoring and better delineate which surgeries may be most appropriate depending on the patient or physical exam phenotype. To briefly touch on sleep cine MRI, it's similar to sleep endoscopy in that medications are used to induce a sleep state with spontaneous ventilation, and sagittal and axial images are then obtained and shown in cine format. Proponents of cine MRI say that it allows for you to simultaneously assess multiple levels of airway obstruction, whereas in sleep endoscopy it's more sequential, you do one at a time. It also allows for you to assess primary obstruction versus secondary sites of obstruction. And then it also allows for the quantification of adenoids, pharyngeal tonsils, and lingual tonsils. It may also help you differentiate in patients with tongue-based obstruction, muscular obstruction versus tonsillar hyperplasia. There are some disadvantages. With the cine MRI, it usually does commit the patient to 2 general anesthetics. Logistically, it can be very challenging to kind of flow from MRI to targeted surgery. The flow is much more natural with sleep endoscopy and targeted surgery. It's also less widely used compared to sleep endoscopy, so even more so than sleep endoscopy, there is no standardized protocol, and there is no reference data for the size of adenoid, pharyngeal tonsils, or lingual tonsils. So even if you can measure them, well, what does that mean compared to normative values? So more work needs to be done there. So once the sites of obstruction is identified, there may be some procedures that can be done beyond a revision or primary aneurysectomy and tonsillectomy. First, we'll talk about some palatal procedures that may be helpful in children with either an elongated palate or palatal or pharyngeal collapse. In general, the outcomes of these procedures are much better described in the adult population. Lateropharyngoplasties are minimally invasive compared to some of the others. It involves suturing the anterior and posterior tonsillar pillars either at the time of tonsillectomy, which is most common, or independently as a separate procedure. The idea is that it stabilizes the palate, prevents collapse. There are only a couple of studies that look at this procedure and its efficacy in children. The first was a retrospective review with 21 children who had only a TNA and 16 that had a TNA and a lateropharyngoplasty. Unfortunately, in their study or methodology, they don't state how they decided which patients would have both the TNA and lateropharyngoplasty and which would have the TNA alone. In both groups, there was an improvement in the AHI, but no difference between the groups. A more recent and larger study randomized kids to receive either a TNA alone or TNA and lateropharyngoplasty, and they also did not find any difference in the rates of surgical cure between the two groups. Unfortunately, in their study, they had quite a high dropout, so ultimately the study was probably underpowered, and that may account for why they did not find any differences. And so what I conclude from this is that currently we have insufficient evidence to determine whether or not lateropharyngoplasties offer any additional value compared to a tonsillectomy alone. For expansion sphincter-pharyngoplasty, it's a bit more involved. I've included some schematics here. With this procedure, fibers from the palatopharyngeal muscle are isolated and then rotated and suspended superiorly and laterally to the soft palate. The idea is that it expands the diameter of the pharyngeal airway. And you can see picture A versus picture E pre and post-operatively that there does seem to be widening of the pharyngeal airway. There's only one study that looks at this procedure and its outcomes in children. It was a retrospective review where they looked at two groups of patients, one that had a TNA with an ESP and one with a TNA alone. They found these groups and matched them based on the severity of AHI, and how they determined who would get an ESP was sleep endoscopy was done, and if there was lateral collapse, and these patients were offered an expansion sphincter pharyngoplasty. But yes, they were matched on AHI preoperatively, but as you can see, not other variables, and I'll show you. So this table shows the characteristics of the study groups. And patients who had a modified ESP tended to be older, they tended to have higher BMI, and also smaller tonsil grade. So even though these groups were matched on AHI, they had other differences in some very important categories. And preoperatively, they had similar AHI. I think that was a mistake. In the body of their manuscript, they reported non-significant p-value. Postoperatively, they found that children who had a ESP in addition to a TNA had greater reduction of AHI. Even though this is an imperfect study, I do think that it shows that in a carefully selected patient, one who might be older, overweight, or obese, or have smaller tonsil grade, an ESP in addition to a tonsillectomy and aneurysectomy may offer additional benefit in terms of reduction of AHI, but obviously needs to be studied further. For UP3, again, not a whole lot done in children. There are a couple of studies on neurologically impaired children. The study by Costco, I think, methodologically leaves some things to be desired. They said that their patients improved, but really they only did PSGs postoperatively in 2 out of 15 patients, so hard to make any firm conclusions from that. A more recent study by Kirshner did find that children who had an UP3 had symptom improvement, at least in 87% of their patients, and they also found an improvement in the oxygen saturation nadir. Most recently, the study by Com et al. In obese children found that in general, there was low rates of resolution, whether it was UP3 alone or UP3 with the TNA. And so what I take from this is that in some patients, it may offer some benefit, but you're unlikely to be curative. For tongue-based procedures, we are talking about lingual tonsillectomy and midline posterior glossectomies. With the lingual tonsillectomy, there are different techniques, most commonly with either cautery or radiofrequency ablation. There are some increased complication rates with this. There's a risk of tongue-based edema, which in up to 19% of patients can cause significant postoperative airway obstruction, and the hemorrhage rates are a little bit higher as well compared to pharyngeal tonsillectomies. Lingual tonsillectomies are most commonly reported in the setting of refractory OSA in children. And this meta-analysis from 2017 looked at the existing evidence, and they found 4 studies that looked at lingual tonsillectomies in the refractory OSA setting in children. The first forest plot looks at improvement in the AHI after lingual tonsillectomy, and they did find that there was a significant improvement. The second forest plot is looking at the oxygen saturation, and they found that there was a significant improvement in the average oxygen saturation after lingual tonsillectomy. So they concluded that in this population of patients, a lingual tonsillectomy can be safe and effective in improving obstructive sleep apnea. They also found an overall cure rate reported across the studies of 52%. We're almost there with the procedures. With the midline posterior glossectomy, only a couple of studies on this. This one out of Toronto had a very specific population. It was trisomy 21 patients who had persistent OSA after an tonsillectomy and who did not tolerate positive airway pressure therapy. They identified tongue-based obstruction on Sydney MRI. Their technique was to identify the lingual arteries on ultrasound and then perform midline tongue division with submucosal coblation. Their results were dependent on the body habitus of the kids. In kids who were normal in weight and who remained normal in weight postoperatively or who were overweight had a significant improvement in the AHI. Whereas kids who were obese pre-op or normal pre-op but became obese had less reduction in the AHI. And so midline posterior glossectomy may be a useful adjunct in normal weight or overweight children with trisomy 21 and persistent OSA. This smaller study included both syndromic and non-syndromic children. Again, these are refractory OSA kids who did not tolerate positive airway pressure, and tongue-based obstruction here was identified on sleep endoscopy. They didn't report how they did the midline posterior glossectomy, but they did find an improvement in the AHI. And so, again, midline posterior glossectomy may be beneficial in a very select group of patients. And the last thing we're going to touch on is hypoglossal nerve stimulation, which has emerged as a likely or a promising treatment for adults with refractory OSA who failed positive pressure therapy. Here, there is an electrical cuff that's implanted around the hypoglossal nerve with a neurostimulator in the infraclavicular space and a sensing lead in one of the intercostal spaces. The stimulator gives an electrical current to the cuff, which then stimulates the hypoglossal nerve, causing the tongue to contract, opening the airway, and that the pacing is according to respirations based on the sensing lead. And there is some good evidence in adults. There is currently one implant that's FDA approved by Inspire Medical, and this is their criteria for the implant. So not currently approved in children, and the criteria is based both on PSG and physical exam findings. Even though it's not approved in children, there has been some work done looking at this technology in children. The largest study out of Boston looked at 20 kids and adolescents that were non-obese with trisomy 21 who had refractory OSA. And they found that in those implanted with a hypoglossal nerve stimulation implant, on the 2-month PSG, there was a median percent reduction in titration AHI of 85%, and they found high nightly usage rates. They also found an improvement in the quality of life score as reflected in the OSA 18 score, which was filled out by the caregivers. To summarize this morning's talk, PSG is the gold standard for diagnosing pediatric OSA, but validated questionnaires can be very helpful in assisting a clinical diagnosis. For drug-induced sleep endoscopy, can be considered either in the refractory setting or in the primary setting with specific risk factors, and targeted surgery in this case is associated with improved outcomes. And numerous adjunctive procedures, limited evidence, but may be appropriate in a carefully selected group of patients. And that's it. Thanks.
All right, that was an excellent overview of everything sleep apnea related. So how'd you get it to?
Here you go.
All right. So we want this to be as interactive as possible. So as we're going along, if anybody has any questions for the panelists as we're discussing these cases, I'm going to try to bring out a lot of discussion, but if you have additional questions, please feel free to step up to a mic and ask our experts anything that's on your mind about how questions you might have about any of these cases. So the first case that we're going to discuss is JK. He's a 14-year-old who has a history of a previous posterior fossa resection. He had a TNA when he was 7, and he presented to you after sleep study. And his sleep study showed an obstructive AHIS-7 central apnea index of 0.5. On physical exam, his palate seemed a bit long. Neurologically, he's normal. There's no neurologic problems that you can identify, and he's failed CPAP. So what are your first thoughts on managing this type of patient, Carrie? And we'll have to double check the mic here.
It's probably on.
You can just say, and then I'll repeat it.
Do I have thoughts?
Did you say Carrie or you?
Carrie. Carrie Lou.
Well, my first thoughts with this patient is to examine them in person, which sounds like I already have, and to see if there's any signs of tonsil regrowth depending on the initial procedure, intracapsular versus total, and also if there's any adenoid regrowth, any obvious nasal obstruction in this population. There could be a component of septal deviation. It sounds like the only pertinent thing with long palate, so I think the next best step would be likely sleep endoscopy to determine the site that's causing the most obstruction.
Any additional thoughts, Dr. Perry?
No, yeah, I would agree. I think that these are complicated kids, and they're not easy to manage. But certainly, a full exam in the office, especially that you can actually do some endoscopy and a sleep endoscopy, I think is probably going to be warranted in this kiddo.
Would you guys tend to do awake endoscopy in clinic first, or rely more on sleep endoscopy? Are there any specific patients that you might do in clinic endoscopy versus go to sleep endoscopy, or?
Yeah, I for sure would do endoscopy in the clinic.
Okay.
And generally, I think you can get a good idea of the nasal airway as well, which is going to be a part of this problem potentially, where you would evaluate the nasal airway prior to decongestion, and then even post decongestion, see if what kind of differences that makes. But certainly in the office, I would, in a 14-year-old, pretty much in all kids, I would do, in this case, endoscopy prior to the DICE.
And then how long would, like, if the patient comes into clinic and they say they're not tolerating CPAP, how long do you want them to try, and how hard do you push CPAP for this type of patient?
Well, it depends on the physical exam if I think I could improve things with further surgery. Sometimes looking at the body habitus of the child and other things, I'm fairly certain that there's no amount of surgery that would obviate the need for positive pressure.
Gotcha.
In that case, I may really encourage. If I see an obvious surgical source, then I'd be more
inclined to
willing,
intervene.
And I'd also be interested in finding out why they're failing CPAP.
Yeah.
Goes to Dr. Perry's point about assessing the nasal airway. Because if I can't cure the sleep apnea with surgery, I can maybe improve his tolerance depending on the kind of mask he's using.
Definitely, and that's a really good point. We were not going to, in these cases, I don't think have any that we talk specifically about nasal airway. We have a whole nasal airway session in a bit, but with this level of obstructive sleep apnea, an OHI is 7, nasal airway can definitely lead to that category of sleep apnea, and intervening on the nasal airway can both help to be an adjuvant for CPAP therapy with that as a goal, but it can also be sometimes more curative. Cine MRI personally has been really challenging to set up a system where Cine MRI works, but it can be really helpful for especially certain patient populations where you might want to go in with more data when you're getting into the operating room.
John, I have a question on this kiddo. So, he had this posterior fossa resection. We didn't really talk about, were there any other neurologic sequelae of that could be contributing to this problem?
Sorry, that's not advancing on the screen. I don't know why. Hold on. No, there weren't, and so he seemed completely normal otherwise, so that, other underlying neurologic sequelae can definitely contribute to failure of surgical intervention. All right, so now it's looking like our presenter mode is making these challenging. Here we go. Now we're getting it. All right, so here's the sleep endoscopy, which you'll see up here. So this is the soft palate is here. As with soft palate collapse, it can be challenging because the mucus accumulates there. And then as we get into the hypopharynx, you'll see the tongue base isn't obstructing dramatically, but that epiglottis is retroflexing pretty impressively. So just go back to show that. So as you advance beyond, it doesn't seem like concentric. It seems like mostly AP palate collapse, and then his epiglottis is retroflexing there. So, sorry, the way the presenter mode is working, it's making it challenging. Sorry about that. So with that endoscopy, what would your next target be for this patient? They're in operating room, they're asleep. Oh, we're not going to do anything. Just go try CPAP some more. Would you maybe try to address the palate, the tongue base, the epiglottis? What do you think is the next target based on that sleep endoscopy for you?
With that sleep endoscopy, with the retroflexing epiglottis, could you tell if it was tongue base that was having mass effect or pushing the epiglottis versus the epiglottis flopping on its own?
Great question. So the tongue base itself seemed to be in a fairly good position. The hypopharynx was somewhat round. It was a little bit ellipsed, but it wasn't dramatic tongue base. It was mostly the epiglottis retroflexing. And as I'm thinking personally about these patients, try to think about what's the primary obstruction, what's causing the most obstruction, and the epiglottis is definitely retroflexing, but that palate is you could see, it's very hard to even see in that space. And that's sometimes where these kids can be challenging, where you potentially have this multi-level obstruction. What would your thoughts be, Dr.
So, if I understand you correctly, really, the palate.
Both are obstructing, and we have to pick. That's where we're left often. And
Right.
it's hard to know which one is primary, because sometimes it's primary obstruction, you have increased airflow, and that draws in, and maybe it's the palate is primary, maybe it's
Right.
the epiglottis retroflexin is primary. Hard to know.
I,
You get to pick rock, paper,
so-
scissor.
You know, I would probably elect for some palate procedure in this case. I mean, you could do epiglotopexy. I haven't had a ton of success with that surgery, to be totally
Yeah.
frank.
Yeah, and I think that, in my opinion too, that really leads into like how much morbidity is the treatment going to provide the patient, and how much success. And with epiglotopexy, personally, I often have to do a bit of tongue-based reduction to really just have it work, and that can be really challenging for patients. So I'll often try to hold off on that one. Let's see. Sorry, it's again with this not advancing slides. So with the multi-level, we're kind of touching on this. Would you do multi-level? Would you do the palate and the epiglotopexy at the same time? Would you stage it? Have you ever managed any patients that you did that multi-level sleep surgery was done, and maybe in your fellowship, and then you regretted later? I know I had. Those patients can stay in the hospital for a really long time.
Yeah, I think if I feel that I'm not putting the patient at risk for circumferential scarring, I would
Mhm.
attempt multi-level, even if it's a harder recovery. I also engage the parents in this discussion too.
Yeah.
You know, maybe an easier recovery, but a lot of parents want only one general anesthetic as much as possible, especially in a child who's had previous surgeries before. And so, yeah, it's a roundabout way of saying I would probably attempt it if I feel like it's not going to place him at risk for scarring.
Definitely. So I think, it depends on what the levels are. And so palate and epiglottis or tongue base, I would be very hesitant to do those two together. Nose and palate, recovery from nasal surgery is much less and is much easier. And so I'd be more inclined, if there was nasal obstruction and palate, to do those two together personally. Thoughts, Dr.
Yeah,
Frank?
I am kind of like a one-move guy, and I get that parents hate the idea of a second anesthetic, but for me, you know, if I identify a couple places, I would much rather kind of hit one place and find out what the result is in this kind of a child than try to do two at the same time.
Definitely.
Unless I like turbinates or something somewhat similar
Yeah,
like that.
exactly.
But as far as the hypopharynx, obviously larynx and oropharynx, I'd try to do one at a time and help the parents get through the idea of a possible second anesthetic.
Perfect. I concur. All right. So our next case.
So John, real quick here, before you go, what do you do? Like,
What's that?
This is a great case. What did you end up doing for this kiddo?
Oh, sorry, I guess I should have put that. So I did a expansion pharyngoplasty, and he had, I guess I should have put that in, huh? And his preoperative AHI was 7, and it was really interesting. So after I saw him and we planned it, he actually got into a car crash, which is something in teenagers that you really need to discuss. And as we're dealing with pediatric populations, we, or maybe it wasn't because he was 14. No, it was another kid that was similar. So as you have teenage patients in your office that you're doing sleep surgery on, you need to counsel them on the sleepiness effects. And so a similar patient that's actually had a car crash while we were waiting, so we had to delay surgery. He was okay, but it delayed surgery. And so symptomatically, he was dramatically better, and his AHI went from 7 to 1. So YA is our next case, 15-month-old, severe OSA, unable to tolerate nasal cannula even, let alone CPAP, just tearing it off. Subjectively, significant nasal congestion, tonsils are 2+, and also mouth breathing, no craniofacial abnormalities. And if this patient showed up in your clinic alone, you might not have as much concern, but they show up with a sleep study and the AHI is 202 and on the room air component. And when you get sleep studies, you either have a diagnostic study or a titration study. And in kids that are like this, it'll be like a pseudo titration where they were so hypoxic that they started them on nasal cannula. And so the room air component was 66 minutes. on a quarter-liter nasal cannula, which is what they needed to correct their hypoxia. Their AHI was 97. What would your next step be on this patient, Carrie?
Well, if I saw that, I'd be interested in consulting peds. In such severe obstructive sleep apnea in the little one, I would be interested in getting a blood gas to see what their CO2
Excellent.
levels are at baseline.
Excellent.
And then perhaps they need to be admitted for more urgent treatment.
Definitely.
And then, of course, the endoscopy and things like that in clinic.
Yeah, so CO2 retention in these patients with more severe sleep apnea, there's severe sleep apnea that's in kids that's greater than 10, and then there's, I would call morbid sleep apnea. Above like 30, 40, 50, those patients can be very different, and sometimes the CO2 tracings weren't working well, and so you really need to have an extra keen eye on hypoventilation in these patients. So that's definitely a good step. Was there anything you do in clinic? Would you do flex scope in clinic? Probably. And we think alike. Would you, maybe we'll start with that and then we'll discuss other.
And real quick here, John, so neurologically, this kid is 100% normal.
Neurologically, this kid is 100% normal. No difficulties during pregnancy or delivery, has been otherwise normal except for snoring since birth, right?
Yeah.
Ever since the baby was born, they've been snoring.
No.
And so I pulled out, and these slides got grainy. The flex scope was, the video was kind of, mucusy and gross. So I just pulled out some images. So here's anteriorly what the flex scope looks like. So anterior, fairly open. As you get to the back, there's mucus. You can see some adenoids kind of superiorly. As you advance down into the hypopharynx, you'll see that the hypopharynx doesn't show a lot of tongue-based collapse. It's not elliptical. These patients are awake when you're doing this in clinic, right? So you want to understand, even kids with like pure band sequence, they don't always have profound tongue-based obstruction on awake endoscopy, but it's round. And the supraglottis looks normal. There's no vocal cord paralysis. So that's kind of where we're at. Sometimes when you do endoscopy, the tonsils look bigger further down. Didn't really identify that. So that's kind of where we're at after that. Would you tell them to do CPAP in this 15-month-old? Do a tonsillectomy? Palate procedure, tongue base, epiglottis, DICE?
I vote sleep endoscopy.
Sleep endoscopy. Would you go in discussing like, okay, if I see this, I'm going to do this, or would you have two separate anesthetics?
My personal practice is I consent parents for like all of the possible things. We go through each of the levels, the things I might do. Usually I have some suspicion as to which I'm most likely to do, and I'll tell the parents that, but I do prepare them for everything. I just find it more efficient on the day of the operation.
Yeah, I agree. I think that from what I've seen in this case so far, the nose is absolutely going to be part of the mix here. That thick snot that we love so much in the back of the nasopharynx that comes off the adenoid, I think that I would for sure consent for T and an A and possibly a reduction of turbs, and then obviously beyond that, I don't know that I would do it at that same visit. Probably just because your preoperative scope didn't really show a lot of tongue-based stuff. And again, the larynx looked okay, but I'd have more information coming out of sleep endoscopy at that point.
And these ones can often, yeah, go ahead.
Why not just adenoidectomy alone?
Excellent question. I've found adenoidectomy can be very helpful for the nasal obstruction, but I've not seen it reduce an AHI from 200 to anything normal. If the patient hadn't come into my clinic with that sleep study, I don't even know that I would have, with that description, I don't know that I would have pushed forward with that. I probably would have done endoscopy because the tonsils weren't super big and the symptoms sounded more impressive, but they have that data in front of you. And with an AHI of 200, I think the chance of an adenoidectomy alone solving that problem would be very low in my hands.
Yeah, I agree, and
At least the way I do in adenoidectomy.
this is also some of the times where we have information that we kind of wish we didn't have, to be totally frank.
Yeah.
And when a kid comes from a pediatrician with a sleep study already there, whereas if you hadn't seen the data, you'd say, oh, well, this kid clearly has a terrible nose, and the adenoids are obstructive, and we're going to make this very simple and safe intervention and find out how we do. It seems, and certainly in my practice, it's not as simple when they come in with this sleep study that is so glaringly horrible that you find yourself saying, well, an adenoidectomy probably isn't going to be all that, and probably isn't the whole answer anyway, but it is interesting how when you have data on a totally otherwise normal child, it may change the way you approach it.
Definitely. All right, let's see if we can get this. So that was my approach. And so logistically, I also will consent them for things that I'm comfortable doing at that time. So tonsillectomy and adenoidectomy is something that I would have discussed, and if the tonsils weren't obstructive, then I wouldn't have done that in this age of kid. If the kid was, say, 3 or over, I probably have a very low threshold for doing a tonsillectomy, but a tonsillectomy in a 15-month-old is very different than a tonsillectomy in a 2-year-old and a 3-year-old. And so I would let the sleep endoscopy guide that piece of it personally. I probably also wouldn't even discuss anything tongue-based in someone under 4. That can be very challenging for the patients to heal from. And the parents often will ask, like, okay, are you going to call me and let me know what the decision is going to be? And you don't want to get into that situation where you're calling out, okay, we found this, we're going to do this, does that sound okay? You don't want, there's already enough logistical problems in every OR around the country, so I wouldn't go down that road. For the patient's sake, just so there's less anesthetic time, of course. And, all right, so let's show this sleep endoscopy. So here's these generous adenoids here. So we got the adenoids. Here's our palate level. There's our epiglottis cellular affection. You see those tonsils that aren't very big, they're collapsing and they're completely obstructing in the midline there. And not a lot of supraglottic obstruction. That's another thing in this patient population that you really want to look out for is sleep-induced laryngomalacia. If I saw evidence of that more on the awake endoscopy, I probably would have had it be a tonsillectomy versus a supraglottoplasty and booked it as that. As patients get older, I think that seems to be less likely, but it seems to be more common in littler nuggets. So what are you going to do now? You did the sleep endoscopy. You're going to take tonsils out. You're going to, I'm guessing you're not going to do anything that tongue-based or epiglottis. It seemed to be pretty good.
So I just have a question for you, John and Carrie. Have you ever had any success at the retry CPAP plan?
No, never.
Okay.
0% success.
Me neither. Like, that never works. If a patient isn't doing well on CPAP and having them retry it again and again, I've never successfully found a way to...
If they haven't actually seen sleep medicine, though, that can be really helpful. Some sleep medicine clinics do have a little bit of a setup where they will have someone that can help walk the families through it. If they just were sent one in the mail and they never had a really good discussion about it, then potentially, depending on what your chance of curing the problem is. And so, so I did BNC because of that degree of lateral wall collapse in the small tonsils. So I did a lateral pharyngopexy, which Dr. Liu described. So my lateral pharyngopexy is slightly different than that described. And so you see the tonsils are pretty small, and when there's crowding along here, sometimes there's even redundant posterior pharyngeal mucosa and tissue, or if the posterior pillars are really medialized, those kids and adolescents, especially if they have lateral wall collapse, can really run into trouble. And so my lateral pharyngopexy catches, so I go through the posterior pillar, and I use a 2-0 if I can fit it in, or a 3-0 Vicryl on a SH, if I can fit an SH. This kid, I think I couldn't fit an SH in their mouth, but that's what I'll use. So I go through, depending on how thick the posterior pillar muscle is, I'll sometimes grab an extra throw of it. You want to make sure you leave yourself enough here to tie, but you don't have to pull it all through because you're going to really get bound up when you're throwing this. Then you go through the anterior pillar. The common way of doing it is just to suture the pillars together. That doesn't work. The tissue here is very thin, I found, and you need something stronger that's going to pexy it laterally. And what I've found is right here, the mandible is pretty dang strong, so if you come through this fossa, the first couple times you do it, you'll be very nervous, and you catch the periosteum of the mandible here, you come out like that, and then you end up going back through. You're going to pexy that pillar laterally in a way that is very challenging to do otherwise. And so that's my lateral pharyngoplasty, so it goes through there. Sometimes it's hard to get that angle, and sometimes you have to do one side at a time. And then after you go through, back through the fossa, having it come out is also challenging. So you sometimes just get the tip. You have to use your herd retractor to move that pillar so you can see the tip of your needle. And then I go back through that posterior pillar, and then you got to hand tie that down to cinch it out. I've found this to be really helpful. So let's see if this is going to advance. So that's what it looks like post-operatively. It really cinches things out, and because of the vectors, it actually pulls things forward a bit too. Because as you're going to that mandible, it's not straight lateral, it's forward a bit, a lot like the expansion. There's also some sutures that you can do in older kids. These things are uncommon. I look for it, and I very rarely need to do it. But you can also do some suturing that pexies that palate anteriorly if there's a lot of, not as much lateral collapse and a lot of just length. And so that can be something to help to minimize morbidity and try to improve outcomes. So you can see these pillars are really pulled laterally. Oftentimes when you do that, that posterior pharyngeal mucosa that sometimes is really redundant, it gets really stretched, and sometimes it's even like tented in the middle and you'll have to release it. So it can really be helpful.
John, so it's basically a horizontal suture, horizontal mattress suture.
Huge, it's like a 6-throw horizontal.
And then you obviously, you're tying it on the posterior side.
Yeah, I've tried tying it a
side.
couple of different ways, and what I found works best in most kids is having it on the mucosa at that
On the posterior
pillar.
side of it. And then are you just doing, is it one or two? Like how many levels are you throwing sutures? One big?
It's one stitch,
Okay,
and that's why I use a 2-0.
got it.
Try to get it to stay as long as possible and take advantage of that healing.
Have you had much VPI with this after?
0, though I counsel them on that. So
And why do you think you have not had VPI?
I don't know, because as I'm doing that, I think it settles in to some degree, obviously. But this kid, I didn't put the results. So HI went from 200 to 6. I told the parents, like, we're going to try to get this better, but it went to 6. I was shocked. And so, of course, I had to put that patient in. All right, so the next one was tongue-based, but I think we're going to move on. Nobody wants to do tongue-based surgery anyways. But it's horrible. I think most patients that probably benefit from a tongue-based procedure are probably very soon going to benefit from hypoglossal nerve stimulation. The caveat that I will say is that when you have that complete concentric collapse that doesn't work, that's where these types of pharyngeal expansion pharyngeal procedures may help you to get to a place where now their tongue base is the main site of obstruction. So we'll just skip through that. And any questions?
Yeah, John, I'll have a question for you guys. So with regard to the lingual tonsillectomy, which is really the only recurrent tongue-based procedure I do,
Yeah.
what have been your indications for it? And operatively, are there things that you guys do to try to minimize the post-operative complications? It's not just edema, but that seems like that is incredibly painful for the kids as well. So,
Excellent question. So I've found that when you have hypopharyngeal obstruction. Lingual tonsillectomy is a lot less morbid than tongue base reduction, but it's also a lot less effective. And so I used the Colorado data to look at the improvements with lingual tonsillectomy, and then I didn't publish the data on the tongue base obstruction or the midline glossectomy case series, just because it was so messy. You do these in patients that have Down syndrome usually. That's what most of the studies have Down syndrome, predominantly Down syndrome, because that's the main patient population that has this unrelenting sleep apnea and that has tongue base obstruction. And they don't get post-op sleep studies, or their post-op sleep studies are like 2 years out, because going through a sleep study after a surgery in a kid with Down syndrome is really challenging. And then the preoperative sleep study is sometimes, a year and a half before. So what changed in that time frame? So that's where some of this data can be really challenging as you're trying to read these studies, is when you look at their patient populations, you don't really fully know if something changed on that sleep study. The short story is that lingual tonsillectomy helps the nadir oxygen saturation the most, interestingly, and the obstructive index is helped a little bit, but it's nothing on par with hypoglossal nerve stimulation. So, all right. So I think we'll move on to the nose. Everybody loves the nose. All right, so the next session we thought we'd put on is looking at nasal obstruction. Kids with stuffy and crooked noses. I don't have any relevant financial disclosures. So first I'm going to talk about the importance of nasal obstruction, talk about evaluation, treatment, and then some of the risks of surgery. And then we'll get into some cases with our panel. So why talk about stuffy noses? Well, pediatric nasal obstruction can be really challenging. The nasal airway, the impact of the nasal airway changes with age, and the diagnoses that can drive nasal obstruction changes with age, and that is largely driven by the respiratory rate, right? So when infants are born, the respiratory is really high. To breathe at that rate and eat, you have to breathe through your nose. That's why babies are obligate nose breathers. And so when they have nasal obstruction in this time frame, it's usually different disorders than when they're older, and it impacts them differently. And so personally, I love the nose, and so that's why we needed to talk about it, and it can be challenging, and there's some interesting things that can happen. The other piece of this is there's a lot of controversy with the septum. As kids get older, septal deviation becomes more problematic and more noticed. And the concerns over facial and nasal growth are something that we should definitely think about as you're getting patients coming into with nasal obstruction. You're noticing septal deviation as you're trying to figure out how to manage it. I think it's something that's really important. So the evaluation, I think, is slightly different in younger kids versus older kids, and that's because of their respiratory rate and the fact that littler kids are, and babies specifically, need to breathe through their nose more. And in younger kids, you really want to pay attention to the respiratory rate and the retractions as you're trying to figure out how much their nasal obstruction is contributing to troubles. And that gets into work of breathing. So as you're evaluating the work of breathing, you want to take those things into consideration. And then in little kids, feeding is very important. And so as you're having littler kids, they're coordinating their breathing, they're swallowing. So especially in little babies, you want to assess how long their feedings are taking as you're trying to figure out how much nasal obstruction is contributing to that. And sometimes it can be multifactorial in their feeding issues, but you really want to try to understand how much that is impacting. Whereas in older kids that might be coming in with stuffy nose, they have a little bit of septal deviation, their turbinates are big, you want to try to understand things in a slightly different way. So you're trying to figure out if there's some trauma that was associated with it. Oftentimes the parents will tell you that, oh, dad has a septum that's deviated, or dad also needed his nose surgery. It's really interesting how often that comes up. And then you also want to assess past treatments. A lot of these kids will have had a variety of treatments over the years, and you really want to hone in on what those treatments are. Sometimes they'll say they tried nasal spray, and you ask them how long. Oh, I used it twice, two sprays that one day. And so you really want to understand what they used, how long they used it, how often they used it. Oh, I used it for 3 months. How often do you spray? Once a week. So you often have to get into some of those details to really figure out whether they responded to maximal medical therapy. Part of that probably, your attention to that detail, probably like we were discussing before, is impacted by how much you think you're going to be able to improve that patient's airway with surgery. So if you feel like you're less likely because they're really narrow, then you really want to make sure they try that longer. If you're feeling like your surgical treatment is potentially going to have less impact. And so as you're doing your nasal evaluation, you want to be sure to understand all aspects of anterior endoscopy. As you're looking at the internal nasal valve or just the nasal valve, because unless we're otters, we don't really have an external nasal valve. I'm not able to close mine personally. Maybe others are. So the nasal valve is delimited by the upper lateral cartilage, septum, and the head of the inferior turbinate. So you want to pay special attention to those aspects. And this is one of the things that's fun about kids is your evaluation of a 4-year-old is very different than a teenager too, right? Like you're not going to have a 4-year-old try to do some big respirations and look at lateral, upper lateral collapse and things like that. But that's important in older kids. And then the next thing that you need to try to decide on is this a patient that you want to decongest their turbinates and then assess again? And part of that is somewhat subjective, and there's a lot of variety of thoughts on that. And so maybe, even though we're not in a paddle, do you guys tend to decongest most of the kids, or just if their symptoms are more severe than it seems like their anterior rhinoscopy would predict?
I decongest every kid. I think it's, especially the older kids, I'll make even more of an effort because I think I can get a more accurate assessment of the septal
component.
Yeah.
Yeah, I agree 100%. I decongest every kid pre and post because you can also get a sense of what the contribution was of the turbinate to the obstruction as well.
Definitely.
To the septum, absolutely.
And then no kid nasal exam would be complete without the thumb push. So really assessing that septal deviation just by looking in there can be really helpful. It's really, I think, interesting how often no one has ever seen profound septal deviation in kids. They have a stuffy nose. We don't know why, and the septum is like literally touching the nasal sidewall. I think we should take some more time in training the pediatricians on how to look in the nose. I try to whenever they rotate with me. And then the other thing that I think is really important in kids is looking at arch collapse. So this young man has, I would say, very profound arch collapse with about as narrow and a high arch palate as possible. He is so narrow that he hasn't even erupted his lateral incisors. He goes from central incisor to canine that's almost behind his central. So he's like super crazy narrow, and he's kind of on the extreme. But I think assessing arch collapse is very important. And then nasal endoscopy, I think, can be really useful. Kind of like decongestant alone, but you, depending on your thoughts on the etiology, if the symptoms aren't explained by your anterior exam, then nasal endoscopy can be really helpful. So definitely a good adjuvant. So the first treatment that we often think of is the least invasive, and that's inferior turbinate reduction. And as you're thinking about who might benefit from inferior turbinate reduction, I think patient selection based on the age is important. So kids that are personally under like 5 can be really challenging to get good inferior turbinate reduction just because they're so small. I found that in these littler kids, probably the co-blader is the best option with this wand, just because it's the thing that can get it done with the least chance of scarring, but probably a bit less improvement. So as kids get older, some other treatments come in, and so the different ways of doing inferior turbinate reduction. But again, you want to assess that nasal caliber with the upper arch. So I always tell the parents, the floor of the nose is the roof of the mouth. And so what the arch looks like really helps you to understand how narrow their maxilla is. And that can help you to understand how much benefit you're going to get with more straightforward procedures. And so this is not as bad as that other kid, but this is a very narrow high arch palate, so there's not as much room in there. And so a co-blader type of turbinate procedure in that type of kid is probably not going to work as well, at least in my experience. And then you might get some kids like this where you'll notice they have a central mega incisor, and those kids are especially interesting. So this one had a history of piriform aperture stenosis and ended up having holoprose encephaly spectrum, very, very narrow nasal passage. So you want to keep an eye out for those types of hints. With piriform aperture stenosis, this is a CT scan. You can see how narrow the maxilla is, even though they previously in infancy had drill out of their piriform aperture. So their whole maxilla is narrow, and their nasal airway is narrow. So you want to keep an eye out for those types of things. So how plump those turbinates are is important. Depending on how plumpy they are, how narrow they are, how much their septum is deviated anteriorly, that's my decision in decongesting. I don't decongest everyone personally, just because then you decongest, you have to leave and then come back, and I'm too impatient to do that. Just makes getting through as many patients really challenging in clinic. But there's definitely times where that's needed. So the other thing that you want to keep in mind is the boundaries of your nasal valve, right? So we're trying to understand how much the septum is playing in our evaluation, how much the turbinate is playing in. And so if the turbinate is really plump like this and it seems like it's mostly soft tissue, that's going to be a different situation than if it's really narrow and the turbinate is smaller and it's a narrow nasal airway. And when you address this turbinate, you're going to want to maybe shrink down some of the bone underlying here, especially in the nasal valve. And that can really help with this, because we all know that the nasal valve is the narrowest place in the nasal airway. And so, let's see, this is advancing. And so if you decongest and you improve your nasal airway to that, then that can be helpful. If it doesn't shrink down as much, then you might want to make sure that whatever you're doing will address the head of the inferior turbinate. Sometimes making sure that you say if you use a microdebrider, and you want to make sure that you improve this area maximally. So just probably because the kids that I get are often really narrow, and especially younger kids, I've found this technique better in kids that are older than 6. So I make, the incision didn't show up, sorry. So I make the incision at the head of the inferior turbinate, and then I carry it down along the inferior border of the turbinate. The incision here allows me to access the bony head, so that if it's very bony there, I can outfracture that off of the piriform aperture to really reduce that area. Or if it's more soft tissue, I can have the microdebrider in there to shrink down that portion. And then as I'm going back, this is the way that I do it, where I make that incision along the inferior border, and then kids especially, I think more in littler kids and adolescents and adults, the bone is often very enlarged, and so lopping off this bone is both fun and helpful. So you resect this lateral portion, and then you curl this medial turbinate mucosa over the stump. So who's doing turbinate reduction in kids? There was a survey of 249 pediatric otolaryngologists, and seems like from that survey, the primary indication was nasal obstruction. Some were doing it for sleep-disturbed breathing. And 71% were satisfied or very satisfied. Failure of the procedure, epistaxis, crusting were common complications. Crusting, I think, more in littler kids than in older kids. It's harder for them to do saline afterwards. You'll often, in kids, need to bring them back and suction out their boogers and help to guide their saline use. Major complications were rare. The next thing that you want to think about in these stuffy kids is working on addressing the septum. And when we're talking about the septum in kids, it's always a balance of benefits and risks. And it's an interplay between the degree of obstruction, the degree of symptoms, and sometimes that's day symptoms and sometimes it's night symptoms, and age. And your threshold for intervention is probably higher in littler kids than in older kids because of the balance of those risks. And that's because controversy persists with the adverse effects on facial and nasal growth from septoplasty. And so there is some data out there. I'm a surgeon scientist, so of course I'm biased to looking at data, and a talk by me wouldn't be complete if I didn't put in some data. So on this series of kids with unilateral cleft with a secondary rhinoplasty, they had follow-up to 18 years, and the nasal growth on the side, on the cleft side, was unaffected by early primary nasal surgery. So in kids with a cleft lip and palate, or a cleft lip that have nasal obstruction, their degree of obstruction can be more severe, and so sometimes you're doing these procedures when they're to help with the shape of their nose as well as their nasal obstruction when they're in first grade. It's done a bit different at that age group. But that's that patient population. This study looked at 28 kids with a septorhinoplasty and a mean follow-up of 12 years and showed no impairment in nasal growth. And then this one followed 24 kids after open rhinoplasty, 3.5 years, no alteration in nasal growth. So there is some evidence of safety in those. The technique that each of those utilized was perichondrium left intact, minimizing cartilage resection, especially in younger kids, and then reconstituting the contact between the vomer, ethmoid, and the quadrangular cartilage. So the amount of septum to resect is probably age dependent. In older kids that have more adult-like nasal form, your amount of L strut is probably similar to what you would do in an adult. I will say that kids that come in with nasal obstruction and these symptoms are more likely to have a variant of nasomaxillary dysplasia where the quadrangular cartilage can be deficient up here. So you really want to, in this patient population, look at your tip support if you're going down this road, and counsel them preoperatively. Sometimes you have to support the tip more with caudal struts and such. In littler kids, I would be really hesitant to go in and primarily resect the same way that you would in an older patient. And sometimes minimizing resection is helped by just understanding that the length of the quadrangular cartilage is too long for their nasal airway. And so often if you just resect a millimeter or two, it can sit on their crest better, and especially in younger kids, it hasn't been deviated for as many years, And so you'd be surprised at a septum that looks pretty straight just with the resecting some of that spur bone and trimming the bottom. Addressing the upper lateral cartilage is very important, and you need to try to understand how much that is playing in to their nasal valve collapse. And that can be really challenging to understand in kids that have really severe caudal septal deviation. Sometimes their tip support and how strong their cartilage seems in clinic can be a helpful cue. And so, like with non-pediatric patients, spreader grafts can be very important, and also for those kids with a variant of nasomaxillary dysplasia, supporting their the lower portion of the quadrangular cartilage to support their tip can also be very helpful, so they don't end up with too much super tip break. Varying techniques for securing the spreader grafts as you're placing them, using a needle of some variety to hold it together can be really helpful, especially in kids, but it can also be really challenging to get that much real estate in littler kids. Caudal strut grafts can be very helpful and can sometimes be, I don't think I've ever put one in that's quite this big, but it can be really helpful to try to support kids that are littler, that are having more severe obstruction and from their caudal septum, and you don't want to resect as much cartilage. As mentioned, special considerations for cleft nasal deformity is always important. Their nasal obstruction can be very severe, and their nasal deformity that can lead to psychosocial difficulties can be very profound, and the combination of those two is usually what leads you to intervening earlier. You're always going to have the timing trade-offs with younger versus older, but it can really help these kids out when you can take down their hump and improve their nasal airway. Some of these kids can have also have a lot of lip scar issues, and there can be differences in alar width that you need to address as well. So before we move on to our panel, just a quick question. Anybody in the, yeah, if you have questions, and then I'll ask some. Great question. Those studies didn't really show a lot of midfacial growth issues in those patients. I think that as we're looking at patients, though, we need to understand the ones that have severe nasal obstruction that tend to have nasomaxillary dysplasia, because it can be that those patients that have nasal obstruction that have a deficient quadrangular cartilage right above their tip, they're more symptomatic from a nasal obstruction standpoint, and sometimes they'll have end-on occlusion, so they have facial growth issues related to a mild variant of Binder syndrome, say, that nobody's noticed. And so you want to really pay attention to those things, and if you can point out some of those things to families that no one's really caught, it can be really helpful in their understanding of what's going on. So who in the audience does septoplasty or rhinoplasty in kids? Anybody? Steer clear? Yeah. Sometimes, as infrequently as possible. Do you have sutures that people like to use for the rhinoplasty portion? Just to make this interactive, and so I can have a drink of my coffee? No? Nice. How about you guys? Do you like to, do you do septoplasty and rhinoplasty in kids much?
Like non-teenagers? No.
Non-teenagers, no.
So I have, not rhinoplasty, I do open rhinoplasties, but septoplasties, and they're really pretty severe. Like my threshold is a little bit higher in the child than it would be in an adult to go in. But absolutely, I mean, if the kids can't breathe and there's clearly significant septal deviation, I do a much more judicious or as small of a resection as I possibly can in order to fix the problem. I don't feel like in adults I'm that worried. I use PDS, incidentally.
PDS, that's what I like to use too. And then do you guys like to use Doyle splints for kids? Me too. And I always trim them down for the littler nuggets.
The other benefit about the Doyle splint is when they come in, you take out the Doyle splints, they love you. They feel so great. So
That's the main benefit.
Right. I love
Is the immediate post.
You're the best doctor ever. I can breathe so
airway.
well. That's great.
See, this is the airway that I created. Everything else is on you. That's the real benefit. All right, so we're going to move on to some cases, the cases of the stuffy nose. So again, try to make these interactive. So as we're going along, if a question comes to mind on how you might evaluate a patient, or just a question for us on how we might evaluate, feel free to let us know. Our first case is a 10-month-old with 22Q. They come into your clinic with inability to take oral feeds. It takes them 2 hours to take a bottle, and they've been noted to have snoring and mouth breathing. And so would you, in that type of patient, how would you approach? Would you flex scope in clinic in that kid? Any other adjunctive information that you'd want to get? Other studies?
So obviously first you need a full exam on these kids, because I'm sure there's more than just simply the septum that's the part of the problem. Absolutely, I do a flex scope in clinic, and if they did have coronal atresia or stenosis, I'd want a CT scan before I'd intervene surgically.
Definitely.
Also, this would be a good case to a patient to decongest as well, to see how much mucosal swelling there may be, to kind of plan how minimal I can be with my intervention.
And the other thing is, when you get these kids in clinic with unilateral choanal atresia, it's amazing how thick that mucus is. You got to go get these flexible suctions and put sealant to get it out so you can actually see what's going on, and decongestion is really helpful. So your flex scope is concerning for left-sided choanal atresia, maybe with some septal deviation to the right. And the presentation for unilateral choanal atresia, it seems like it's more likely in older kids with unilateral drainage, as shown here.
Okay, that is a great photo, John. That is a
good one.
all-time great photo.
It seems like it's less nasal obstruction. So when you're dealing with littler kids with unilateral choanal atresia with obstruction symptoms, how would you further assess that? Obviously, you already mentioned scope, so I have to show you the scope exam. So here's the choana on the obstructed side. Here's the choana on the non-obstructive side. Would you go in? The kid's not eating well, taking a long time to feed, has 22Q. They're not really coughing and choking. Would you go in and open that up right away? Would you push them off? What would you do?
Well, if they're having difficulties feeding and with some growth concerns, then I think you have to do something. The question is what you would do.
So would you put them on some Flonase to try to open up the contralateral side? Would you do modified barium swallow maybe, see if that's contributing? It's a 22Q kid. I don't know that you would necessarily do that always, but in a kid at risk for aspiration, maybe that's contributing. Scan right away.
I mean, so he's 10 months old.
Yeah.
So if he's at failure to thrive, I think there'd be some information with regard to that if he's really taking 2 hours to feed every time he feeds for his entire life. So that would be interesting. Secondarily, I think you'd want to also look at other sites of problems, right? So these kids who can't eat, Yeah, most the kids who have a unilateral corneal atresia alone, I mean, they do fine until they get to a little older, to the age of that little snotty kid you had there that I
Yeah.
loved. So there's maybe something else going on
Yeah.
at other levels of breathing and eating. So you need to do obviously a scope in the office to look at that pre and post decongestion. And as far as like I said, for the corneal atresia kids, I like to have a CT scan because it helps identify what I'll be doing either more acutely or more distantly. Certainly a swallow study is reasonable too if they're having aspiration issues.
So in littler kids with unilateral that are having this degree of symptoms, similarly, I didn't want to like just go book them for repair. So I treated them with some topical steroids, and then because I wanted to understand the degree of obstruction, because I was hoping that would help to guide me, I also got a sleep study. And with the topical treatments, when they came back, their feeding is now 30 to 60 minutes, so that's better. Still not normal, but better. Their kind of weight gain has stabilized a bit. Their OHI was 13, and the central apnea index is 17. How would you interpret that data? Oh, and you also wanted a scan. So here's a scan.
Let me ask one question, John. When you said nasal treatments, what exactly for this
Great
age of
question.
child
So in
do you
babies,
do?
I do, in kids that are babies, I usually do Ciprodex drops for 3 weeks. And then in a kid like this, I would probably then switch to Flonase. I feel like Flonase takes a long time to work in little babies that are having more severe nasal obstruction, so that's my typical. If there's a lot of goopiness, in older kids, I'll also intermittently use mupirocin ointment to help with the kind of gunkiness.
So when you say Ciprodex drops, just to be specific, or
Eye
nasal,
or ear drops.
how many drops?
I do
and
2
how many
drops twice a day for 2 to 3 weeks.
And then as far as nasal sprays, do you do the 2 sprays daily, or do you do 1 in a
I
child?
usually
with
do
tonsil?
1 in kids.
Okay.
Usually 1 once a day. And then I say we're going to do this for, if they, like for this type of kid, it'll depend on how much improvement they got. So if they did the Ciprodex for 2 to 3 weeks, and then after they stopped, the symptoms didn't come back, I wouldn't do Flonase. But if there's rebound symptoms, then I would do Flonase and try it for, a month or 2 and then stop. So here's the imaging. So you can see choanal atresia. They also, of course, said that there's maybe a mass here. So I feel like every little kid that has nasal obstruction and unilateral has had this mass because the septal deviation makes them think there's something there, and then every single one has then needed an MRI to make sure it's not a mass. So maybe I need to suction them immediately before so they can see that it's not a mass. But oh yeah, go ahead. So Ciprodex is in 1 bottle, so I give it that, but if the insurance doesn't cover it, then I'll do dexamethasone. There's usually in kids there's a low-grade bacterial infection, and so if you use dexamethasone only, it doesn't address that. In my completely biased, unscientific experience. All right, so based on the continued feeding problems and the obstruction on the sleep study, plus choanal atresia is so fun to repair. I went in and repaired it. Warning the parents, okay, there's obstruction, but there's central too, right? The central index is even a little higher than the obstructive, and we're not sure where things are going to land. And so I warn them if there's central components still, then we'll have to deal with those. But at least the main goal was to get this kid feeding and gaining weight. In some of these kids too, you can tell how narrow the nasal airway is by how tight the endoscope fits in. And so If you're using a small endoscope, flexible endoscope, and it's really tight in there, I think that's a good indicator that they're going to have a lot of trouble, and if you can open their nasal airway up, you can help them. So, you know, of course, the flap looks like this. It's beautiful to make. It elevates perfectly. It's nice thin tissue, I wish. Often I will do a posterior septectomy to kind of broaden the circle. So instead of a circle, it's more of an ellipse, so it doesn't scar as much. Any thoughts on how you guys do choanal atresia? Similarly?
Similar, yeah.
Drill out as much, the other part is drilling out as much as you can laterally until you get into the venous plexus, the pterygoid venous plexus.
Yeah, so I've given up on the drill out for my atresia repairs because I get in the plexus and then it feels like it scars right back in. But the posterior septectomy in such a way so that you don't have a circumferential scarring is what I found to be incredibly usable. And so it doesn't look normal, but it really works really well.
Functions well.
Yeah.
Definitely. And then when you're done, that flap, look how pretty it looks. It looks beautiful. That's why in papers you'll see drawings of what the flaps look like, but it turns into hamburger back there, personally. And then I think the scarring is important, especially for little kids. So I try to hold off on doing this especially unilateral choanal atresia, until later, because that scarring is a lot harder in littler kids than in older kids. And I've found that in littler kids, I'm often going back because I want to get it to heal, and I'll do balloon dilations to keep it open. Personally, do you guys find that you do that with your choanal atresia repairs? Or you probably, your flap probably looks better than my picture, so you don't have that problem.
Yeah, mine are perfect, no revisions ever. Do you give these patients steroid drops after? For how long? Great
question. Because I only have one way of doing it, I do Ciprodex drops again for 2 to 3 weeks. And then often that's enough. Sometimes I'll scope them about 3 weeks after in clinic if they're old enough to allow me, not so strong that I can like hold them down to look, to see how much swelling there is, and then sometimes do some steroids longer. Some people have used drug-eluting stents. Have you guys used any of those drug-eluting stents?
I have not, but I do tell parents in these cases that we're going back to the operating room a couple of times just from the get-go.
Yeah.
I feel like going back into breeding in the operating room can help prevent the scarring, and so I will, tell them we'll go at, date, operate now, and then 2 weeks later, we're going back to the operating room, and 2 weeks later, we're going back. I tell them we're going back every 2 weeks until we're healed, even though we don't necessarily have to go back a bunch of times.
Yeah.
Just because I feel like that debridement is critical to try to prevent that, circumferential stenosis that comes in.
Definitely. Excellent approach. So feeding improved post-op. Actually, by the evening when I saw this kid, the kid was already eating in about 20 minutes. The mom was very, very happy with how the feeding was going. But that's not everything. So then we, of course, had to get a sleep study. And so the obstructive component almost went away to 1.3. I'm going to call that normal because the chat study said 1.5 was abnormal, so that's normal.
It's normal for sure.
And I will say though, so the normative data on pediatric sleep studies were based off a different scoring algorithm. So things that are called hypopneas now weren't called hypopneas when they came up with the current scale, grading scale that we use. And so there are some active studies that are trying to understand what pediatric obstructive sleep apnea looks like in normal kids, but they weren't grading it the same way. And so that's why in studies you'll see some people use 1, 1.5, 2. It's hard to know what normal is for some of these hypopneas that just weren't measured before. And the other thing I'll mention is the central index. So if the central index was flipped and it was obstructive 17 and central less than obstructive, and these numbers were even a little bit bigger, like, it was like 20 and 15, something like that, I've found that more severe obstructive can lead to central, and so it's that mixed apnea, but it's very uncommon, I found, to have where the more predominant thing is central apneas be driven down so much. I was kind of surprised that that went down as much as it did.
That was my question.
Yeah. And so technically 8.6 is normal. So to have abnormal central apneas is normal is 10, and that's because of that normative data. So you can have 10 central events, but you can only have one obstructive event, which is interesting, I think. All right, next case. 6-year-old presents to you 4 weeks after nasal trauma. They were seen in an outside ER and said, hey, go see ENT after the swelling goes down. And then 4 weeks later, they're in your office, which is unfortunate, but not too uncommon a situation to be in. And so they present, they have mild deformity, mild nasal deformity and some mild to moderate congestion. Physical exam shows that the dorsum is firm and somewhat deviated. You can see a bit of old ecchymosis. The septum is moderately deviated. Turbinates are mildly enlarged, because this is what you want to see. This is just a little mild something, you know. So what would you do in that situation? You're 4 weeks out. What are you guys going to do for this 6-year-old cutie? Closed reduction?
Yeah, I would talk to the family about doing a close reduction and then counsel them on the fact that this is pretty far out and likely there will be a residual cosmetic deformity and possibly some nasal obstruction as well. But I suspect, in my experience, most parents would want to give that a try, accepting that risk and potentially avoid a rhinoplasty later on.
Have you had a closed reduction 4 weeks out work? Anybody in the audience? Anybody? 3 weeks. Have you had a 3-week? Yeah, okay, that's good. You're stronger than I am. 3 weeks is tough. 4 weeks, I don't think that I've ever moved. I might try in this type of kid, but kids also, I feel like they firm up faster. And that one's severe enough that I probably, if it was mild, I'd like maybe I can get the ash force up in there and break it up a little. At 3 weeks, sometimes I can get that. I probably wouldn't. So Dr. Liu is going to do a closed reduction, and then a week later they come back and they look subtly different, but still a clinically important enough deviation that the family isn't super happy. They don't love the way it looks, and they want you to make it better. Why didn't the ER send us here sooner? That's another conversation that we have to build systems that try to prevent this, obviously, but it's not uncommon. So would you then go in and do osteotomies in the 6-year-old right away? Maybe you do that at 4 weeks, no?
Yeah. So I've given up on the osteotomies in children prior to my practice. I don't do those often enough to really feel comfortable doing it. So if a kid did come in and had a significant obstruction, where they needed that done, I'd have a colleague who does this often look at it. It's just not something I've done recently, and so
they're hard.
That's what I do.
Literally, the bone is hard, and they're hard.
They might break their nose a few more times.
Yeah, that's true.
Actually, that's an interesting topic of conversation. So when kids do come in, and this is usually more the teenage group who've been hit in the elbow with a basketball, or hit the elbow playing basketball, and they have a reduction that may not be satisfactory after closed reduction, and they're looking for something more permanent. I do explain to parents, look, you could walk down this path. It's a pretty complicated path, and as soon as you finish his nose, the next day he's playing basketball again, he gets hit again, just so you're aware, because sometimes it's reasonable to say, listen, let's wait till that risk is out of the way before we actually do a final, procedure on those children. So I do have that conversation commonly.
The worst is when you have that conversation over and over again, and then you're 3 weeks after the rhinoplasty, and the kid goes, okay, can I go play basketball now? I'm like, yeah. Anyway, so yeah, those are the worst. All right, so if the septum was worse, would you guys do a septorhinoplasty? Would you just do osteotomies in the 6-year-old. Thoughts from the audience? Maybe Dr. Chen in the back? Only if it's really obstructive, yeah. In this age group, I would typically, if they're having severe nasal obstruction, I would probably do turbinates first. Try, if their nasal airway was more severe and their septum wasn't horrible, I'd probably start with turbinates, see if you can get them by, and try to avoid that for the septum part in that age group. So would your thinking change in a 10-year-old versus a 15-year-old? Threshold would change somewhat? Or maybe they, instead of being post-trauma, they're just coming in with nasal obstruction, and maybe the external doesn't look as bad, and it's a 10-year-old.
Yeah, I'd definitely be more inclined in a 15-year-old.
So I have a question for you, John, or Carrie. So the kid who comes in with a, like I said, a baseball to the nose, and you reduce it, how long do you tell them to wait before they can go return to sports, and why? This is a question that comes up all the time, and the kids are obviously athletic and they're very interested in playing in their whatever sport they're in. I'm curious to know what you do.
That's a great question. So I explain it like this. I say there's a risk benefit in all these decisions that we're making. If your child is getting a scholarship based on that sport, that's a huge benefit. So that might be more inclined to take on the risk of going back and doing something like that earlier. If your kid isn't going to get a scholarship, they enjoy playing it, that benefit is less. And so they have to make that judgment call. If they're like 6, 7, 8 years old, there's very little benefit in that those kids are really getting other than the fun of doing it. And so I tell them they got to wait at least 2 to 3 months to do anything like that. But at the same time, in those littler kids, just walking down the street is potentially hazardous to their health with their arms flinging, right? Like they can hardly go walk around the playground without getting whacked. So, but I think the higher risk sports is definitely something to discuss.
I say 6 weeks.
So I tell them they can go back immediately.
Interesting.
It's, but my feeling is that the trauma that causes the broken nose is almost universally high velocity trauma.
Yeah, yeah.
And so there is this in these kids, maybe they're not getting scholarships, but they love whatever sport it is. Yeah. And if you wait 6 weeks and they get high velocity trauma 6 weeks in one day, they're going to break their nose again. Yeah. And so I always wonder, like, what am I doing? Why am I, as I've gotten further on in my career, I think, well, I'm making these kids wait for 8 weeks, but it's not like low velocity. It's always an elbow, or it's a baseball, or it's a softball. It's something that's coming in fast. And I don't know that when you wait that time and look at the bones are nice and firm, and boom, it hits it again, they're still going to break their nose again. So anyway, it's just something that in my practice I found myself being much more liberal with going back to sports because, again, generally the injuries these come they're not low velocity. It's high velocity elbows, high velocity balls, high velocity heads coming up and hitting their nose, or knees on trampolines, or whatever it happens to be.
That's a good point.
So say our patient comes in with nasal obstruction, and we're now thinking that the turbinates are a driver. What's your approach for turbinate reduction in kids? Do you like to do coblator? What's your specific approach for turbinate reduction in kids that septum seems to be more of a small driver?
I favor the coblator, and I think the evidence favors that too. There is a ton more cresting than with the other techniques, but I also think there's lower, I've seen less epistaxis post-op rather than compared to like a sub.
So do you use the wand type of coblator, or do you use the turbinator, which is such a good name, but you can't get that, I can't get that to fit in kids' noses.
The wand.
The wand, you've got that to work?
Yeah.
She's very good. I can't get that thing to cause any significant improvement.
So for me, it's a little bit age-related and size-related. I have had great success with the microdebrider. And kind of what you described there earlier, John, and also long-term results, kids who are years out from that procedure, they still do well. The older they are, the more likely I am to do the microdebrider and just make the incisions and in the operating room, and they bleed like crazy in the OR. The turbinates are so bloody, but when you can remove some of that bone as well as that submucosal tissue, it's been great. If they're younger children and maybe the obstruction isn't quite as bad, I will use the co-ablator, but I love shrinking turbinates. I think it's one of the most satisfactory cases we do. So,
How do you stop the bleeding in the operating room?
I actually just let it bleed while I'm doing it for quite some time, then after soak cotton pledgets once I finish. But and I try to cover it up so people don't see it as much. If maybe I put something in the nose so the staff doesn't notice it, but they bleed like crazy. It's interesting.
Sometimes I stick a bit of Surgicel in that incision, but it doesn't often stay, but seems to help sometimes.
So when you do that method that I described where you resect that bit of mucosa, it does leave a pretty bloody nose, and so I usually will use a suction bovie along that, and that posterior turbinate that's often polypoid and horrible, it's really interesting when you use that suction bovie on that, it really scars it down too. So some of that posterior turbinate that is really bulbous and horrible looking and not sure how anything's going to get back there and treat it, the suction bovie can often shrink that down as well. So that's the way that I do it. And I'm always nervous as I'm doing it that way of, the nasolacrimal duct and such, but try to be careful in that way. Do you guys, so you use Surgicel, have you used anything else like Nasopore or any other products in the nose to help minimize the nosebleed after turbinate reduction?
I find with Nasopore, then I'd have to debride it, especially in a younger kid who's not rinsing very well,
Yeah.
because then it just gets kind of thick and crusty. And
That's why I always have to bring those kids back. Definitely, yeah, no, that definitely is true. And I think one of the challenges is that as we're doing these procedures and we do a bigger turbinate reduction, so we have to cauterize, and then because we cauterize, we're nervous it's going to bleed, so then we put in the Nasopore or Posicept, something like that. That then is sitting there, and littler kids might not rinse it as much, and it can be really challenging to get little kids to put saline in their nose. I remember my kids, they had stuffy noses when they were little, and as they were getting older, the oldest, he was about 2, and I was trying to hold him down and spray his nose, and I was just done. So I was like, here, just spray your nose. So he grabs it, he puts it in, and he sprays. And I was like, what? So sometimes giving them the control too can be helpful. But yeah, getting saline, Flonase, anything in the nose can be really challenging in kids. Any other tricks that you guys have noticed over the years on different nasal treatments in littler kids?
One of the things that I do talk to parents about with regard to either a saline or Flonase, whether Flonase or nasal steroids, is really getting them to try to clean that nose before they put in the steroid. It makes a difference if the actual medicine can get to the mucosa versus just on the mucus. And so I do talk to parents all the time if they're going to make a run with Flonase or a nasal steroid to really saline the nose out, get it suction as much as you can before you apply the actual medicine, the drug to the nose.
Any tricks you've found over the years on getting kids to blow their nose? That's another, they can't blow his nose. We don't know what to do. Any little tricks that you've found? The only thing I found that worked for so the older one would blow. The younger one, he was really into Hulk. So I was like, blow like Hulk, because he'd blow like faint. And then he would that was the finally thing I got him to do it. So sometimes little pearls like that, trying to train families that are having these complicated issues can be helpful. The other thing for those goopy noses, I think intermittent mupirocin can be helpful when the nose is really boogery. Getting that nose to a less crusty boogery place where the medicines can work for the allergic component can also be helpful. Yeah, so I have them use mupirocin on a Q-tip usually. Just a pea-size amount, and I have them put it just inside the nose and then squish it in. And it can be really helpful for those crusty, boogery noses. I also use it a lot for nosebleeds, which we have like way too much of here. It worked well when I was outside of Tucson for nosebleeds. Here it doesn't work quite as well just because it's very dry here. I don't know if you guys noticed that. It's really dry here. And I tell the parents here now, I say, your nose is no saguaro cactus. It's not made for this dry environment. You have to put stuff in it. So. All right. So any, this thing is, any audience questions? We're just about out of time here. Audience questions on any of the kid stuffy nose issues? Thoughts you've had? Advice for all of us dealing with these fun problems in kids? Good. Yeah, definitely. So when babies come in with rhinitis of infancy, when they're under like 10 months or so and their nose is stuffy, it's impacting them, part of that evaluation is trying to make sure you don't have one of those rare things, right? So kids that have piriform aperture stenosis, choanal atresia, a lot of times those kids, when you ask those families, during delivery, they didn't have a long stay, but they needed a little extra oxygen. Their oxygen was a little low, so you want to check out for that. And when you're looking in the front of those kids' noses, it's swollen, it's boogery, and so one of the other things is like, are you going to scope that kid? And when the nose is really swollen, I found it's really hard to identify nasolacrimal duct cyst when it's so swollen. So in those kids, I'll often do Ciprodex to start with. So I do 1 to 2 drops twice a day for 2 to 3 weeks. And it depends on how bad the obstruction is and how much it improves. And I'll tell them, if it's really good at 2 weeks, then you're done. If it's gotten a little bit better, if their symptoms are more severe, I might do it for more like 3 weeks. And then stop. And then you have to tell them to stop because there's some systemic absorption if you do it longer than that. And even though I have this long conversation with them, it's not uncommon when I see them back at a month that they're still using it. So you really need, if you're using these medicines, you need to double check that they've stopped, because sometimes they'll just, aren't I supposed to use that? Saline is also really important. So in little babies, I usually tell them to do the saline every diaper change because it's something that's happening. And then to kind of peel back. And then if they get better and then things get worse, that's when I'll use Flonase in littler kids. And if you end up using Flonase in babies that have rhinitis of infancy, I think that you really need to look for something else in there. And so that's kind of my approach.
And what was your dose for Flonase? One spray once a day?
One spray once a day, and then try to wean it as quickly as possible. So, all right. So with that, thank you.
Well, that was a fantastic kickoff to our meeting. Thanks so much. That was really great content. Just a couple things to add to my announcement this morning. One, I hope everyone has downloaded the Socio, I think it's what's called Socio app. It's real easy to do. I just did it myself. But if you have any issue, you can talk to any of our assistants in the back. But that's how we're going to get feedback and reach out to you if we have any announcements. So please do that. You can connect to the free Rose Conference Wi-Fi and then download the app and sign in. The second thing is we're trying out something new, and you probably just got an email if you checked. We're actually going to be live streaming this. It's just for you folks. It's not going to be public, but we're trying this out maybe for some future iterations of this conference. So please try it out and give us any feedback on what you think. But it's a closed live streaming that we're having of the meeting today, and there'll be another link that we'll use tomorrow, and so we're trying it out, so we appreciate any feedback you have. Otherwise, we'll take a break here. Please visit our exhibitors and take your bingo card with you, and then we'll reconvene at 10 o'clock with the laryngology session. Thanks so much.
and the diagnosis and the treatment. I want to share with you some cases at the end. So I am a paid consultant for Smith & Nephews for their laryngeal carbureted device. So the normal glottal cycle as seen here is an idealized version. You see that there's an open cycle, an open phase, and then there's a nearly closing phase, and then there's a completely closed phase. But in reality, the glottal gap defined by the vocal cords in complete adduction can assume a variety of glottal gaps, ranging again from complete to having an anterior gap, which is more commonly seen in men, and then a radial gap, a spinal gap, a posterior gap, which can be seen in women, an hourglass gap, and an incomplete gap or a slit gap. So, as you can see, it's difficult to tell what is a pathological gap and what is not. The only thing that's pathological is if someone comes in with hoarseness. So I think we all know how to diagnose paralysis. That's pretty straightforward. You can tell that there's shortening of the paralyzed cord. There's anterior displacement of the arytenoid. Sometimes the length difference isn't so dramatic, so all you see is a little bowing, a little shortening. So here is an example of someone with a well-compensated left vocal cord paralysis. You can see that the closure is complete, and the voice is actually pretty good. I'm not sure why the voice didn't play, but okay. Okay, so here's another example of someone with a pretty hoarse voice from her left vocal cord paralysis, and there's a whole lot of compensation going on, but it's not working out that well for her. You can see the false chords coming together. So the clue that she's not yet phonating with the false vocal cords is that even with regular video laryngoscopy, you don't see vibrations of the false chords, but they're certainly touching. So paresis is a whole another category which is pretty controversial because you can have natural asymmetry in the movement of the vocal cords. And if you ask different examiners, they'll have different opinions. And there's natural lagging of one vocal cord in movement as opposed to the other one. So if you see paresis, it can be also inconsistent. It's not a red flag. You don't have to get a CT scan of the neck and chest as you would for someone with an idiopathic vocal cord paralysis. And the findings could be subtle. It could be just some bowing or maybe some loss of tone. So here I want to show an example of someone with a left vocal cord paralysis and a right vocal cord paresis. He does have some voice complaints, but you can see that the airway is very compromised. And when you ask him to take a deep breath, there's adduction of both cords because of Bernoulli's principle. So if this patient asked me to medialize his cord, I would say no way.
Breathe in. Breathe out.
So here's an example of the cords coming together on inhalation. So if you're not sure if someone has full excursion of the vocal cord, you can ask them to do this he-sniff maneuver. So the sniffing will force the cords to AB duct to the full extent. Wait, hold on.
Go ahead and try he. Excellent. Go ahead and make sounds like...
Okay. Okay, so something else to make note of, if you see a vocal fold 6 that looks wide base, that looks fusiform and translucent, it's almost like a unilateral Ranke's edema, then you should probably consider the possibility of paresis too in that vocal fold cyst. The two don't go hand in hand all the time together, but basically, if someone is trying to compensate for a little bit of paresis, you can press so hard that you can get phonotrauma as a result, and you can see a cyst like this. If you simply go in and excise the cyst without augmenting the paretic cord, the cyst might come back. Okay, so here's another example of this podule or paretic vocal fold cyst. And you can see how there's some thinning of the paretic cord. Okay, so here's an example of someone with a right vocal cord paralysis who's having a little bit of a gap in the mid-membranous section. He has some voice complaints. Now he's many years out from the initial injury or the initial onset of the paralysis. Even though the traditional teaching is that you go in and do something permanent for any vocal cord paralysis that's more than a year old, I would say in this case, I would probably still go for an injection augmentation. Now, different people will have different opinions, but I find that most people can tolerate maybe going to the OR once a year for an injection if need be. And surprisingly, even though these injectable materials are not supposed to be permanent, in some patients, they do hold on to it for a lot longer than what the manufacturers have said that it will last. Okay, so now we come to spindle shape glottic gaps. If the patient's hoarse, there could be a couple causes, including presbylarynx, which is common, and we all know how to look for it. It could be sulcus vocalis, which is a groove in the free margin of the vocal cord. The cause of it is not well known, and it's best diagnosed intraoperatively, actually. And then there's vocal cord scars. There's something called pseudo-sulcus vocalis, which I don't want you to get confused with sulcus vocalis. So I see it all the time in the office. So these are your cords, and then this extra swelling here is actually infraglottic edema, so it's not part of the cords. But it sure looks like there are two grooves. So these grooves run from the anterior commissure all the way to the posterior glottis. You don't need to treat this. There's some association with LPR. Some papers said as high as 70% link between LPR and this condition. If the patient has active symptoms of reflux, then I would say, yeah, go ahead, give them PPI. But otherwise, I don't routinely give out PPIs now. Okay, so for vocal cord scars, which are very, very hard to treat, there are all kinds of fancy procedures that you could do, such as incising the scar, filling it with fat, and sewing it back up together. It looks nice in the diagram, but technically I think it's very, very hard to execute, and the results are hard to predict. For me, I would just try injection with a steroid. Now, what kind of steroid? Just dexamethasone, because it's completely clear. So I don't use Kenalog in the vocal cords because of the sediments. There's nothing wrong with using Kenalog necessarily, but it's just that it leaves this white appearance, and you probably, for other examiners, they won't know what to make of it. Okay, so a really, really bad vocal cord scar is a vocal cord defect, either from trauma or cancer or radiation. So this CT scan obviously shows a big chunk of the vocal fold missing. These patients are not just hoarse, as you can imagine, they're having a whole lot of problems swallowing. And there's no way to really fill in the defect unless you swing in a muscle flap of some sort, or you call your free flap surgeon to do it. So in these cases, the patients usually have already switched over to supraglottic phonation, and that means either using the false vocal cords to speak with, or a lot of times you see them using their arytenoids vibrating against the epiglottis. So the speech from that usually is very low pitch, it's unsteady, it gives out easily, but nevertheless, it's still a voice. So you don't want to take that away. If anything, you want to enhance it. So here's a patient who has a large chunk of his left posterior cord missing from intubation, and he's phonating with his false cords. He comes in, he's super breathy. He runs a grooming salon for pets. He's aspirating a lot. He's losing weight. He wants to continue his business. So then, in this case, I just injected the left false cord with Prolan Plus, and he's happier. He comes in, he's like, I'm talking better, and I'm swallowing better. So he was able to get his G-tube out. But the happy times didn't last long. As you know, the Prolan Plus can dissipate within 4 to 5 months, and that's exactly what happened. So he comes in month after month, with his swallowing getting worse, and he's refusing a G-tube, and he's losing more weight. He's already pretty skinny, but now you can see all this food debris intraglottically. So eventually he said yes to a G-tube. And in this case, I don't think any more injection into the false cords will help make up for that really large glottic gap that he's got. Okay, and here's another patient who has had multiple surgeries to his neck. He probably had at least 2 or 3 thyroidectomies, and he had a couple cordotomies. So he's got bilateral, essentially a right vocal cord immobility and left vocal cord paresis. So he's got this permanently open glottic gap, and he's having a hard time swallowing also. So then, I actually used Gore-Tex to neutralize the left false cord, and he's able to swallow better. His voice wasn't a whole lot better. But he hasn't come back to see me in 2 years. He lives in New Mexico. Okay, so next we'll move on to some in-office approaches for injection augmentation. So there are many different approaches described. I actually prefer the per-oral approach. So for injection, the intersection between the vocal process and the superior arcuate line here will be the ideal site for injection. But obviously, I say if you're in the office, if the needle catches the vocal cord, just go for it, as long as it's not too superficial. So you need really, really good topical anesthesia. So the way that I do it is I just use 4% lidocaine. I spray about 4 to 6 cc's over the larynx. You don't need anything fancy. You just need an Abraham cannula, which can be readily purchased. So here's an example of the Abraham cannula getting in, and then I'm squirting about 4 cc's, and the patient will cough and gag like crazy. So they always get a pre-procedure COVID test. Okay, so an additional way to numb the larynx would be doing a superior nerve block. And it's the same block that I do for, I don't use the same injectable liquid for chronic cough, but this is the exact same thing that you can do for chronic cough. So you just palpate the lateral aspect of the hyoid bone, and then you walk your fingers down 4 millimeters, and then nearly 4 millimeters, right around there, and then you just inject with a regular hypodermic needle, and you give maybe 1 cc of 1% lidocaine with epi. Sometimes the anesthesia works so well that the patient's actively aspirating before my eyes, but just know that it's transient. Okay, so I like Prolan Plus. It comes with its own needle, and it comes with a needle that, it comes with its own straight needle. Now, in the OR, you would bend it right on here to facilitate entry into the laryngoscope. In the operating room, I would argue that you bend it closer to, in the clinic, I would bend it closer to the tip to approximate the angle of the Abraham cannula. In the past, I've tried to bend it closer to the 1/3 junction, 1/3 and 2/3 junction to try to approximate the angle of the commercially purchased injector needles. But I find that because I'm just using my fingers to bend, there's always a sharp angle here, and that angle will hit up against the posterior pharynx and just make the patient gag like crazy. But if I make the angle a little bit less, the injection goes a whole lot smoother. So here's an example, a very good example. The many examples of patients gagging too. So usually I inject about 0.2 to 0.3 cc's for larger gaps. And just know that you have to over-inject to compensate for about a 30% volume loss because 30% of the injectable is made up of this carrier material that will be resorbed. Okay, so the cryotherapy approach has been talked about a lot. I don't love it just because when I enter this way, and the needle happens to be in the cord, I can tell by inference that it's in by the indentation that the needle tip makes, but I don't have a direct view of the needle tip. With the per-oral approach, as you saw in the last slide, you can see clearly where it's going. So certainly this is the workhorse approach for a lot of laryngologists, but in my hands, I always find it to be just 1 or 2 millimeters short of reaching the cord. So this other approach I actually like pretty well as a thyroid approach. Now, the diagram here is not correct. You need to double bend the needle, and it could be just a hypodermic needle, 1.5 inch. I actually have gone to use a spinal needle because I think it gives me a little bit more play. So you bend it right at the hub, and then you bend it again here. And it works well because the patient typically doesn't gag, and the angle takes a little bit of getting used to. It doesn't exactly go where you think it's going. And in men with very prominent thyroid notches, I find the approach to work well. So here you can see the bend of the needle, and then I'll do it again since the first pass and it seemed like it leaked out of the cord. So here you see a bulge. The sound's not playing. Oh, so here I asked them to say 1, 2, 3. Okay, so the transcardiologist approach works very well for young women whose thyroid cartilages are not ossified. So I've done that in women probably under the age of 30, but I've also done it in a woman who's in her 70s. So if you see a young woman, you could try it. So some of the things to take note of is if someone has that prior radiation to the larynx and they're coming in for a vocal cord bowing or scarring and you want to augment it, I would say injection augmentation is probably a safer way to go, just because anytime you manipulate a post-radiated larynx, I worry about getting contraradial necrosis, which is very, very difficult to treat. And then the other thing to remember is that calcium hydroxyapatite, CAHA, which has a couple of different commercial names, including Prolarin Plus, Radius, Renew, is actually FDG Avid. So if the radiation oncologist calls you in a panic and said, oh my goodness, the larynx is now lighting up post-treatment, just tell them, I just did a procedure last week, and that's what you're seeing. Okay, so now we'll move on to some of the difficult cases I've encountered. Because of COVID and because of maybe the rise in, respiratory disease, we're seeing a whole lot of mangle larynges and mangle airways. So with prolonged intubation, you can actually get erosion of the posterior glottis. And defects here are hard to diagnose because on adduction, the supraglottis would prolapse over and make it very hard to view any defects here. The typical patient will come in with a history of having been intubated for, any number of days, and then their voice is very breathy. And yet, if you just do a simple laryngoscopy, it'll seem like the membranous cords close fine. So sometimes it's an intraoperative diagnosis. Now this picture, which I pulled off the internet, shows a very dramatic defect on both sides in the posterior glottal tissue. So here are the vocal processes, and you can certainly get erosion of the vocal process as well. If that happens, that means the cricothyroid joint has been destroyed, and usually you'll find that cord to be fixed. But if the cords are mobile, then this diagnosis is a little bit hard to make. Okay, so this is a patient that I've been working on for a while. So he had been with a couple other doctors, and he's had a couple injection augmentations of paralyzed, immobile, let me be more precise, immobile right vocal cord. Wait, hold on. Hey, the sound's not playing, I don't know why. Okay, so I'll play this. Oh, it is, okay, that's fine. Okay, so, here, there's no, so here I had already done a thyroplasty on him, and his cords are not even closing, touching. And I don't know if you can appreciate that there's a defect in the right posterior glottis. If he opens again, right here. Okay, so then I was like, oh, that's pretty embarrassing. I did a thyroplasty and the cords are not touching. So I moved on to, so with a regular thyroplasty, if the cricothyroid joint is mobile, you can actually rotate that joint and then close off the posterior glottal gap that way. But if the CA joint is destroyed, you would not be able to do that. And then you can see on the CT also in this patient that there's a posterior glottal defect, and I've done a thyroplasty on him. Okay, so next, I did some injection of Prolan Plus. I pumped that core full of Prolan Plus, hoping that I could close up at least the membranous cords. So the reason you see all this white deposit is because I don't think the implant had taken up room, so then the Prolan Plus became more superficial. That's Dr. Black speaking. We've been managing this patient together, kind of. So you can still see a big posterior glottic defect here. And don't worry about all this superficial injection for Prolan Plus. In about a year's time, that all just went away on its own. Okay, so he's pretty frustrated. He runs an airplane parts company. He says he has to be on the phone all the time. No one can understand what he's saying. And it's not just a voice. He's also aspirating. So for people with a posterior glottal gap, it actually presents a whole lot of problems with swallowing as well. So you can see he has some food debris in the back.
Good. Okay, now if we put it back to the regular light. and do
Okay.
that again.
So then I did, okay, so people have described these fancy surgeries to try to reduce this posterior glottic gap. So you could do an open procedure where you do a lingual fissure and you cut out a portion of the cricoid, or you can swing a local flap in to fill in the defect. Now, this procedure for sure will require a trach and a laryngeal stent. Given how much complications I've seen with tracheostomies, I am very reluctant to do a trach unless someone is not going to make it, unless they have a trach. So I don't want to do something elective and put a trach in a person. So then I just ended up injecting the interretinoid space with Program Plus again. And that actually worked okay well for him. For the first time in many years, he's speaking better.
Can you swallow? Good, okay.
So there's still a gap, but it's smaller than before.
Okay. Well, you know, this is.
Okay, so now we're moving on to another case that I've been working on for a while. She's my personal project. So I see this all the time now. If someone comes in and the exam doesn't look all that remarkable, now in her, she actually has a left vocal cord paralysis from this horrific car accident when she was 15, and it lacerated her carotid artery and took out her vagus nerve. I don't know how she survived. But anyways, she sustained a left vocal cord paralysis amongst many other injuries. So I had done a ballplasty on her 2 years prior. Now the ballplasty sometimes is evident on laryngoscopy with this little infraglottic bulge, and she still has a little bit of bone here, but it wasn't a big problem for her at work. And I would see her actually in the hospital, and she would tell me, you know, I get all these headaches with speaking, it's hard for me, and yet, you know, she was getting by. But then in the past year, she comes to me, she's like, I can't go on like this anymore. I just can't get through the day. The headaches are horrendous. So when I scoped her, it didn't even seem that bad. So that, how do you decide? Well, usually we give someone the diagnosis of muscle tension dysphonia if the exam is pretty normal and you don't have much else to hang your hat on. Or is it true that you need a little bit more bulking up of that left cord? Okay, so in order to decide, I have this protocol that I go through. So I will spray them with 4% lidocaine. If it's SD or MTD, a lot of times their voice all of a sudden gets a whole lot better. And if that's the case, then I'll decide to go on to just Botox them. If that makes no difference, then I'll go ahead and do a trial injection of saline. So the delivery of lidocaine can be done either with the Abraham cannula, which I've described, or you can just squirt some lidocaine through the working channel of a therapeutic scope. You can do that either with an injector needle, and just don't use the needle portion of it, or you can just use an angiocath. Okay, so anyways, for the saline injection, I've tried different they're all using GI or pulmonary, But for some reason, a lot of them, the plunger does not work once the scope is in the patient. But if you take the injector needle outside of the working channel and you push the plunger, it works. But in any case, the Stairs brand is the only one that works for injection in my hands. Okay, so yeah, so there's kind of my algorithm. So I tried the 4 days of lidocaine on her. She didn't really get better. So then I injected 0.2 cc's of saline in her, and I tell her, call me sometime in the next 2 hours as you're speaking, because the saline will get pushed out. As you see here, the needle went in, there's some blanching. That's how you tell that it's gone in. So she calls me, she leaves me a voicemail, or leaves my nurse a voicemail. She's ecstatic about 20 minutes into this. She's like, I can sing now, I'm so happy, I got my voice back. She even sent me a video, actually. Okay, so then I took her to the OR and injected her with Program Plus. She was pretty happy for the first 2 weeks. Then she comes back and she's like, I am no better. I am worse than before. So, in this video, you can see that she was actually pretty stiff in the left core. And then I'm like, oh, what did I do? I've made her worse. So then there's nothing to do at this point except to wait for the program to dissipate a little bit. In another month, it became more pliable. So then I had a discussion with her. Since she's just not even able to get through the day, she has to have other people talk on the phone for her. She works in a GI lab as a technician, and she has to mask all the time. And she has to pull her mask down in order to even make herself audible. And here you can see the voices all over the place. It's fluctuating like crazy. And the little bulges, that's from my pyrophylloplasty. Okay, so the story goes on, and I then said, why don't we inject Botox in the contralateral mobile cord, in the right cord. And it took another 2 months of a whole lot of hand holding. At first her voice was like Mickey Mouse, or Minnie Mouse, that's how she called it. And then it slowly got better. It slowly got much clearer.
Good. Wow. Oh.
It was still kind of wispy as high pitch. So that's the last I saw her, which was in the beginning of January. So I thought she'll be seeing me soon. All right, so, okay, I have my time marker back there. In conclusion, some of the takeaway points that I want you guys to remember is that glottic gaps can be normal and not pathological. And then be mindful of the airway when you're considering any kind of vocal cord medialization. And the hoarseness at a proportion to exam, maybe muscle tension dysphonia. And then the helpful diagnostic tools include topical lidocaine as well as saline injection. Thank you. Okay, so next we have the illustrious Dr. Lott from Scottsdale here with us today. Dr. Lott is homegrown in Arizona. He went to Northern Arizona University and then went on to WashU for med school, did his training at the Cleveland Clinic, and then came back to his home state to practice. Dr. Lott is an unusual brand of laryngologist. He does all kinds of crazy airway reconstructions, partial laryngectomies, and he runs this top-notch lab in tissue engineering. He'll be talking to us today about his research, which is absolutely fascinating. He also has a program for laryngeal transplants. So all of these things just seem so sci-fi-like, and yet it's happening. He's actually put in some 3D printed partial larynges or I guess the future is in tracheal reconstruction. We're just swimming right now in all this tracheal stenosis and total subcoaxial stenosis. So I'm really looking forward to your talk today, Dr. Lott.
Good morning, everybody. Thank you. I'm not sure I've ever been accused of being illustrious before, so thank you for that. Appreciate it. Let me just get this plugged in.
Does anyone?
Yes, I have way too many things on my desktop. I got to get that. That's on the agenda for maybe tonight in the hotel room, is to try to get that squared away. Okay, everybody, can you hear me well? All right, well, thank you, Dr. Yip, for the invitation to come and speak, and to the rest of the conference organizers. I really appreciate it. And I'm excited to get a chance to speak about some of the work that Dr. Yip was mentioning. I'm a laryngologist at Mayo Clinic up in Phoenix, and I'm also the director for the Center for Regenerative Medicine at the Arizona campus. And so for me, it's been a real joy to try to merge those two passions of mine into my practice. And so I want to show you some of the advancements we've been able to make in our lab and translating these into the clinical practice. So from a disclosure standpoint, I do some consulting work with Cook, but there's nothing relevant in this presentation that I'll be speaking about with Cook. I'd like to start off just with a couple of quotes that I think really define that combination between science, or especially regenerative medicine, and clinical practice. And, you know, we're at a place where we can really use our imaginations and think kind of beyond what our normal practice is like. And, well, maybe can we 3D print a new voice box? Can we 3D print ears and jaws and all these different things? Or, you know, these kind of things that were just imagination or science fiction at one point are actually starting to become real. And it's a really exciting time to be able to look at that. And I think in order to kind of get that imagination going, the other quote from Einstein is just, you know, question everything. And, you know, I found that as I've gotten through my kind of in my practice for a while, I start doing things and I just do them because I do them. And then a resident asks me, well, why are you doing it that way? And I don't really know. It's just because now I just do it that way. And so having these questions asked constantly kind of fosters that imagination and maybe looking at different ways. And so I think the two big questions to ask when we're trying to improve our practices and trying to improve patient care is, number one, what is the problem? You know, what are we trying to address? What isn't working quite as well? What could be done better? And then, why can't we? That's that same question the residents ask. Why can't we do it this way? Why can't we do something else? And so for our lab and for the regenerative medicine component, the problem is, as you guys know, the larynx is really instrumental in so many of our quality of life types of things. And so if you lose the laryngeal function, you lose that ability to breathe, swallow, speak. But really what patients complain about the most is that social isolation that they get. Right? If you can't sit down at dinner with people and you're having to feed through a feeding tube, or you can't express yourself, you can't talk, or you have a stoma, and it's embarrassing to have that, you don't tend to go out. You tend to become very isolated. And so you may be alive, but you're not really living. And that's a lot of the things that I hear from people. So to try to fight that, we put together the laryngotracheal regeneration program as a component. And that, like Dr. Yip says, has really two parts to it. One is the laryngeal transplantation component, and the other is the tissue engineered component, and we're looking at all parts of the larynx. And we're actually doing all parts of the head neck area, but for the purpose of this talk, it's just the larynx part. So larynx, trachea, and vocal fold. All right, so some of these questions. Why can't we transplant the larynx and have normal function? Well, we weren't the ones that answered that. Dr. Strom in the Cleveland Clinic was really the first one that did the first laryngeal transplant. Happened to be my chairman in the Cleveland Clinic when I was there and got me interested in all this. So this is kind of, he's helped mentor me over the years and helped me see some of these possibilities on where things can be. So he did the very first transplantation back in 1998. And a patient that was 40 years old had a clothesline injury to his larynx, had a crush injury there. And I think this video really says it all. Let me play this here for you. So this is the first laryngeal transplant patient.
I don't feel down anymore. I mean, it's one of the greatest things that has ever happened to me.
Although Tim endured 20 years with a robotic voice,
I'm a fighter. That's what I am.
Today, Tim speaks and can even sing with a voice he can call his own.
In the land of the free and the home of the brave.
So that's still fascinating. I've seen that video a million times. It's still fascinating to me that someone with a transplanted larynx, that really the vocal folds don't move in and out incredibly well, can have pitch control, can talk, can function. He went on to a career as a motivational speaker, believe it or not. Had a long stint with the larynx transplant. It was explanted about 16 years later. For whatever reason, he took himself off his medications, and he was starting to get chronic rejection at that point anyway. Since that time, there have been a bunch of others in Colombia that haven't been incredibly well documented, but 2 others that have been documented pretty nicely. One at UC Davis in 2012, and then a few now actually in Poland, but this was the first one. And I like to point this one out because this is the first patient, and if you notice, there's no trach, no stoma. He is breathing on his own without a trach tube. And this was a patient that had severe radiation damage, conjugated necrosis, fistulas, and so they actually transplanted essentially his entire neck. So you can see almost a skin paddle. If I can get this to work. You can kind of see where the flap of the skin paddle is here. So they essentially just transplanted this entire portion of his neck. This was back in 2015, and he's still doing well at this point. So, 6 years into it. The problem is that these were kind of one and dones for the most part. There's one done in Cleveland, one in Davis, one or now a couple in Poland. But here in the States, there really wasn't a place where patients could go and know, hey, here's a trusted place that we can reliably do transplantation. They're researching it. We're trying to further that science. So that's what we did. We established the transplant program on the Phoenix campus and have it approved through UNOS. And so it's a formal VCA, vascular composite allograft transplantation through UNOS. We are up and running, so we are currently recruiting patients. And as of now, we have approval to do 2 transplants per year over the next 5 years, and we look at each one at a time, essentially. So, and see, okay, what are the outcomes, what are the costs, what's the safety? An N of 3 isn't great to make big-time, life-changing decisions for people. So we wanted to do enough surgeries that we can get a good idea, is this really worth the time and investment and the patient sacrifice in the lifelong immunosuppression, or should we be steering somewhere else? Also, that number of 10, if we have it looks like this is a successful thing and something worthwhile doing, that's kind of the magic number for insurance companies to say, okay, we will help cover some of the costs for these transplants. The eligibility of the patients that we're looking for, we kind of 2 different phases. The first phase are trauma patients that, similar to that first transplant patient that had a crush injury. Patients that are essentially going to do a functional laryngectomy for. The vast majority of these are radiation failures. So, anybody that, their larynx is in place but it's not functioning is a great candidate. And then people that are, have laryngeal cancer that are already a transplant patient, so they're already on immunosuppression. We're not adding anything to that. Or low-grade cancers like low-grade carcinomas, things with very, very low risks of metastases. What we eventually would like to do is to get to the point where we can do the transplant in the setting of laryngectomy. And the concern with this is you don't know where the status of the nerves and the vessels and those are, so it's kind of a next level up. But there's enough in our research that shows that we actually should be able to do this for patients, and that's really, I think, where the biggest benefit is going to come from. So we're very excited about that. So if you have any patients, feel free to reach out to me, let me know. I think there's a lot of good that can be done for some of these patients. The other big question is, well, why do we have to do a transplant, and why are we doing a laryngectomy? So why can't we just replace the diseased area of the larynx and restore function? Most cancers don't involve the entire voice box. It involves a certain portion. So why not just remove that portion and be able to reconstruct that in a patient-specific manner? That's where the tissue engineering side of our research comes into play, is to look at that specifically. I'm the guy that gets to stand up and talk to everybody, but by no means is I'm the only person that does this research, and by far not the smartest person on the team anywhere near it. I have a great group of multidisciplinary team, so physicists, biomedical engineers, surgeons, immunologists, biologists, and it's a lot of fun to come together with a big group of people that have different visions and different looks, and come up with a common goal and a common plan to make something come to fruition. So our vision overall, in addition to saving the world one voice box at a time, is to come up with patient-specific tissue replacements that are permanent, completely biointegrated, have native functionality or restore native functionality, and implantable in 3 weeks. Again, if we want to use these for cancer patients, we have to be on their time frame. They can't wait 3 months for us to tissue engineer some new voice box or trachea. We have to get it into their time frame so we can get the cancer out in a responsible time. So the first question then is how about the vocal fold? Can we look specifically at the vocal fold? So some of these really complex patients that Dr. Yip just talked about that have scarred vocal folds, they're gone, or from the cancer, or whatever it may be, can we just replace that diseased portion? And form follows function, so we have to be able to replicate the native form of the vocal fold, the native structures, the best we can. And as you know, there's the epithelial layer, the lamina propria, and within the lamina propria there are 3 different layers: superficial, middle, and deep, and then thyroid muscle deep to that. The voicing, most of sound production comes from that superficial layer of the lamina propria. So lamina propria in general is what is vibrating for the most part, and the superficial layer is the one that vibrates the most. And so we need to be able to have the mechanics similar to those 3 layers so that it vibrates appropriately. The good news is that the lamina propria is made mostly of hyaluronic acid, and the concentrations of cells and elastin and different things will vary slightly over the course of those as those transition points come in. So we can mimic that pretty closely. So what we did just as the first start, and we're kind of early in this part of the research, but as a first start is just take the hyaluronic acid, and you can vary the concentration, and you can see based off concentration, you can get 3 separate layers with that. And these concentrations tend to pretty closely mimic the thickness and, again, the biomechanical properties of the native vocal fold. Then you can add elastin, you can separate, and you can make these more specific based off the layer. In order to say, hey, this is a vocal fold, we have to be able to prove a few different things. So one, can cells live within the structures at about the same concentrations that you would see in a normal vocal fold? And so this is a live dead assay. Things that are green are alive, and things that are red are dead. You can see a couple of them here. So you can see just at varying concentrations, you can see that the cells tend to thrive. The thicker, the more dense the concentration, it's harder for cells to move around, so it's harder for them to replicate. But they don't appear to be dying off. You don't see very many red cells there. Same thing out, even if you were looking out, followed out to a week, you can see that cells are thriving, they're just getting less dense, which again, it actually mimics the vocal fold. The deep layer has very few cells in it, has some more fibrous, and very few dead cells. So this tells us that cells can live within the construct, and they can live on top of the construct and actually form an epithelium. So here you can see a epithelial layer formation, similar to what you would see here on top of the lamina propria. But one thing that we have, this stain, sorry, I keep turning my head, this stain was about 2 weeks into the epithelialization or the culture, and we don't have a basement membrane yet. So that's the one thing that we need to kind of improve on, is to get the cell's ability to replicate. Now, if you were to put this in the body, what we end up seeing is the cells will be there and they'll form this epithelial layer, but over time the body grows its own cells, brings its own stem cells, and forms that basement membrane to the epithelium. So we know cells can grow in it, cells can grow on top of it. How about the mechanics? Can we actually make the mechanics work correctly? And this is the first test, really just looking at the mechanical properties that show us, hey, if you alter, which is kind of a no-brainer, you just have to sometimes prove the obvious through tests, that the higher the concentration, the higher the frequency, or the faster it vibrates, the mechanical properties will change, which is important because if we're trying to grow a vocal fold, you all know, no two vocal folds are going to be the same, and they're all going to vibrate at relatively different frequencies. So, obviously my fundamental frequency is different than Dr. Yip's, different than whatever it may be. And so now we have the ability with this to say, okay, your fundamental frequency is around 140 hertz or 180 hertz. Let's come up with a concentration that closely matches that. Because if you're way off, you're going to have dipophonia, your voice is going to sound worse, and it's almost better if you didn't have that in, that structure in. So we can fine-tune our vocal fold structure. Does it vibrate correctly? So can you get that kind of that medial to lateral mucosal wave motion? And obviously here is a normal vocal fold. Here's a high-speed image of our vocal fold construct, and you can see that medial to lateral displacement. You can see closure here, so it kind of mimics the motion of the native vocal fold. But you can also make Jello do that. But Jello doesn't sound very good. So the other question is, does it actually sound good? So here is the construct here. We're basically blowing air past the vocal fold construct that's over here. And you can hear it vibrate. Maybe can you turn it up at all, please? Maybe not. Let's see if I can turn it up here. There you go. So here's the sound. Super impressive. Just a buzz. So I wish it was like singing opera or something for you. It would be a much better presentation. But listen to this. So I was doing an airway surgery with the jet vent, and the patient was not quite paralyzed, and so they were kind of closing their vocal folds. And we were able to get airflow past them, and you can hear the vocal folds buzzing. So that's the sound of the vocal folds buzzing. And that's all they're designed to do. Vocal folds are just creating a frequency, right? A sound propagation. And it's your pharynx, it's your throat, your pharynx, your sinuses, all that create that characteristic sound that gives that guitar string tone. It's the body of the guitar. The vocal folds are just the strings. So you can hear it's a little different pitch than what we're doing, but I'm also listening outside of the patient. So that sound still has to travel outside of the throat, outside of the mouth, and through that patient, so you hear some of the tone, but it's just a vibration. But importantly, the vibration for this one was at 140 hertz, which is right in the middle of the male range. So it shows us that we can get vibration in the right range. So it vibrates, looks good, it vibrates at the right frequency, but how does the sound really come out? Because that could be a pretty chaotic white noise sound. So you actually have to be able to look at the spectrograms, and so these are sound spectrograms that listens to the sound of the tone of those as that vibrates. And so you can see the harmonics here. You want to see nice, discrete lines that come up. Anything that has a bunch of yellow everywhere, you can see it's a little more noise over here, but you can still see nice harmonics. So that tells me that the sounds that are coming off these are pretty good. And again, you can see the fundamental frequency here is about 150, a little higher here at about 180. So even if you change the concentration, you're getting a decent sound that comes out. So a pretty good step toward reproducing a vocal fold that vibrates and can mimic sound for patients. So again, this is great for scar patients, or if we're trying to do a larger replacement, then we want to have a vocal fold structure within that tissue-mediated construct. So that leads to the next question is, well, why can't we replace half the larynx? If we can replace the vocal fold, can we replace half the larynx and restore function that way? And that's really where the big question comes from. So that's what this vision kind of looks like. As you know, again, most cancers tend to be on one side of the voice box. We do a laryngectomy because it's really hard to fix that hole once we've taken out half the voice box or to get any sort of functional reconstruction. So the process that we've come up with is patient goes through, gets their normal CT scan. I like the attention to detail and the male pattern baldness here. It's pretty good for them to go through that, but pretty representative. We can get that CT scan, remove the surgery, so on the software we can remove exactly what we need to do with the surgery, make a mirror image, and with that mirror image we can either directly 3D print the scaffold, or we can print a mold that we shape a different scaffold to. You can add a secondary scaffold either through electrospinning or some gel or some other construct. And while you're creating that, you can use cellular products. So you can use, this is showing adipose-derived stem cells, or you can use things like exosomes, different protein extractions, different things to help growth factors for it to grow. You get those cells, you expand them, you drive them towards epithelium, put them in a bioreactor that mimics the body. And that process will take about 3 weeks, which kind of fits within our time frame. It's not completely epithelialized, but it's driven towards that epithelium, and it's seeded to go towards an epithelial lineage, which is what we want. So you start it off in a bioreactor, and you put it in the best bioreactor, which is the human body. Right? So it's, again, it's in the right location, the right form, everything, to be able to get these constructs to come together. So that process, we can get it down to 3 weeks. And that's what this looks like in reality. We've done now 6 larynx implants and 7 for the trachea. And so this was the very first patient, well actually this scan isn't, but I'll show you one in a second. But here's that process. So here's a patient that had a large cancer on the left half of the larynx. You can take that, and you can do 2 things with that. We actually can do much more. We're starting to bring in virtual reality and be able to take a look at these images in virtual reality, create a mold with this. And so you start talking about cutting half of a person's larynx out, and you talk about the surgery and reconstruction, and you look at the patient and it's just a blank face. You know, most people can't pronounce larynx correctly, let alone kind of grasp what you're trying to talk about. Well, if you can hand them a 3-dimensional model of their specific larynx, and you can show them, hey, here's your tumor, here's what we're looking at, and I can draw on it and say, hey, this is what we're going to remove, this is why it's important that we get a new vocal fold structure in there. It takes something very abstract for them and makes it very real, and they get buy-in. And if you're trying to do things that are relatively new and you don't necessarily know how things are going to work out, the patient has to understand that process, and so they have buy-in to say, okay, I'm on board for the journey with this. So it really helps to have that model. You take that same information, just like I showed on the image, on the video, and you can create the scaffold. Now the scaffolding is thin so that we can get vessel ingrowth, but it's rigid so it maintains its shape. And like I said, you can either directly 3D print it, or you can create a mold that shapes a flat surface to it. And the other thing you can do is you can make a 3D rendering of that. So this is a patient, our first patient here, they had a chondrosarcoma. And we had to decide, is that chondrosarcoma far enough away from the contralateral arytenoid that we can make this work? Because our implant just has a rigid structure like a medialized vocal fold. It can't open and close, so if the contralateral side can't either, you can't do the surgery. So we had to make sure we can get a close enough margin around that tumor to be able to preserve this arytenoid, and we thought we could. We thought that there was enough room to be able to do that. You can actually even remove the tumor and see what the current cartilaginous defect looks like. So you can say, hey, there's a decent margin here that we can remove this. And then we just create that scaffolding to be able to come around and form the new posterior portion of that cricoid. And this is what the model will look like. You can see here we drew on it, and we wanted to remove the top half, leave the bottom half of the cricoid cartilage, remove the entire left thyroid cartilage in the chondrosarcoma, and it's exactly what we ended up doing. So remember, here's the bottom or top half of the cricoid cartilage, left thyroid cartilage in the tumor itself. So pretty accurate, and it helps us really to get a good look, good concept of what we're doing. And then just in showing pictures of kind of what this looks like in reality. Here's the rendering of the implant. Here's the implant printed. This is made out of polyethylene, so it's a polyethylene background to it. And we didn't do this part for the patients, but what we're doing now is we're electrospinning PCL on top of it. What we found is that polyethylene is great, it's nice and rigid, and it maintains its shape, but cells have a harder time growing on that surface, so we need to add something that's more cellular friendly. And so we kind of electrospin. Electrospin is like making cotton candy, essentially. But you can control the fiber orientation of the cotton candy. And you can see here is the polyethylene size compared to the PCL size. So it's a much more friendly environment. You can still get vascular ingrowth through these pores, but cells can adhere better in these strands. And so just to give you a couple pictures of one of each, the trachea implant and one of our laryngeal implants. This is the first time that these types of things have been done for inpatients. And so this was this patient is a trachea patient, and she had a heart transplant and a bunch of complications with the heart transplant, and actually had kidney failure and now needs a kidney transplant. And she had a bunch of areas that just kind of died. She has leg defects on her leg, had a trach tube, and the cartilage around the trach tube just died also. Everything just kind of was collapsing in. So for almost a year, I tried everything I could possibly think of to do to get the trach tube out and not have to do anything. She wasn't really a great option. She had so much scar tissue in her neck, not a great option for a true resection. So I was kind of at a loss of what else to be able to do. So we end up creating this patient-specific. So this is the exact size of the trachea. You can see the polyethylene, you can see the pores in it. It's measured here at 5.5. It actually went into, it was about 4.5 centimeters in length. And so here you can see the implant. So essentially what I did is you can see all the scar. This is just dense scar around the trachea. There's no way to do a resection in this. This is where her trach tube essentially was. This is the trach tube was right here in the middle of this. Is remove all the cartilage from the inside out, basically. So you're working within the defect, and left just a strand of the posterior mucosa. So you have something to suture to. And you take this big C-shaped structure, and you can implant that into it. And then this is what she looked like before and after. So I'm just going to see her next week. This will be her 4th month. So she's our most recent. This is her preoperative exam. This is measured out to be about 3 millimeters or so just really small. And I just could not get that to stay open. Here she is at 3 months. A little bit of granulation tissue here that I'm hoping when I see her next week will be gone. But everything in this picture is all the implant. You can, I wish you could see it better, but you can see the normal tracheal rings down here. But she's 4 months out, trach tube's out, she's swallowing fine, her airway's wide open. For some of the people I've done with these longer segments, the only complaint I've had, they've all epithelialized, none of them have had infections, even with her being on immunosuppression. She had 2 weeks of perioperative antibiotics and no infections. The only complaint I've had is because it's rigid, they bend over to tie their shoes, they can't breathe. So we got to work on the motion a little bit of that. So you got to bring their feet up to them to tie the shoe, or just hold your breath. From the larynx side, so similar kind of thing. There's a hemilaryngectomy defect. This is the patient I showed you with the chondrosarcoma. So here is the hemilarynx defect. Here's the picture I showed you before, just of what we removed. And here is the implant in place. And so with this, because we don't have the stem cell component through the FDA yet, we line the internal portion of this with a muscle flap that shrinks down over time. It kind of wraps around the implant. And then we put on the back side here the strap musculature for blood flow. So it's basically sandwiched between 2 muscle layers. And here's what she looks like. She's about 4 years out now. She was our first one. And the left side, so this is the side that we implanted. And you really can't tell much of a difference other than this defect that we actually purposely left here to try to keep her airway more open. She's developing a vocal fold structure here. The other interesting thing is the false vocal fold on the left side. That's not part of the implant. There's no vocal fold structure on there. So again, going back to what I first said, form and function, how impressive that is. In 4 years, she's developed a new false vocal fold structure. She's functioning well. Her trach tube's out. She's not swallowing. So here's laryngectomy, typical laryngectomy voice. And here's where she was at 3 months.
When sunlight strikes raindrops in the air, they act like a prism and form a rainbow.
And she is at about 3 years.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow.
So pretty normal voice for the most part. She's been able to maintain that over time. The feeding tube was out in the first month. She's very anxious. She had a really hard time getting the trach tube out, and so it took her quite over a year to get the trach tube out. The people I've done since then, the rest of the 5 actually all had trach tubes out in the first 3 months. So exciting. I think it's a great proof of concept. We really want to further advance this so we don't need these muscle flaps. You take those few hours out of the surgery, you don't have the increased morbidity, and we can just do this by putting in the implant with the cells, and it should regenerate much more quickly. And it shows, again, if you can reconstruct that with the proper form, you should get the proper function. With that, I'll go ahead and stop, and happy to have any questions, if you could answer any questions if you have any. I think we have a minute left.
I have several questions.
Okay.
I have several questions, Dr. Lott. So first, there was one patient with all these, that's already immunocompromised. You said she had her leg that died, and you did her trachea. So then in that case, she didn't need to be on any additional immunosuppressants. But what about these other patients that you've done? Do you have to add on immunosuppression?
Yeah, so great question. You need, with the tissue engineered constructs, you need immunosuppression, and you don't. So as long as you're using the biomaterials that are shown not to have rejection that get integrated, so like the polyethylene and the PCL, and you're using your own stem cells or other structures, there's no rejection to it. The big risk you have is your body going to extrude it, try to push it out, and we haven't seen that part of it yet. So that's why I think as we're advancing in tissue engineering, it's going to overtake transplantation at some point down the road, because you're not going to need to have immunosuppression for these. It's a patient's own cells.
Yeah, that voice is better than most of the patients I see and I've worked on. Okay, so what about this, all this subglottic stenosis, tracheal stenosis, that wasn't listed as one of the eligibility criteria?
Yeah, because I know that just in New York they do the transplant, and I think there's utility to that, so they are part of it. If there are people that need that, that we think transplants can be the best, but I think for the vast majority of people, you don't have a segment that's much longer than 4 or 5 centimeters. And this has worked now 7 times for me, even for somebody that went through radiation after we put the implant in. So I would probably try something like this first before we went to just a pure trachea transplant. Now, if the larynx and trachea are both involved, we can do both of those at the same time.
Oh, I have so many patients for you, if that really is the case.
Well, good. We'll have to sit down and chat.
Okay. So then, this is how we can get in. We just, when you don't have a coordinator that we should contact to get these people in?
It's probably easier to go through me than to try to figure out the Mayo system and go through all the different phone calls and things. So email me, I'll get you to the right people for anything like that, yeah. Or give me a call or whatever. I'm obviously, if it's from one of you guys, I'm more than happy to chat with you and make sure we get the patient in and they don't get lost in the system.
Okay. It is only 2 laryngeal transplants. Oh, these would be from cadavers, the 2 transplants a year?
You're correct, yeah. The first part were all cadaveric transplants, yeah,
Gotcha.
exactly. Yeah.
So then, well, what about I mean, it's a very mundane question, but what about insurance? I mean, a lot of my patients have access. Would that be a barrier then to get them into you?
Yeah, so it should not be. For the larynx transplant program, we've actually spoken with a bunch of the different insurance companies, including Access and some of the other places, and they've agreed to treat this as basically as a laryngectomy and a free flap reconstruction. So as long as Mayo has a code or something to say, hey, this is something that we can do, they're willing to work on this, and then everything else is covered through costs of the clinical trial.
Okay.
Yeah.
Okay. So then, when you do this, there's no code for it, but you're just doing it.
Correct, exactly. Yeah, these end up getting coded as just tracheal reconstructions.
Oh.
Yeah. Luckily, the cost in this is setting things up. It's getting the 3D printer, it's getting the technology, to actually print this, it's a couple $100 to do that. It's not a big cost to actually create the implant, and that's really the only thing on our side is an extra cost that we would be losing money on. Everything else is a tracheal resection with reconstruction or a hemilaryngectomy with reconstruction. That's how it's billed, and then we just put the implant in.
Okay. I mean,
That's meaning, that means,
you have 1 minute
well,
left.
yeah, 1 minute, okay, thank you. Yes?
This may be off the wall a bit, but did the infamous Dr. Macchiarini lay any true groundwork for you with your work?
Yeah, that's a great question. So for those of you who aren't familiar with Dr. Macchiarini, he's an Italian scientist that was working at the Karolinska Institute, and basically was an entire fraud, unfortunately, from the clinical side of things. His actually basic science research has been reproducible and has been founded to be pretty solid. It's just that he falsified all of the clinical work in addition to a lot of different things. So yes, the basic science things we're able to take and add from, but really the biggest lesson is, for these things, the one thing I didn't show is I actually have a whole ethics board that has an ethicist, that has multiple people on there, including a patient representative, because you get so much involved in this, you have spent so much time and money, you want this to succeed, and we don't want to be tempted ethically at all to be able to do this. So if there's any question on if a patient is a candidate, or, hey, this patient's having complications, what should we do? It goes to that board, so I'm completely removed from that process, and that in large part was due to that. One of my big claim to fame, believe it or not, is I was the last person he met with before he got arrested, and it wasn't for anything else. We were just meeting to discuss science, I promise. He was at Mayo Clinic giving a talk, and I chatted with him, and then he caught a flight back to Italy, and then he got arrested. So perfect timing to not get involved with that. So that was a sigh of relief. Anything else? I think it's my time, right? Thank you all very much. I'm happy to chat, during lunch or anytime. Thank you.
Next, we'll have our very own Kathleen Cazzato, who's a speech and language pathologist here at University of Arizona. She also holds a faculty appointment with the College of Speech and Language Pathology, or Department of Speech and Language Pathology at U of A. She comes to us from having worked at multiple major institutions all over the country, including Northwestern. She's been a swallowing expert. So for us, she's really been instrumental in setting up the swallowing program. She does the fees. She tells me not to operate if someone has a high vagal injury, so I don't get myself in trouble from doing a CP myotomy. Kathleen will be doing a talk on muscle tension dysphagia today, and then Dr. Watt will be piggybacking on that and talking about in-office balloon dilations of the esophagus.
Well, thank you so much. I've been looking forward to talking with you all today about dysphagia. And I did want to take just a moment first to say how much I've appreciated working with Dr. Yip and Dr. Wong and all of the ENTs in our practice. I think, I know I have learned a great deal from our interdisciplinary work, and I think it's also benefited our patients as well. So what I'm here to talk about today is muscle tension dysphagia, which is a somewhat newer diagnosis in the dysphagia realm, and actually much, if not 100% of the research in this area comes from Dr. Lott in his lab, so we have our own personal expert here. So what I'd like to go over today is first to talk about what is muscle tension dysphagia, and this is a particular diagnosis that lends itself to also discuss what's involved in a comprehensive dysphagia workup, to kind of review and discuss the issues involved in that, because this is a diagnosis that necessitates that in order to arrive. I'm going to talk briefly about other diagnoses to exclude and that you might consider when you are working up these patients, and then briefly about treatment considerations. So starting off with the definition of muscle tension dysphagia, it is a functional swallowing disorder that is associated with abnormal laryngeal muscle tension at its core. And it can often co-occur with accompanying disorders that suggest laryngeal hyperresponsiveness, so things such as chronic cough, PVFM, and muscle tension dysphonia, some of which I think we'll be talking about later during our panel. So this is really a diagnosis of exclusion, and that is why a comprehensive evaluation is really important, because you have to rule out several other potential causes that have a different treatment approach before you can begin to consider whether muscle tension dysphagia might be appropriate for any given patient. So starting off with typical complaints that a person with muscle tension dysphagia might have. But as you read these complaints, you might notice that pretty much every dysphagia patient who comes to your practice also has these complaints. But things such as food getting stuck in the throat, it hurts to swallow, I'm coughing and clearing my throat all the time. Those are all things that suggest that, clearly something is wrong somewhere along the swallowing mechanism. So when a patient comes to you with these complaints, I know sometimes it can be challenging to figure out the most appropriate referral source right away. And this is really the list of professionals who all could be involved in helping with the management of dysphagia. Especially a patient who requires a comprehensive workup, chances are all of these professionals will be involved at some level. But as far as kind of where to start, or what you might use as your first referral source, these might be some general guidelines. So you might consider more of a laryngologist referral if the primary complaints have to do with pain, especially if the pain is not only with swallowing, but outside of swallowing as well. If a patient has known vocal cord injury or involvement, a general globus sensation, or a history of head and neck cancer, that might be the first suggestion, is to see a laryngologist first. You might consider the referral to speech-language pathology if the symptoms really seem to be localized to the oropharynx and during meals. So that might include things like coughing directly during intake, a feeling of food and liquid stuck in the throat. Anytime patients are starting to avoid different consistencies because they're just finding them too challenging. I've stopped eating bread, I've stopped eating meat, I've stopped eating crunchy things. And if there are also associated changes not only with swallowing, but with voice and speech. So if there's a combination of dysphagia, dysphonia, dysarthria, that might warrant a referral to a speech pathologist as well. GI might be a good initial option for reports that are more having to do with the chest or sternum or stomach. If the reports are coughing with eating, but it's after a meal or only in certain positions, I might be more inclined to take that route first. And with any of these patients, a dietitian is always a good consideration to have as part of your team, especially if a patient has really started limiting consistencies or is on different types of diet modifications that limit their nutritional intake. But the reality is that if you refer to any of these professionals who's used to working with dysphagia, I think most of us know to refer to others as appropriate as well. And in a complex patient, I think all of these professionals are appropriate to be involved. So if you're referring to a speech-language pathologist to take a look at dysphagia, these are the three things that we might do to management of that patient. So when you refer out to a swallowing evaluation for speech, and then you might get one of three different kind of reports back. We often start with the clinical swallowing evaluation. In many cases, we are then recommending some form of instrumentation, such as either a FEES or a video fluoroscopic swallow study, and then perhaps therapy. So if we go back to our initial patient and kind of take a look at their complaints that they've listed, if this patient were to come to me and I were to begin a dysphagia workup with them, the first thing I would do is try to consider, does this patient have any reason in their medical history for me to suspect that that is the cause of an oropharyngeal dysphagia? So remembering that it is, dysphagia is a symptom, it's a symptom of an underlying problem, and in a yet to be diagnosed etiology, we need to do some exploration there. So I'm looking for any reason that already exists, a history of stroke, progressive neurologic disease, head and neck cancer, even if it's remote, iatrogenic reasons such as cervical surgery, spinal surgery, or intubation, or if there's respiratory comorbidities such as COPD. I'm looking for any reason that might explain their symptoms. In the absence of that, which a person with muscle tension dysphagia probably would have an absence of many of that, my initial hypotheses would be that a few things have to be excluded. So these are all options that might run through my mind. I might suspect a structural problem, such as an osteophyte or a Zenker's diverticulum. I might wonder if there's actually an underlying GI problem, such as reflux or motility difficulties that are manifesting as more referred sensations to the oropharynx. Or I might be wondering if there's a yet-to-be-determined diagnosis for which dysphagia is a presenting symptom. So I might wonder if there's an underlying neurologic process or rheumatology underlying diagnosis happening. And muscle tension dysphagia might also be on my mind too, as a possibility if all of those other things have been ruled out. So I would start with a clinical swallowing evaluation. I would first get a very thorough case history, trying to get an understanding of the patient's symptoms, how often, when they started, what kinds of foods, really getting a nice picture of what's happening when a person's eating and drinking. I would do a thorough cranial nerve exam, and again, I'm looking for any kind of underlying things that make me suspect a neurodiagnosis with that. I'm likely going to do a patient-reported outcome measure, like an EAT-10 or a swallow call, and then ultimately I'll watch the patient eat and drink a few things, just so I can get a picture of what it looks like, what symptoms am I seeing, what modifications has the patient learned to make over time to adapt to their eating and drinking. And really the purpose in doing this is to determine, number one, do I want further evaluation on this patient in the form of either a video or a FEES? And if yes, which evaluation might be the most appropriate for that patient? Or am I thinking a referral to another specialist might be a better use of the patient's time and resources? In our hypothetical patient with muscle tension dysphagia, I will be doing some form of instrumentation, if not both. So our two choices, I'm sure you are familiar, but to refresh your memory, is the video fluoroscopic swallow study, which unfortunately is known, I think, at every facility I've worked in. It's been known by a different name, which is very unfortunate. But you might be called the modified barium swallow study, a video swallow study. I've heard dynamic swallow study. At our facility, it's swallow function pharynx video. And if you are a seasoned person who happened to be around from the very beginning, you might have been familiar with cookie swallow test, which is the term that Jerry Logeman formed when she was first developing this procedure. Or a FEES, which, thanks goodness, only has one name. So just to kind of review and discuss the differences between these tests and the information that you can learn. So a video fluoroscopic swallow study is completed in a radiology department, usually with the radiologist present, although that depends on the laws in your state. It gives a lateral view of the head and neck, and you can see all phases of the swallow, the oral phase, the pharyngeal phase, and the beginning of the esophageal phase. Some limitations are that you cannot visualize secretions, you can't visualize the vocal cords easily, or vocal cord movement. It involves very controlled types and amounts of food, and everything is mixed with barium. So for some patients, it's inherently an abnormal eating condition because they're eating amounts and a substance that they don't normally eat. And it's limited in timing. So a radiologist, their culture is to try to limit your exposure to radiation. The fluoroscopy machine is turned off between every food or liquid presentation, so you miss information between every bolus. A FEES, on the other hand, is completed in multiple settings at the patient's bedside if you're in the hospital, in our office, even home, and mobile FEES can go to someone's bedside. It's a superior bird's eye view. You can see only the pharyngeal phase, and even a portion of the pharyngeal phase is obliterated during the pharyngeal constriction, so there's a whiteout period. However, it does provide really excellent views of secretion management. So if someone's having difficulty even with saliva or lots of complaints of mucus, we can take a look at that. We can really look at the vocal cord function and that role in swallowing. You can use any amount and type of food, which I have found is really helpful in patients with inconsistent or vague complaints. I had a patient once whose primary concern was that she was really bothered by the fact that she could no longer eat Frito corn chips, that particular corn chip was very challenging, so she brought those in for her FEES study. And it can take as long as needed. So I'm not limited by time, I'm not limited by radiation. I can take as much time as needed to feel like I got a really good look at that swallow. So in most situations, either of these tests is a great starting point and will give you the information that you need. However, there's some patient scenarios that might make me want to do one test before I do the other. So for example, I might opt for a video first if I want to really see the oral and pharyngeal phases and the interaction between those phases. So situations in which that is true are often patients who've had a glossectomy, or patients with ALS, which can really affect tongue strength and function as a first symptom. So when I want to see those interactions, that might be a test I would like. Anytime you want to look at a kinematic movement, so like laryngeal elevation, you need that view of the lateral view, or UES opening can only be visualized by video. If one of my hypotheses is a structural concern, such as the impact of cervical hardware or an osteophyte, we can see that much more effectively on a video, and any time I'm wondering about the cervical esophagus. So if that's my primary list of concerns, I might go for a video first. However, there's other situations in which a FEES I might opt for first. In the inpatient setting, if a patient is fragile, it's really nice that you can bring the FEES to the patient, or if you're expecting that you can only look at limited consistencies and you don't want to bring them down to radiology to do a whole procedure. Anytime I'm worried about vocal cord function as a possible primary etiology for the dysphagia, a FEES gives a much better view of that. When I'm concerned with fatigue, so again, I bring up the case of maybe a patient with ALS or myasthenia gravis, where you want to see the impact of time on swallow function. There is evidence to suggest that FEES is more sensitive to seeing microaspiration. So if I'm, kind of worried about that. And I've highlighted this last point because in our hypothetical patient with muscle tension dysphagia, sometimes being able to have that visual feedback of the swallow, I have found is really helpful. A lot of times with these patients, it's not only what they're feeling that is problematic, it's the anxiety about what they're feeling and what that means. And so if they can visualize that the swallow looks pretty normal, sometimes that alleviates some of that anxiety. It doesn't alleviate the problem, but it might make them less worried about it. So a video fluoroscopic swallow study, it's very common to follow a protocol with barium that starts with small amounts of thin liquids and then moves through various consistencies such as thickened liquids, puddings, and solid foods. There's a trend and a desire kind of on a national level to standardize the video fluoroscopic swallow study, both in terms of what we're giving the patient and in how we're interpreting the patient. So the most frequently used one is something called the Modified Barium Swallow Impression Profile, MBS-IMP, which was developed by Bonnie Martin Harris out of Northwestern. And this is a list of the 17 components of swallowing that a speech pathologist is examining and looking at during a swallow study. So I'm going to take just a moment I know everyone's worried about aspiration. Did the patient aspirate? Did they pass their swallow study? Is there aspiration? And clearly that is very important, but it's really just a small piece of the puzzle. Just knowing that somebody aspirated really doesn't tell you much of anything. It doesn't tell you why they aspirated. It doesn't tell you how to treat that aspiration. And you could certainly have a significant swallowing problem that doesn't involve any aspiration at all, as in the case of our hypothetical muscle tension dysphagia patient. So I'm going to show an image now of a normal swallow study. This is a person just chewing a cracker coated with barium. Okay, so the material collected in the vallecula briefly, which is very normal with solids. A nice rapid swallow. One swallow pretty much cleared all of the material from the pharynx, and the patient is, that's a very functional, normal swallow. Now I'm going to show you a swallow study. So one of the differentials in a patient with complaints might be something like an osteophyte. So I'm just going to show you a study where you might see something that concerns you. So really good bolus hold here, a little bit of loss, but what's happening here As you can see, we're not getting as good clearance through the pharynx. This patient has it's not that large, but a little bit of a cervical osteophyte here, but it's just in a bad spot. So with the movement of the swallow and the elevation of the larynx, this patient still can't quite get good inversion of the epiglottis. So the epiglottis is getting kind of stuck on that spot. And as a result, the patient feels like there's something stuck in the throat. So those are very similar symptoms to someone with muscle tension dysphagia. Something stuck in my throat, I feel like I can't clear food, I feel like something is there. So that's an example of what we might see if it were a more structural difficulty. Fees, typically there's not really a specific published profile like there is for a video swallow study. Usually you pass a scope, we start off just like you with your laryngoscopy exams, just sort of looking around, looking for structural difficulties, looking at secretion management. We guide the patient through different speech and voicing tasks to see movement and symmetry of structures in a more functional aspect, and then we give different substances of food and liquid, often mixed with food dye so they show up easily. And the goal is that we are, commenting on movement and symmetry of structures and muscles. And then once food and liquid presentations are given, we're looking for clearance. We're looking for if there's residue, where is it? If it's aspiration, how much and with what? And what's the patient's response to it? Did they cough? Did they swallow again on their own? Did they clear their throat? So this is a FEES of a patient who actually I did suspect have muscle tension dysphagia. So I am going to, it's really an example of a normal FEES, which is often what you see in a diagnosis that ends up being muscle tension dysphagia.
Now we're going to see what things look like when you're swallowed, okay? So I'm going to have Ryan start with some milk. We'll start with just one sip. Yeah, it's green. You just have to trust us on that one, but yeah.
Everyone laughs at the green milk, that's what she's commenting on. But what we're seeing here is a really timely swallow. This is, the reason we give milk is because sometimes we can see some coating a little bit better, but this is very trace coating on structures, but very, very normal.
Your single sip. Are you feeling any of the weird sensations in your throat?
Very, very mild.
Okay.
I mean, that afferent.
Kind of numbs things.
Yeah, that makes it feel so much better.
What she's saying here is often with this kind of diagnosis, I'm asking the patient, are you feeling your symptom? Are you feeling your symptom? If so, where is it? Show me. And she's saying, no, I don't. I really think that medicine you gave me helped me. And just going off of what Dr. Yip was saying earlier, this particular patient did have some topical lidocaine before the procedure. I try to avoid that during FEES, but this patient really did want it. And just that administration that numbs the larynx just a little bit alleviated her symptoms, which is kind of leans you towards the category that there's a real sensory component to her swallowing challenges.
Now we're going to see what things look like when you're swallowed, okay?
Sorry. And then again, I'm just for comparison going to show you a FEES where a patient had similar complaints, but there's a more structural reason. So as I'm sure you're familiar, this anterior protrusion here in the hypopharynx might suggest either cervical hardware or an osteophyte. And you can see the impact of that with this next bolus presentation. Again, everyone laughs at the green food. But this is a thicker consistency, and just like in that video swallow study, what we're seeing is that it just can't quite clear the epiglottis. So there's not enough room for that movement there. The epiglottis is resting right up against that protrusion, and so when it can't completely invert, it's almost like it's just clogging that pathway. Okay, so the workup so far for a standard patient of muscle tension dysphagia has been normal. So in that case, a GI referral is very important to complete some procedures such as this, an esophagram, high-resolution manometry. We're ruling out any esophageal issues as a primary problem. And if those issues are ruled out, it's also important that, that there's a stroboscopy involved. And so Dr. Yip performs stroboscopy, our speech-language pathologist here also performs stroboscopy, and you're ruling out any abnormalities to the larynx that exist. But indications that you might see on stroboscopy of muscle tension dysphagia might include issues associated with laryngeal hyperresponsiveness, such as chronic cough or PVFM or a globus sensation, or any signs of a supraglottic compression with phonation or signs of dysphonia. And so these, in the absence of any findings from other tests, those are all things that might kind of point you to considering muscle tension dysphagia as a primary diagnosis. And the theory behind this is you have laryngeal muscle tension kind of creating this cluster of symptoms. The tension can be the primary cause of the problem, or the tension could be secondary to an underlying problem. But the muscle tension can create this whole cluster of symptoms. Sometimes a patient's presenting symptom are these chronic cough, PVFM, but in some patients the presenting symptom is the dysphagia, and that's what they're most concerned about. So in that case, you might consider some trial therapy to include similar techniques you'd use with a patient with muscle tension dysphonia, strategies to reduce muscle tension. Swallowing specific exercises have often found to worsen a patient's symptoms. So you would, this is a case where your diagnosis really does affect your treatment plan, and one treatment might be contraindicated for your patient. So in summary, you might consider a diagnosis of muscle tension dysphagia if you have an idiopathic dysphagia with, after a thorough workup, has no known cause. You're seeing evidence of abnormal laryngeal muscle tension, accompanying signs of hypersensitivity and responsiveness to trial therapy. So thank you very much.
Okay, next, Dr. Lott will talk about in-office balloon dilations. As you're setting up, I have a question for you, Kathleen. So you said that topical lidocaine can relieve some of that tension. I've had 2 patients now who are asking me for Valium, and they don't seem like drug seekers, but they said they can't swallow, but they take 1 milligram of Valium, and then they can swallow. And they have to take it 3 times a day before each meal. And I really have no choice but to give it to them. And I'm not really a person to give out, I'm not in the right profession to give out benzos. So have you heard of that?
Well, I've heard about it from you. So definitely on patients that we've shared. And I guess my thought would be I'd really want to make sure that everything else has been excluded and ruled out before the patient, turns to that as an easy fix, when there might be another fix that would actually solve the underlying problem.
Okay, all right. Then, Dr. Lott, maybe you can elucidate that.
Sure. So absolutely. So I was asked just to give this is a quick 10-minute just talk on incorporating balloon dilation, esophageal balloon dilation in the office, and some of the things you can do to get that better. So again, the disclosure here, I do consult with Cook Medical. They do make an esophageal balloon. I'm not going to talk about any products. I don't get paid if you buy balloons, anything like that. So this is really more about the process itself. As you know, a lot of laryngology has really moved toward doing things in the office. We do office laser procedures, office injections, and office balloon dilations for different things, even in the airway sometimes. But really the big push for some of our more straightforward patients is to do the balloon dilations in the office. And the benefits to them, as you guys can probably guess, one, you save a trip to the operating room. So you avoid general anesthesia risks for patients that maybe aren't the best surgical candidates. You can get faster results. And so if this is somebody you're doing diagnostics on also, you can do biopsies, you can do a variety of different things. Be sure you know what you're looking at, do a dilation real quick, and both the diagnosis and the therapy is done at the same time. And if you're at a facility where you can get frozens back, right away, you're close enough, you can actually get a result on something that you biopsied before the patient leaves. Bleeding is really not a concern. I haven't had anybody with any sort of bleeding issues, even people that have been heavily radiated and have pretty dense scars. Vast majority of people do just fine with it. It does take a little convincing and a little hand-holding the very first time, but after that, they realize it's really not that big of a deal. And then lastly, it's just less expensive than going to the operating room. And really what we're focused on for this is you can balloon dilate anywhere in the esophagus, and the more advanced you get and used to doing it, you can dilate anything in the esophagus. But really is focused on the upper esophagus and mostly in that kind of upper esophageal sphincter range. And the two big things you see there tend to be CP hypertrophy or some sort of upper esophageal web or stricture in that area. And you can see on the video fluoroscopic cookie swallow study, whatever the name of it's going to be today, you can see, again, here's the CP myotomy. You can see kind of stippling of the posterior cricoid area here, or you can see a web. This is a great sign, and this is the thing that sometimes we miss a lot on these video fluoros is, hey, things look good because this pops up for a split second and then it goes away. But really look out for these webs. They're a lot more prevalent than you think they are. And they're really easy to get rid of just in the office with this procedure. So when to go to the operating room? Sorry, when not. Yeah, when to go to, I should say when not to go to the, okay, yeah. When to go to the OR, when not to do it in the procedure. I forgot how I wrote my title there. So patient tolerance is the big thing. Again, it does take a little hand-holding at first, and then people that just are too anxious, they have really tight nasal anatomy, you don't think you can get the scope and a balloon through their nose, stay away from it for those people. If they have significant esophageal pathology, so really severe strictures, if they are at risk for airway or bleeding concerns, if they're, you're not going to reduce as anchors or fix as anchors with this in the office. Radiation you can do in the office, but I wouldn't recommend it for the very first time you're dilating that patient because the pliability isn't the same. You don't know how that tissue is going to respond. So typically I'll take those patients to the operating room the first time. If they need a subsequent dilation, then I'll talk to them about doing it in the clinic. If you don't have the personnel or infrastructure at your place to be able to do it, or depending on insurances, they have a harder time understanding what you're doing in the office, and so there may be some insurance concerns, and it may take a little while for you doing these for the insurances to understand what it is that you're doing and you're actually saving them money. Where to start? If you haven't done balloon dilations or esophageal dilations and you're wanting to do these, obviously start out in the operating room first. It gives you time to kind of get used to things, play with them a little bit without the patient staring at you. If you haven't done things in the office before, maybe start with some things that maybe are relatively simpler, like doing tracheoscopies, getting the patient numb with lidocaine. You can do tracheoscopies, do transnasal esophagoscopies. Transnasal biopsies are good because you get used to putting things through the channel and taking biopsies and moving around and positioning your scope to get the right orientation of things. Alaryngeal patients, so laryngectomy patients are great at this. They don't tend to have the significant of a gag reflex, and it's a lot easier target, a lot easier shot. Simple strictures, and then again, don't pick a radiation patient for the very first one that you did. Preparation, so you're at the point you decide you're going to do it, what do you need to do? So you can't be done by yourself unless you're really, really good and you can use your feet to blow up the balloon or something. You have to have a person to kind of push the thing for you. You have to have a flexible scope that has a channel in it. And I say that, and that's not necessarily true. If you plan on using a guide wire, you should have something with the scope in it, but you can put a guide wire and the balloon down one side and the scope down the other side and do this without a guide wire. So the channel is optional, but it's a lot easier to numb people up and to place it with a channel. You have to have the balloons. A guide wire, if you decide you want to use it. I don't use them. A lot of people do. Topical anesthetics. And then you have to prepare for the worst, even though I've never come anywhere near it or experienced it. You have to be able to manage airway issues and have a co-team available in case something unforeseen happens. You never know when you're messing next to the larynx. Then the procedure, patient selection, again, vast majority of people do just fine. I really have not had any issues. Once it's done, they say, yeah, it's fine, we'll do it again next time. Informed consent, just again, get a good thorough explanation. For these types of things, it's much better to in my experience, to list all the things that can go wrong. So if something does go wrong, it doesn't seem like you weren't aware of it. So things like, hey, you know, you may have spit up a little blood for the next week or so. That's normal because we made little incisions. Just the things you would do ordinarily for a dilation, but really go through that with them ahead of time. You have an inflation device and get the balloon prepped, get all that ready before you put the scope in so you're not wasting time trying to get that done. And usually we fill that inflation device with about 40 to 50 milliliters of sterile water or saline. Either one's fine. Anesthesia, I spray the nose with oxymetazoline and lidocaine spray. Sometimes I'll use lidocaine spray for people that are really nervous or really gaggy. And then I drip lidocaine through the laryngoscope channel in the kind of piriform sinus area and then on the larynx itself, just to get them more under control. And you have to prepare them. They won't necessarily feel as much pain per se. They still feel the pressure. You know, the anesthesia doesn't take away the pressure sensation for them. So then when you put the scope through, I always like to do a full esophagoscopy first to make sure I'm not missing something. I'm not dilating something I don't think I am, or dilating the wrong thing, or missing some pathology below that. Then if you decide to use the guide wire, you can place the guide wire through the laryngoscope channel or just in the other nostril. You can push the balloon in the same nostril or the opposite nostril. I typically inflate the balloon for about 15 to 30 seconds. It's about what the patients can tolerate, and then they get kind of sick of it after that. And then you can, if you have a needle injector like Dr. Yip showed, you can inject steroids into that area to try to loosen up the scar. And then I like to do another esophagoscopy again afterwards to make sure there aren't any big tears in the esophagus or something that we miss, something that's bleeding, just so that I can rest a little more comfortably afterwards. So here's just 2 quick videos to show you what this looks like. This is actually, I do what I call an office pen endoscopy. If you're going to get the patient numb, I do a full exam. This isn't for an esophagoscopy, but it gets to the point home. So this is a patient that came to me with a really large cancer, obviously. And it came to me with a globus sensation. So probably not much dysphagia on this one, I guess. And here's just dripping the lidocaine through. And you can see once you get the lidocaine drip right on the vocal cords, everything's squared away. You can go all the way into the kind of proximal bronchial segments. So you can see it coming down. This is sped up a little bit so you can see them more quickly. But if you need, you can actually go further down. And the patient's not coughing. You can hear them a little noisy breathing, but they're comfortable. They're breathing just fine. I just warn them. It feels weird, but you're breathing fine. You can see as far as you need to. Go to the trachea first, so you're not bringing goop from the esophagus into the trachea. Then I'll go down to the esophagus, do a transnasal esophagoscopy. This guy had not fasted or anything, and so he still had a bunch of mucus and saliva in his esophagus, but you can get a good look through his esophagus, make sure everything looks good down there. There's an extension of tumor. And again, this is the good way to practice with the balloon, is to come in and take a biopsy. So we take a biopsy, we send it up to pathology, and we can get that frozen infection result back right away. All right, so again, that's just really just to prove that with enough lidocaine, you can really do anything, and the patients are very comfortable. Here's a video of the actual balloon dilation. This is done, I borrowed this from Rebecca Howell, who's a laryngologist in Cincinnati. It's a great video. I didn't feel any reason to do it. She does it different than I do this. So she'll actually place, you can see doing a transnasal esophagoscopy, significant fungal disease in the esophagus here. And so she places the guide wire through the channel all the way down into the stomach. So that the guide wires are crazy long for whatever reason. So place it all the way down the stomach to make sure it doesn't move, and then remove the scope from the guide wire. And then you'll see the next thing is to place the balloon over the guide wire. I tend to just push the balloon through the nose without the guide wire. It goes into the same area. It may take a little bit of finagling and posturing, but you can get it in without the guide wire. And here you can see just, again, how crazy long these guide wires are. Then you'll put the balloon through, thread it over. I can fast forward a little bit here probably. She also goes down the same side. I tend to go down the opposite side. So there's not so much in one nostril. And you can just see the balloon. It'll follow it into the kind of post-cricoid area. And you see the patient's tolerating it just fine. They're not coughing, they're not choking, and you can do your dilation and blow it up, and you can do various sizes. Typically, I'll try my best. Different balloons have different sizes. I try to go between 18 and 20 millimeters for these. One quick plug, if you're interested in learning all this stuff, we do have a course coming up in about a month and a half in Phoenix. So please feel free to join us. Thank you. Thanks.
Thank you, Dr. Rock. Yeah, I have a couple questions for you, Dr. Rock. Are you putting the T&E down the trachea as well? Because I saw you insufflating.
I do, yep. So I just use the same scope for everything, basically.
Oh, that's huge.
Yeah, it is. It takes a little bit. The T&E scopes are really long also, but the diameter is the same size as like the high-def scope, so they're bigger scopes, but it's going to be down there anyway for the balloon.
Okay.
And so I just use that whole thing for it.
Okay.
Yeah.
So for these muscle tension dysphagia patients, they're pretty desperate, and yet the workup will tend to be normal.
Right.
So do you do an empiric balloon dilation in the office to see if it helps?
Yeah, that's a good question. There's actually a paper out there, believe it or not, that talked about that talked about empiric balloon dilations for some of these patients. I don't usually do it as the first line. So if you think about muscle tension dysphagia, just like muscle tension dysphonia, you can have underlying causes or primary, or the underlying cause and dysphonia. So you can have a stricture or a bar, but also have the tension component to it. And so I will usually try to do things in tandem with one another. So we'll get the workup, get a good thorough GI evaluation, at the same time as having them go through therapy to address the muscle tension component. And then if it shows that there's a bar or a web or something, I'll do the dilation at that point.
Okay. Now, if there's no bar or no web, would you ever offer Botox or even just I know an empiric CP myotomy seems really radical, but would you ever trial dilation plus or minus Botox?
I will. I guess part of the muscle tension dysphagia part of it, with a couple of studies, something like 90-something% of people got better with the therapy alone. And so I would try those first, and if they're not progressing with therapy, then I would start doing some of these other things to say, well, maybe there's a tightness there that we just can't see. One of the things we haven't published yet is a high-resolution pharyngeal and esophageal manometry, and we see that those patients tend to have increased relaxing pressure and decreased relaxing time. And so that valve doesn't open up quite as well, which may be, to your point, if you can't get the muscles to relax, doing a dilation just to get in there and stretch that out may be something that would be helpful for that.
Okay,
Yeah.
Okay, great. Thank you.
Question. Thank you.
Okay, so we're switching computers. There's a little bit of downtime. Does anyone have any questions? Oh, yeah, go ahead. Oh, 20 minutes? Huh? Oh, it is.
So the question was, if a report comes back and they're showing evidence of penetration, but they don't mention aspiration, what to kind of make of that. So penetration would mean that a bolus was seen to enter the vestibule. So it entered the airway, but it stayed above the level of the vocal cords. So it didn't actually go all the way down into the trachea, versus aspiration means that it goes all the way down into the trachea. So penetration in many people is completely normal. Some people, we used to kind of treat it and worry about it, but as more studies have been done on normal, we're realizing that many people penetrate regularly. So as long as someone's clearing that material and it doesn't actually aspirate, usually it's not problematic.
Okay, it'll take a minute to load. So the panel discussion is going to be on vocal cord dysfunction, or what we otolaryngologists call paradoxical vocal fry movement. Or the more inclusive term is exercise-induced laryngeal obstruction. And then there's a new term we want to coin, which is dyspnea of unclear origin, which we're seeing more and more of. So I'll just run through a bunch of videos just to illustrate to you what I think PVFM is. I don't think there's a whole comprehensive video library out there as to how to really diagnose even this condition. And then we'll just have an open forum discussion. Okay, since we're short on time. Okay, so in normal respiration, when you just stick the scope down someone's pharynx, in quiet respiration, there's actually a natural abduction of the cords. So there's always going to be a little bit of a gap. And then if you ask them to sniff or inhale, then that's where you see the vocal cords pulling apart. But that's only momentary, and then the vocal cords will kind of snap back to this quiet respiration position. So here is an illustration of that. Now, in this actually very healthy Army officer, he comes to see me, he's very Disney. So then I asked him to inhale. This sound's not playing. So you'll see the vocal cords abducting, and then they'll just slowly, he inhale, and they kind of slowly drift it back to the quiet respiration position. Okay, and then, so that's normal. So if you are asking them to inhale, exhale, there's always a little bit of abduction at the end of the inhalation phase, so that does not really count as PVFM. Okay, so I had the same officer run up and down the stairs, I don't know how many times. I mean, he was always very, very fit. So, and he was able to do a lot. So then after exertion, the cords are wide open. I mean, here he spoke to me. So here he's able to maintain his cords wide apart. Okay. All right. So next I'm going to show you some pathology. So I've already kind of gone over the nomenclature. So now we have this pipeline of referrals from allergists and pulmonologists. So after the patient has had a full workup, nothing turns up, and they've been to the cardiologist, but they're still very out of breath, and it's not even COVID related, so they come to us with the last stop. Okay, so in a fancy PVF or vocal cord dysfunction lab, you would have this kind of a setup. So we don't. So I just use a poor man's way of having them run up and down the stairs many times. So if we had this setup, the patient would be seated in an exercise bicycle. They would wear a helmet, and then the laryngoscope would be taped to the helmet, and then be placed inside the larynx, the pharynx during, say, 20 minutes of exercising, just to catch maybe these intermittent episodes of paradoxical vocal fold movement or supraglottic closure. Okay, so here is an example of what we would call PVFM. Again, the video's not playing, but basically I told her to inhale, and then the vocal cords came together. Yeah, so okay, so here's another example. This one would be more obvious. So this woman actually just constantly was keeping her cords abducted, whether she's exhaling or inhaling. And it's not even from the guarding, from having the scope in her pharynx. So she's quite short of breath. Okay, so here is a 60-year-old, quite obese guy, well, coming in. He's super short of breath. So I just want you to take note of how the arytenoids just closed in and is opposing next to the epiglottis. Okay, so then this video I have already shown you from my other talk, but actually, I had misdiagnosed him with PVFM. The adduction of the cords actually just came from both cords not moving well. And then so when you're taking a deep breath, the cords will come together. So he actually sounded pretty stridorous. So when you hear stridor, that's not a usual sign of presentation for PVFM. These patients come in, they actually seem pretty asymptomatic otherwise. So the textbook example and what we had learned in the past, not that we had learned a lot about this condition in our training, is that it's kind of a psychiatric or psychogenic condition in a highly competitive young female athlete. That was the prototype. And sometimes we do meet one of those patients, and they do seem to be more amenable to speech therapy. But now we're seeing more and more people outside of this mold. So next, we originally had a whole talk prepared by our two speech pathologists that I forgot to introduce. So we have Dory Smith, who also holds a doctorate in performance arts. She's an active soprano. She has her own voice studio. She still performs regularly. I've seen her perform in A Christmas Carol, and she's phenomenal. It's like an angel singing to me. And then we also have Natalie Monahan, who used to be a voiceover actress in LA. She did a Shaman commercial, is that right? That paid for grad school. So anyways, I'm very, very fortunate to have both of them here. She also did musical theater. So anyways, so they do voice and they do airway, which consists of basically laryngeal hypersensitivity conditions. So you want to talk a little bit about maybe your approach. I know we're short on time, but maybe just a short blurb.
Sure. So as one of the overriding themes here is multidisciplinary collaboration and evaluation and treatment, this disorder is certainly a great example of that. In our treatment, we get patients who are at various stages along the diagnostic process. Maybe they've seen the pulmonary, maybe they've seen GI, maybe they're a referral from Dr. Yip. A lot of our job is patient education and also dealing with some of the barriers the patient has encountered during the diagnostic process and addressing patient skepticism. So our treatment is very multifactorial. Primarily, it's designed to train the abduction of the vocal folds during breathing cycles, allowing very easy movement of breath to and from the lungs without that laryngeal constriction. Often it is more considered to be an umbrella term as far as what we see anecdotally with our patients as far as uniting this constellation of symptoms that has lowered the threshold of what the patient is able to withstand without feeling triggered or without having dyspneic symptoms. So we try to tell the patient that and reassure them that this condition can be brought under voluntary control through a variety of different methods, through that education, through biofeedback, through respiratory retraining, which can take a multitude of different forms and can be personalized to the patient.
I agree with what Dory just said. Specific to some of the athletes that we do see, there's a specific other treatment aside from our relaxation protocol and relaxed breathing training and rescue recovery strategies that we tend to use with the athletes because those traditional techniques sometimes don't work. So there's biphasic breathing training, which capitalizes on what was seen during continuous laryngoscopy when athletes were experiencing PVFM, where they're having episodes where there was a period of high resistance inspiration followed by low resistance inspiration that helped them open and pop open the vocal folds so they were able to take some breath in. So there's a training protocol that we can work through with our patients with that specific presentation.
Okay, so after Valerie and Dory try their magic, sometimes these patients will return to me and say, I'm still not feeling good, nothing's helped. So I did offer Botox to some of them. So the rationale behind Botox is that most of the laryngeal muscles are actually adductors, and they're only one pair of abductor muscles. So if you inject Botox, the idea is you're preventing the cords from coming together. So this is just an example of someone who had gotten Botox, actually for SD, not for this particular condition. So I think I've injected maybe 2 or 3 patients for PVFM or just dyspnea of unclear origin. I don't know, there's, even though it seemed like the motion abnormality was corrected, but they were still very unhappy. So I haven't found Botox to be very satisfying. And I don't know what your experience has been, Dr. Watt.
Yeah, I kind of agree the same way. For the vast majority of people, it helps to some degree, but not significantly. Some people get a sustained benefit and it works and wonderful. So yeah, it's hit or miss, and I kind of tell patients that. And I also tell them that, with Botox, it sometimes is a dose-dependent thing. So, I may do great with 5 units, and you may need 8 units, or 5 units may be too much for you. So sometimes it's trying to find the right dose, and that may be why some of them don't do well originally, because we don't have the right dose for them.
And if you do Botox, would you do a unilateral injection, or would you do just the true cords, or would you also do the false cords?
Yeah, that's the other thing I tell patients is that that's also hit or miss. So I just have to be prepared to do a few of these before we really iron it out. I will typically do both vocal folds to begin with, about 2 units per vocal fold.
Okay. Have you run into difficulty with insurance companies approving Botox for these patients? Do you have to call it something else, like laryngospasm, instead of, say, dyspnea or PVFM?
Yeah, I have, and sometimes you have to do, exactly, you have to kind of be creative, because it's, in my opinion, it's one large underlying pathology that just manifests different ways. So I think that, we're just trying to treat a specific symptom, and you're still treating the same underlying cause. And so, we'll use paradoxical vocal fold motion or dyspnea or whatever it may be. Eventually, though, it works out just fine.
Yeah, I absolutely agree. I think it's just part of this larger umbrella of laryngeal hypersensitivity, where it was manifested as a chronic cough or globus or PVFM. So I've found that a lot of patients have had some kind of intubation in the past, however brief. Have you found that association?
I haven't seen that with the intubation part of it, especially with the younger female athletes. I haven't seen so much, but maybe some of the adults or people that don't fit that prototype or stereotype, then yes, I would say actually it tends to be some sort of laryngeal trauma that they've had that initiates it.
Okay. So then you don't put an emphasis on psychogenic causes, right? I mean, that's a very antiquated idea.
Yes. I mean, I think laying the blame completely on psychogenic causes is an antiquated claim. I do think that anxiety and depression and those components have a role in it. I don't think it's necessarily the only role, but it feeds that kind of feedback loop. So it is something that I do discuss with them and address, but I don't say, hey, it's all in your brain, you're crazy.
Now, it's not common for this, for a voice and swallowing center to be hooked up with a psychiatrist or a psychologist. And obviously, for all the problems that we treat, muscle tension, dysphagia, or dysphonia, or this condition, it'd be nice, to have someone who could specialize in this area. Do you have someone like that?
No, we don't. I have a few psychiatrists and psychologists that I work with that I've had the conversations with on, hey, this is what we're looking for, but not specially trained. Believe it or not, though, I've heard that there is a new, not true subspecialty, but group of people that are focusing in kind of head and neck psychiatric issues.
Right. Okay. All right, the course co-directors are approaching us, so that means our time's up.
Everybody's hungry.
Okay. All right. Okay, we'll take a question, is that okay? One question, Dr. Wong says. Okay, yeah.
The best way to differentiate between exercise-induced asthma and exercise-induced laryngeal obstruction.
So by the time these patients make it to us, just like chronic cough, to me this is a new chronic cough. They've gotten everything else out of the way. This is a diagnosis of exclusion. So by the time they make it to us, they've had pulmonary function tests, they've been seen by pulmonologists. That part of the puzzle has been already been cleared up. So by the time they come to us, they should have no cardiac issues, no pulmonary issues. No one really knows what to do with them. Okay, all right. I guess it's lunchtime. So. Okay. Thank you.
So before we go out to lunch, just a quick announcement. My name's Eugene Chang. I'm one of the course co-directors. Thank you again for your support, as well as thank you to our sponsors for your support as well. We've made it through half of the first day, and we've learned a lot about peds, and we've learned a lot about laryngology. What I would ask is that in the next room next door, there are bagged lunches. There's a vegetarian option, a sandwich option, as well as a salad option. Please go out, grab a bagged lunch, and while we're doing that, I'm going to be setting up Dr. David Yen. So Sanofi, Genzyme, and Regeneron were kind enough to sponsor a non-CME event. So during that time, you'll learn specifically about Dupixent or dupilumab and their role in CRS with nasal polyps while you folks are eating lunch. And then after that, we will start our afternoon session of rhinology. We're really going to focus on sinus disease with nasal polyposis. We've got some fantastic guest speakers, so grab some lunch, get some energy, and we'll start setting up for the non-CME activity, and we'll see you in just a couple minutes. But thank you again.
tear out your carpet and get rid of your dogs and cats and pets, and they're going to put you on shots. Don't go see the allergist. And I had allergy colleagues say to me, well, we don't want our patients to see you. You're going to scope them, and you're going to do surgery, and their polyp's going to come back. Don't go see the ENT. But that model doesn't really make sense, and I think all of us agree collaborating and working together makes a lot more sense nowadays, because we recognize there's big overlap between these disease processes, okay? So very careful in patients with nasal polyposis that also have asthma to be respectful about the medications and therapies that my colleagues are maintaining and doing for them. So not indicated for acute exacerbation of disease. Be careful about stopping maintenance steroids or other interventions that might be under the direction of someone else. Again, right now, be careful of those therapies. Work together collaboratively in that regard, okay? Arthralgia, this has been reported, okay? So I mentioned that here. All these are listed. To be honest, I have not seen any of these myself, but just to be aware of them, arthralgias have been reported as well, okay? Final pieces, may I ask, has anybody in this audience seen a parasitic infection? Has anybody seen helminthic infection? Okay. So for fun, asking around, I've had people in Miami say they have, because maybe folks spending time in South America and otherwise. I'm from Pennsylvania, and the Amish actually have demonstrable rate of helminthic infection because they spend a lot of time barefoot in youth. I didn't know that until more recently, but just to mention. So right now, we think, and I think smarter people will talk to you more about it upcoming, we think the pathophysiology of nasal polyposis may be our innate response to parasitic infection gone awry, if you will. So it's not clear how blocking IL-4 and IL-13 might impact that. So if you have a patient who is a potential or has helminthic infection, please do treat first. This is something we just added, okay? How keen are we, how aware are we about thinking about vaccinations? We're pretty on the way now, right? Who think we'd be talking about vaccinations every day like we have for the last 2 years, okay? So in the setting of vaccinations, we don't have any information overlap. So the general guidance here, complete age-appropriate vaccinations as recommended. And so no further information in that regard, but just to make mention, okay? Last bits, as far as the adverse reactions, I'm going to focus here on CRS with NP, injection site reaction, eosinophilia, insomnia, toothache, gastritis, arthralgia, and conjunctivitis, okay, right? Special populations, pregnancy and lactation. Again, don't have information on either of these. There's a registry, okay, for any patients who may be exposed with pregnancy, and you can read the piece on lactation. We know that IgE can cross. So we don't know the impact there, but just special considerations to be thoughtful of, okay? So I'm sorry to beat you up with all the small print, but I think it's important, all right? Does anybody have any questions about those warnings or contraindications, thoughts or concerns? Please. I individually have not seen any of these reactions myself. I have to say that, okay? Okay. I have heard report, and I think it makes sense. I've heard report of this from 1 or 2 allergy colleagues, and I think it comes down to having more experience with the drug over more time and other disease states, treating people for AD, asthma, and so on. So I have heard report of it, but I can't say I've experienced it myself. But great question. One of the things I'll point out later on is who stops intervention based upon side effects. If someone has a side effect, but they decide to power on through, if you will, it says something about the disease impact on their disease state in terms of quality of life, okay? So to me, one last thing on the safety piece. There's biologics out there, and as healthcare providers or even patients, it can be hard to get your sense about what biologics mean as a class. And there's ones out there advertising now with concern for increased risk for immune dysfunction or even oncological cancer concerns. And so I think it's important to note, yeah, there's some things listed here, but in the grand scheme of things, this is my opinion. I think what we shared with you, at least for me, I view as fairly clean, if you will, okay? So that is all the small print, okay? So this is getting to the real world, what we know, and I don't have to explain this to anybody here because we all treat patients. CRS with NP affects our patients' quality of life, and we all know it goes beyond nasal symptoms, right? It's not just the sense of smell, it's not just the nasal congestion, it's the impact on performance and function in other ways in terms of quality of life, clearly reflected in SNOT-22, other symptoms as well, okay? Now, this one here, depending upon the audience, this can generate a lot of discussion and a lot of comment and a lot of disagreement, okay? So this cites data here, a 40% polyp occurrence rate 6 months post-surgery. I bet you everybody here in the audience is going to shake their head and say, no, my recurrence rate isn't that high, okay? But we're also all above average drivers too, I'm quite sure, okay? So you know how things go when you look at numbers. I would encourage people to try to think about what their own numbers may be. And you could say that your number is only 20%, or you could say, I think my number is 60%. But I think we can all agree that our polyp recurrence rate, fortunately, is not 100%, right? Thank goodness we do get some people across the line with complete surgery and good medical management. But I don't think there's anybody that would claim that their polyp recurrence rate is 0. So the concept here is that there's some subset of patients with CRS with NP that we're failing, if you will, that have recurrence or persistent disease. And then what do you do with that patient, okay? What do you do, right? So this is an example of a type of patient. It wasn't an actual patient in the clinical trials, but a type of patient. This is a patient that comes back to see you because she has symptoms coming back 9 months after she had surgery. And nasal congestion, fatigue, loss of sense of smell. We know this as the folks listening to our patients. I make this more personal. What do you do if this patient is your patient? You did the surgery 9 months ago. So it wasn't done by the person down the street who's trying to cure cancer with a balloon. This person had good surgery that you did, okay? And this is sad but true. It happens to all of us, like it or not, okay? So a little bit about the science, okay? At least within the States, 80% of patients with CRS with NP have it driven by so-called type 2 inflammation. And I have to say myself, as a practicing physician who's, let's just say that the scientist in me is atrophied, didn't necessarily understand why this is important, okay? But I think it becomes more important going forward to know the underlying mechanism, particularly as we're learning about more of what's going on with type 2 inflammation, but more about additional tools that might impact this process. So I do believe it becomes more important going forward, okay? But basically we're looking at a situation where we have interaction between the outside world, okay, and us. In the outside world, there's irritants, there's triggers, so here they're listed, allergens, pathogens. I think there can be others as well, right? Chemical irritants, strong odorants, smoke. So I don't think it's just limited to allergens and pathogens. But what separates us from the outside world is the epithelium. In the case here, nasal mucosa. That's the barrier between us and the outside world. So we get barrier dysfunction, and we have an innate immune response and an adaptive immune response, and we get a vicious cycle where it escalates with the cascade of the symptoms here listed. Greater disease severity, polyp recurrence, olfactory dysfunction in terms of alteration of sense of smell, and we know the overlap with other atopic diseases, and again, the objective markers of inflammation, okay? So here, I think the most important thing on the slide that I'm going to say is the exact mechanism of nasal polyposis is not fully elucidated. We don't know for sure, okay? And I'm not here claiming to know myself either. But going over this, we do know for sure that IL-4 and IL-13 signaling through the IL-4 receptor alpha subunit play a role with this, okay? So while you're looking over this, I highlighted epithelial barrier dysfunction, the immune impact in terms of cells and chemical messengers of inflammation in nasal polyposis. One thing I want to point out is this, okay? Thank goodness for Regeneron and Sanofi and the other industry partners that we have that are out there coming up with tools to help us with patients. And from this presentation, we could think brilliant people figured out that blocking the IL-4 receptor alpha subunit was the perfect target, okay? But I'm a bit simplistic about it. I think about this like a circuit board, and it's like flicking the switches, and you're saying to your spouse, did that turn off the bedroom lights or the bathroom lights, right? And if they're not labeled, you don't know until you start flicking switches, okay? And now we're on a stage where we have different tools to block these different messengers to see what happens, okay? So we know that IL-4 and IL-13 signaling play a role. We know that other cytokines play a role as well. What is their impact going to be on different disease states? We don't know until some of these clinical trials get done, and you're going to learn about more about that in sessions to come this afternoon, okay? But we know IL-4 and IL-13 for sure play a role with nasal polyposis, okay? And this is a illustration or graphic of how blocking that receptor can stop signaling from both IL-4 and IL-13. So if these play a role with this cascade and we block that, it should have impact. It should have impact. So that's the mechanism of action, if you will, okay? All right? So here, looking at inflammatory markers, okay? And I was talking to Eugene's fellow about this a little bit, okay? This is a window in the future, okay? Right now, we see objective evidence of impact with total serum IgE dropping 65% over a year and other markers of inflammation, okay? So I would guess there's not that many people here with tons of experience looking at ECP or Etaxin-3 or TARC or periostin or any of these other ones that are out there. But these objective measures of inflammation clearly drop in people that are on therapy. What does this mean yet? We don't know for sure, okay? We don't know for sure, but I think this is a window into the future. And are we going to have a time frame in the future where we can have targeted therapies? We can look at some of these and establish a profile who may or may not respond. So we know these markers decrease. This is a bit of a window into the future. But again, you do not need to check these, okay? I will say as an aside, I started paying a lot more attention to these data points, even though it's not required. Many of their patients are going to have a diff. It's very, very interesting to take a look and see what their eosinophil count is up front. From allergy work, many of them will have a serum IG. I've started to look at that a bit more and think about how it might help me to stratify a patient or guess, is this person really going to respond to one intervention or another? So not required, but something that's interesting to look at, okay? All right. Any questions? That was the science, okay? Any questions about mechanism of action? Okay, good. Okay, so I don't want to beat people up with the study, but this is the clinical program. Okay, I was lucky enough to be in 52. Okay, so and right now thousands of people were treated with this agent before the clinical trials even opened within ENT, let alone thousands and thousands more since it's commercially available for AD and asthma and nasal polyposis. So this drug may be newer to us, but it is not a new drug, okay, right? So in 24 and 52, you can see the inclusion criteria. Right now, folks can read this here, but things I'm going to point out, this was not sinusitis light, okay? This is not sinusitis light. Mean duration of symptoms or of diagnosis, 11 years, okay? All adults with prior surgery or prior treatment with steroids or intolerant and able to take systemic steroids, and this is all with polyposis. This is all with no CRS without nasal polyposis. This is all with polyposis, okay? Vast majority of people had one or more surgeries, average of 2. Vast majority treated steroids in the preceding 2 years. So again, not sinusitis light. If you practice for some time, you're going to have some of these people in your practice, okay? Because maybe you didn't cure them, or maybe the luminary at the academic center didn't cure them, but there's plenty of people like this that we don't cure with surgery and our other disease management tools, okay? So study design for 24 and 52, just an overview here. Both arms, similar, it's just some differences in length of therapy. So background therapy of mometasone BID, okay? It allowed rescue with steroid or nasal polyposis if needed, okay? So that was the same for both arms. In 24, 2 arms, one arm on therapy, as simple as it comes, 300 milligrams biweekly, straight up, the other on placebo, and then off therapy for the next 24 weeks. 52, same 2 arms on therapy the whole time, placebo, and then the middle arm on therapy every 2 weeks, and then decreasing frequency to every 4 weeks to see how patients might do with change in dose regimen, okay? All right, so the endpoints you would expect, nasal polyp score, nasal congestion score, upsit for sense of smell, SNOT 22 for quality of life, Lund-Mackay for CT burden, and in 52 looking the same thing with different time points, okay? Also looked at how many patients needed steroid or needed surgery. I lump these together as the interventions that your patients might wish to avoid, okay? So that was the design. You can look at these different measures here, okay, and I think it's important. For many of us, if we're not in research or doing different things, how important is it to describe your patient's nasal congestion in a particular way, or polyp grade in a particular way? And we all know it's quite subjective. You know, what does it mean when someone has severe polyposis, okay? So it gets easy to say, oh, I don't really need to know about these scores or things. But I would encourage you, if you can, to get familiar with them, because they're useful tools to convey to others. If you want to take good care of your patients and you want to try to get them on dupilumab as an intervention, these are information points that are necessary to be able to convey to others in a standardized fashion to help you get your patients on a therapy that you might want them to get started on. So in brief, nasal congestion score, 0 is none, 1 is mild, 2 is moderate, 3 is severe. So it's pretty straightforward. So if your patient is moderate nasal congestion, that's a 2, okay? If it's severe, that's a 3. So for my team, instead of saying mild, moderate, severe, I'll just assign a number because then it's just easier, okay? So all the patients here had moderate to severe congestion. Polyp grade, I've been in rooms with esteemed rhinologists where they're arguing over it, okay? But at its simplest, it's 4 per side, okay? So total score is 8. 4 is complete nasal obstruction. 3 is below the inferior border of inferior turbinate or medial to middle turbinate, okay? And I think that's an important OR. 2 is below the inferior border middle turbinate, essentially out of the ethmoid, out of the middle meatus, and 1 is disease restricted to within the ethmoid cavity or within the middle meatus, okay? So that's the grading score. So here for the study, patients had a grade of 5.8 or 6.1, so pretty severe advanced disease. In its simplest form, if you do nasal, if you look with it, you do anterior rhinoscopy, you look at the speculum. If you see nasal polyps, it's at least a 2 on that side because it's extending beyond, you can see it in the nasal cavity. Frankly, if you see it touching the septum, and there's debate here, okay, but if you see it touching the grading score is important to know, and there's a great resource, type 2 inflammation, that has images and things to look over if you want to get more familiar with it. UPSA score is sense of smell, okay? This is consistent with no sense of smell whatsoever. SNOT 22, big impact on quality of life. And CT burden, let's just say these people had significant disease, okay? Right? So here, not surprisingly, problem children, okay? If you don't know where to start, you're not sure this fits in your practice, you have questions or reservations, I might encourage you, this particular population of patients with nasal polyposis who've NSAID exacerbated respiratory disease, the so-called problem children, these are folks that have a difficult disease burden that's hard to get a hold of. I think that aspirin desensitization has a role. I've seen aspirin desensitization be very, very effective. I also don't have tons of patients who can get access to it. I also have tons of patients who can maintain it. So I'm not saying that doesn't have a role for that. But folks in this situation are really, really tough. And maybe a patient type you think about if you're looking to say, hey, I want to gain experience with a medication, this is a group that you could look at. And a lot of them were in the study, okay? Comorbid asthma, and again, vast majority of people with atopic disease, so not surprising, okay? For fun, I measure these measures. Look at the disease burden of these folks in terms of eosinophils, okay? And IG, so definitely high. Don't need to know them to get them on therapy, but as a marker of disease burden, okay? Right? So let's circle back to that real person, and she fits the bill. 43 years young, SNOT 22 score 49, moderate nasal congestion. Her polyps get out of the middle meatus, below middle turbinate on one side, and near the middle turbinate on the other side, so she's a polyp score of 5, okay? So she's an example, and she's doing the right stuff, okay? Everybody here, what about this one? Is this enough, okay? Is this enough? Steroids the devil that we know, right? And it works, it's just the side effects and the concern, okay? So right now, when the studies were done, you could look at this. This is my individual practice. I don't view INCS, fluticasone, mometasone, I don't view that as standard of care anymore, at least in my practice. I'm looking at as much steroid as I can get there safely. So at least in my practice, I want my patients on mometasone rinses, or I want them on fluticasone with an exhalational delivery system. I'm trying to get as much steroid as I can get there safely, okay? But at least at this point in time in studies, this was standard of care. She said 3 bursts of steroids over the last year. How much is that, okay? How much is that? Is that dangerous? Is that worrisome? We don't think about it because there's these episodes of intervention. And our patients can respond to them and be very, very happy. But for most of us, everybody has their own particular taper, if they will, okay? But the odds ratio of increased risk lifetime of osteoporosis doubles after 3 to 4 typical bursts of oral corticosteroid. So this gal alone, depending upon the taper, she could be at double lifetime risk of osteoporosis from just those tapers. So it's not as innocuous as we might think, just as a reminder, okay, right? So the results, okay, and again, to summarize, there's studies, but what do your patients want, okay? Because that's what we're dealing with. We're dealing with people. They want to breathe, they want to smell, and they want to do so without dangerous or disruptive interventions, okay? And here's the good study design. Improve sense of smell, polyp size and congestion, and reduce needs for steroids and surgery, okay? So this is the primary key and secondary endpoints, all of which were met with a ridiculous p-value here, okay? So there's the study, but this is what your patients are actually looking for, okay? All right, so here, looking at nasal congestion, a reminder, change in 1.34, okay, is going from severe to mild or moderate to none. It's a 3-point scale. Okay? Not only is it a quick change, not only is it a change 24 weeks, it's really, really fast. Okay? So here, if you're looking at biweekly dosing, this is sampling, that's 4 weeks, 2 doses, and this is therapy. They're just on therapy and they have significant improvement in nasal congestion score, okay? So 59% improvement overall at week 24, okay? Placebo group, okay? Right now, the placebo group had some impact, and I would say a couple of things. Number one, there's placebo effect, okay? But we know the refill and compliance rate with intranasal corticosteroids, old data from back in the day, Flonase refill rate was 2%, okay? So in the context of a clinical trial, patients are more compliant with medical management, so not surprised that we see some impact in the placebo group. People will point this out here. Yes, stopping therapy after only 6 months or 24 weeks, you saw some creep in terms of symptoms. People extrapolate this to say, hey, people are going to have to be on this medication for forever. But individually, I don't think that this says that. I don't think we can say that yet. And I would put this in front of all of us. We know that we cure a majority, well, I shouldn't say cure. We know we render a majority of patients polyp-free with thorough surgery and ongoing steroid, right? So let's say you think your recurrence rate is 40%, like the slide said. Then in 60% of people, you get polyp-free, albeit with ongoing topical steroid. If a singular physical intervention like surgery, coupled with ongoing medical management in a way that we're all comfortable with, can render patients polyp-free, I believe that we're going to see some people that using this tool similarly we might be able to get and keep polyp-free. We shall see, and I want to encourage those who are perhaps more academic to take a closer look at that. But again, can't say for sure whether they're going to have to be on it or not, but we see some rebound off therapy, okay? So here, what about polyp grade? Again, no one comes in and says they have a score of 7 or whatever, but you get the idea here. Polyp change minus 1.71, okay? So at 24 weeks, 2.24 at 52 weeks, okay? You could look at these pictures here and say, that's not terribly impressive. But I would remind all of us that this is in the setting of no other intervention besides mometasone BID, okay? And I think it's a really important point here. None of these interventions are standalones. They are in the terms of a clinical trial. But do you always operate and never use topical steroid? No, of course not. Do you always operate and not use oral steroid? If needed, some do, some don't. Could you have someone in your clinical practice on treatment dupilumab and still go there and do debridement? Absolutely, okay? So I have to tell you, for me in my practice, if I have a rigid endoscope in here to get a picture like this in a patient who's back for follow-up, I have a very low threshold to clean that up a little bit, okay? To quote David Conley, grabbing that polyp is getting rid of an IL-4, IL-13 factory, okay? So you're removing something that plays a role with the inflammatory process. You're going to allow better access. If you're using irrigation or anything, you're going to have better access. You may improve their congestion. So I have to say, even though these pictures you can look at, oh, they're not impressive. Let's remember it's with nothing else, and nothing stops you from house cleaning that up if you wish. They had patients in the clinical trials with more impressive images than this. Talked about my own practice, I have 6 complete responders. I give them credit for not having a picture up of a patient like that, because not everybody responds to that degree, okay? But again, one example of response. If there's one thing you take away, if there's one thing, it's this one, okay? How was the lunch? What did they serve you all? Sandwich, anything good? Whether it tasted badly or poorly, you wouldn't be able to say if you couldn't taste, right? And we all know, okay, salt, sour, sweet, bitter, all sense of smell, right? Okay? So here, if there's any one thing, this is what I think is really, really impactful, okay? Rapid and sustained improvement in sense of smell, okay? While patients on placebo worsen, okay? So the UPSID is a flawed test, okay? It's a good test. It's validated a lot. It's a good test, but it's a smell identification test. Again, I think you're going to have some sessions. I think Zara's talking more about olfaction and some other things. It's not a threshold test, right? So this would be like doing a hearing test saying, is that a dog? Is that a cat? So, this is ID. It's not threshold, okay? But nonetheless, it's a validated test. And so looking at it, here, 18 or less is complete loss of sense of smell anosmia. And you remember from before, most of the people in the study, they're starting out from baseline, okay, of 13 or 14, right? So these people, 2 weeks, that's the first dose, okay? That's the first dose. That's a sample, okay? Within 4 weeks, if you look at that, you're looking at greater than an 8-point change, okay? So with a singular dose, you're seeing a change in 6 of the upset. So 67% improvement seen virtually right away to an overall peak here of about a difference of 10 at 24 weeks. So think about that. That's going from no sense of smell up to if you're 18 and going to 20 to moderate microscopy, or severe, potentially up to normal, if you will. So this is massively impactful, okay? So impactful in my own experience that I will not sample a patient with this intervention because I think it's rude, if you will, to have them have impact on their symptoms if they're in a situation where but it could occur where they don't have access to the therapy. So this is just my management approach in my practice. If I have a patient, after discussion of different management options, who elects for this as a therapeutic approach, I will have my team go through the process of making sure they have coverage for it first before sampling. I will have them come in the office to get their first dose in the office. I think it's responsible, okay? It's an injection. I don't have anybody in my patient who's not self-injecting, but I think it's responsible to have oversight and supervision and medical guidance of that. And what if they're the person that did have a hypersensitivity response? So I want them in my office to do that. So they'll come in, we'll give them that dose, they'll stick around, we'll make sure they're fine, and they have the second sample. So the sample is one whole pack, so that's 4 weeks of therapy, two doses. This has been so impactful in my practice that I've gone to that because it's not fair, okay? And again, if you see this impact, we always joke around, patients will complain, but you're good patients, they'll let you know when they're happy too. So to me, this is a really, really big piece that I think is important to know and remember, if anything we covered. SNOT 22, huge impact too, okay? More than half the questions in the SNOT 22 are not focused on nasal symptoms. Do you feel well rested? Do you feel productive, okay? What's the quality of your sleep? More than half the questions in SNOT 22 are not on no symptoms. MCID on SNOT 22 is a difference of 9. You're seeing within 4 weeks, 2 doses, double the mean clinically important difference on therapy. So these folks have a big, big change, okay? I'm sharing my own experience. I have a patients come in, who puts down a 3 on the SNOT 22? Like, we're all American, there's a pandemic, it's busy. Like, who puts down a 3 on that score? But again, patients will come and they're telling you what they think, how they're feeling, how they're doing. But again, overall, you're seeing a big change here in SNOT 22, 59%, okay? So quite impactful, okay? The things that patients want to avoid, I'm going to go in reverse. 74% of fewer patients require systemic steroids, 75% fewer courses, and 76% of your patients required surgery or systemic steroids, okay? So the interventions they may wish to avoid from the cost perspective, per se, in terms of life disruption, in terms of potential for side effects or otherwise, you're seeing huge impact here, okay? All right, one example, CT scan, all right? We operate on patients, not films, but as a metric that was seen as well in terms of change in Lund-Mackay scoring. Again, you could look at this and say it's not terribly impressive, but let's remember this is just with medical therapy, no other intervention, okay, right? So circling back to safety piece, okay, listed here for Dupixent versus placebo, injection site reaction, we mentioned these, okay? I think some things on injection site reaction to think about. If it happens to placebo as well, there's some common sense things that we'll go over in the next slide or two, but they're listed here. Someone asked the question about the conjunctivitis earlier, but here, treatment discontinuations due to adverse events. On placebo, 5%, on therapy, 2%. So you're much more likely to plow through some potential adverse events if you're having the desired or therapeutic effect, okay? Okay, getting to the practice. So that's all the study, and you're going to. I think you have an overview of some of the different studies that are out there looking at biologics. The practical pieces. Okay, 2 options. Right now, your patients can self-administer at home with medical direction. Okay, once they're educated on that, which is quite straightforward, or they could come in for injection, and this is super simple. 18 and older. 300 milligrams biweekly, okay? So it's the same dose for everybody who's 18 and older. No weight, no PFTs, well, we're the ENTs, no eosinophil counts, nothing. Adults 18 and older with nasopolposis with symptoms in spite of appropriate maintenance therapy, okay? So right now it comes as either, well, instructions for use, well, here I'll show you. It comes either pre-filled syringe or pre-filled pen. I'm not a switcher. They first have the syringe come out, and not everybody loves needles, okay, so now they have a pen. Some is messaging, but the pen is nice. I call it an applicator. Since the pen came out, all my patients are on the pen, although I didn't switch people from the syringe. Both are available. Right now, I'm going to tease parts of the country. The only time I know of colleagues having patients come in to get dupilumab is if they're actively receiving allergy shots for desensitization and they're there anyway. It makes sense. They're in your office anyway. That's fine. And in New York City proper, patients will come in for injections. I'll say that. And I think it may be, no, doc, that's your job, or it may be an intention thing. But those are the only two scenarios I've come across where patients might choose to come for injections. Look, particularly in the setting of COVID, the ability of your patient to self-administer therapy was a really, really nice thing, okay? So here, read the IFU. In terms of injection site things, rotate the site, okay? Kind of common sense, okay? One pearl, if they miss a dose and it's within 7 days, they can take it and continue the schedule. If it's beyond 7 days, they can wait to the next dose, okay? So one tip or pearl. I find, what enhances compliance? Something working, okay? So individually in my practice, I haven't had a lot of difficulty or concern with compliance. For fun, I will point out that my patients have stratified in a couple groups. This is just my experience. I have a group that knows that they're coming up to the 2-week mark. So, maybe a patient with challenging AERD, they know it works. They know when they're getting closer to the two-week mark. I have some of those patients who know. I have other patients who have no idea whatsoever that they're approaching the two-week mark, which makes me start to think, do we evolve to other dosing regimens? On label, it's every other week, but I think about that, okay? All right, so it's refrigerated, okay? So, you want to bother a kid, put cold eardrops in, right, okay? You want to have some injection site reaction, inject something at 20 degrees. It's not going to feel so great, right? So I think rotating sites, making sure it warms up is helpful. It's fine at 2 weeks. It doesn't have preservative, okay? But it's fine for 2 weeks. So that sample, our patients, once it's out, we'll just say, look, leave it out. It's good for 2 weeks, inject then. If patients are home injecting, I'll just say take it out the night before, right? Just so it's room temperature. Common sense is common sense. If it looks spoiled, maybe it is. I'm pretty sure your industry partner will help out if need be, if there's a question about any dose being spoiled. Or not good. So if you see precipitate or it's severely discolored, if there's anything remaining, we should get rid of it. As I said, it comes 2 prefilled syringes or prefilled pens. Super, super easy, okay? These things here, there's all these steps along the way. Is this safe? Does it work, right? Is it FDA approved? Do providers cover it? Can your patients self-inject, okay? These are all barriers along the way. And if we prescribe it, because we talked to them about it, we think it's going to work, but they can't get access to it or they can't use it, it doesn't do any good. So I want to give Regeneron and Sanofi credit for having the programs in place. There's nursing support. Well, if you can have a telehealth visit, you can certainly have more nursing support for injections if need be. Coverage support. They have field access specialists. So this is really, really important. Rely upon them. That's part of their job, okay? And the patient access support from the cost perspective. All these programs are there, and we've relied upon it heavily. Biologics are a newer thing for us on ENTN, right? All these things that are out there, buy and bill, biologics, what do? Okay? So we can say it's easier, I'm going to send all these patients to my allergist. But to me, that's like saying, oh, this patient has an infection. I'm just going to go send them to ID, okay? That might be the case if antibiotics were fat or there's one of them, but that's not the case with this, okay? Biologics, you're going to learn, if you don't know already, we've got tons of other choices coming, some that are approved, some in the pipeline. So I don't think we can say, hey, we're just going to offload this on someone else. Another thing, part of our payment is non-economic, right? Okay, part of our payment is feeling good about helping our patients and making a difference. I don't want to give this away, okay? I told you about my mechanism where our patients come in for the first shot. One of my nurse practitioners loves being the person who helps them with that first dose. Why? Because she wants to be involved in a process where she knows patients are very likely to do really, really well and be happy. So she wants to be part of that process because these patients can do really, really well, okay? So for that reason alone, I want the upside of seeing, I want to get that hard patient better. I don't want to give that to the allergist. So if our interventions, good surgery, medical management, if it hasn't worked, we get them started on therapy and they get better, I want to be the person that's there to enjoy that, okay? And what about what we do in terms of follow-up and so on? If a patient's doing great, is it wrong or is it better to say, look, you're doing great. I want to see you to make sure from the maintenance perspective things are well. These folks want to come back and see you. They want to say, hey, doc, are they there? Are they gone? They want to tell you they're happy. They want to tell you you're doing great. There's no rules here. What I do for follow-up, if I have a patient's doing well, I'll have them come back either every 6 months or once a year. I do that because I want to monitor their disease progression, and we're still learning. I want to do that in case we get into a fight with payers about did they respond or not, and so on. So when these folks come back, I get a congestion score, I get a SNOT 22, I get a polyp grade, I get it documented, so if that ever came up, I have that information, okay? So a chance for a patient to come back and get seen, share how they're doing. Nasal endoscopy, debride if you need. Do what's right by taking care of the patients, but there's nothing wrong with having an established patient base that keeps coming back to see you for their care, okay? All right, so the cornerstones of therapy: sense of smell, 71% improvement, reduced polyp size and obstruction, 59% improvement in nasal congestion, and the polyp grade change we highlighted, and then reduction of big E's. These are the endpoints of the study. These are what your patients are looking for, and are supported in the context of at least a study. An anesthesiology colleague of mine always says to me, Dave, show me the study that shows that parachutes work, right? Clinical trials have to be done to get FDA approval to prove safety and efficacy. They have to be done. We all know that, okay? But some things are common sense. You're not going to know how well this does or doesn't work unless you say to yourself, I recognize there could be a role for something like this in my practice, and I'm looking forward to everybody here getting their own experience with it, all right? Thank you. So I know I'm bumping up against limits. Eugene, we have, you're starting at 120. Do I have just 3 or 5 minutes? If there's any questions, is that fair? Any questions for the audience, please? Thank you.
What have you found is the average duration for which they have to take the medication? How long are you keeping them on it, or is it indefinite?
So that's a superb question. I'm really glad you asked, okay? So right now, by study, we don't have any information beyond what industry partners did to a certain point on therapy to say what happens when they're off or not, okay? So this is an honest discussion to be had. Are there patients that are going to have to be on therapy for forever? And I have to say, I suspect there are, okay? Are there patients that we think we can get off therapy? I'm quite certain the answer to that is, I'm sure there's going to be some as well, okay? But at this point, I cannot give you a book or study answer. What I can give you is information from my own experience, okay? So right now I have 6 complete responders, like polyps are gone, including 2 who are AERD, okay? I have 2 people who are non-responders, okay? So for balance, if type 2 inflammation is responsible for 80 to 85% of patients, not everybody's going to respond, okay? It's not all type 2, okay? So I do have 2. Now, just one word on that. There's no formal guidance, but from the Euphoria group, if you don't have a patient respond after 4 months of therapy, most would deem that to be a reasonable time point to say they're probably not, we gave it a college trial, okay? So for the patients that I have that are complete responders, I've asked each and every one of them, do you want to stop therapy, okay? And each and every one of them has laughed at me. Okay? Yeah, see you in 6 months, doc, okay? So I think it's a great question which I don't have an answer to. I am a value guy. By the way I was raised, okay, by my own personality, I don't like waste, okay? But I'm not in a situation myself where I feel I'm going to make that choice for my patient. So for the complete responders, I'll wait till a payer says we're not going to cover it anymore. Or a patient says, doc, I haven't been taking it for the last 6 months, okay? It's going to happen, okay? But I can't give you great information. So all my patients that are on it, that have responded, are still on it, recognizing that commercial availability has really been just getting to 2 years right now, okay? I was nudging Eugene's fellow in terms of some of the more academic colleagues we can have out there. There's work that needs to be done in that regard, looking at how does this work concurrently with surgery, for example. I'm fascinated by that piece, and hopefully we'll learn more about that in the years ahead. So just to answer your question directly, don't know. All mine that are on it are still on it. We'll see as more time goes by. Okay? All right? Please. Gotcha, sure. So I will preface this by saying, of course, I'm not a reimbursement specialist, okay? And our industry partners, they have field access specialists, okay? but I'm going to take this back and make it general, okay? If you look at any clinical trial, right, they're going to have inclusion criteria, which we went over to say this is a patient that might be appropriate for this study. Payers in general, not referring to dupilumab in particular, that's what they do. They're going to look back at whatever pivotal study was done for inclusion for patients, because if that's the study that proved people responded, and they're going to say, we want to see patients have those characteristics, okay? So regarding metrics, if this is FDA approved as add-on maintenance therapy for folks with nasal polyposis, with uncontrolled or inadequately managed symptoms in spite of maintenance therapy. The maintenance therapy, translation, intranasal corticosteroid, okay? You probably don't have a patient with nasal polyposis who's not on intranasal corticosteroid. Doesn't mean that they're complying, but we can't control what they do on a day-to-day basis, okay? So they have to be on intranasal corticosteroid because that's what the indication says, okay? They have to have inadequately controlled disease. How do you define that? What metrics did we go over here? Who's doing the upset every time? Who's necessarily doing the SNOT 22 every time? Asking nasal congestion takes 3 seconds. Is your nasal congestion mild, moderate, severe? Okay, say 5, okay? So moderate nasal congestion, okay? And then polyp grade, okay? So the things that you want for the study, and I have those other data points. I joke around, I never run on time, okay? So my staff, anybody who coming with nasal symptoms, will just give them the SNOT 22. It's super easy. It gives them something to do while they're waiting, and you have a data point that's useful. And you'll have patients come back even, they have sinusitis and nasal symptoms, and they've never been on steroid and saline irrigation. And they come back 6 weeks later and they say it didn't do a thing. And their SNOT 22 got better by 20 points. We're like, well, you're having a bad day before, or something's doing something. So I'll get those, but really nasal congestion score, polyp grade on steroids, those are the key components, okay? It's nice to know when their last surgery was. It's nice to know when their last course of oral steroids were. It's nice to know SNOT 22, but I find consistently what you need to get it in that regard. The baseline to meet criteria is congestion score, polyp grade, and the fact they're on nasal steroids. Is that what you were asking, Eugene? In terms of practical aspects. Again, and they're here to help. And that's why these things that seem esoteric, like polyp grade, that's the thing. We're worth looking over, because you'll have some on your staff, I call them the doers, right? People who are trying to get things covered. When my doc said the disease was severe, they want to hear 5. They want to hear 6. That's what they want to hear, per se. So those are important pieces. But the field access specialists are there to help with that, okay? All right? Other questions? Please. So this is the thing, okay? I think most of us didn't practice in an era, or, all right, from the asthma perspective, let's say, we've had a lot more tools to manage chronic disease for asthma than we did, say, 40 years ago. So our generation, folks in practice may not see people with avascular necrosis of the hip or some of these other things, okay? And the cataracts or the osteoporosis or the heart disease or the diabetes, these are chronic illnesses that it's hard to necessarily ascribe to the steroid that you prescribed, right, okay? But looking at numbers, as I said, once you join the 1 gram club, that's not that much, 1 gram, okay? So this is me, I do 40, 30, 20, 10 taper for 3 days as my sort of off-the-shelf steroid taper, more than a Medrol dose pack, but this is what I do, it's 12 days, okay? You know what? 3 of those doubles the odds ratio, 3 courses, lifetime, not 1 year, okay? So it's easy to do because, put them on a course of steroid, they get better, but it's having its impact. I'm not trying to convince my patients of that. I'm just really happy to offer them another choice, okay? So to me, I have I'll say mature practice. I've been in practice for 22 years now. I live in the shadow of giants. I'm 50 miles up the road from Penn. I tease the people that train me. I've got more failures from Kenny and Lanza and Boldra and Palmer and, because they went to Philly for surgery and they end up back in my practice, okay? And they're sticking with me not because I'm gifted, but because I'm in their hometown. Right? So what do you do with those folks that have had full house surgery and whatever, okay? So that case you're managing, but that person ought to know about this as an option, right? It's the whole concept of shared decision making. And all the barriers that we raise, it's a shot, it's difficult, all this is true. That person, I'll have some of those and I gnash my teeth because I have some people that I know, man, they do great on this. And they're like, nope, I'm fine. I have one guy in particular, he wants me to cut the grass every year. Doesn't want to go to the OR, doesn't like, I'm sitting there, plucking some polyps once a year, and it keeps the guy happy. And it kills me because I know I could get him better, but it's his nose, right? So I think that person would be really someone that'd be worth having a discussion with, I think you're, great question. If you're the one prescribing steroids, then I think there's I want to call it an obligation, but I think that's prudent. I think that's prudent. Because if you're, and I don't work in a legally paranoid fashion, but if you're doing something we know has a documented potential impact on that, I think at some point that becomes thoughtful. I do, Doc. I do, okay? Yeah, even for protective reasons, please.
If you have a patient with Sanford's triad, who looks like a great candidate for the medication, but they're very anti-vaccine, anti-COVID, are you going to green light them for Dixon or not?
I'm going to tell them that this is a choice, okay? Because we know there's the science and then the irrational part. I use that word on purpose. This is not a vaccine, right? This is a different therapy, right? So to let them know about it, if they don't want to do it, that's perfectly fine. And I joke, I care about value, and these interventions aren't free. But you know what's inexpensive? Inexpensive is breathing with your mouth open. Okay, and suffering, that's inexpensive, okay, right? So when we talk about, hey, look, you can always live with mesopolyposis. So I think that patient with that disease burden, right now, if they're anti-vaccine, that could have to be, the COVID and the government, the mandates and so on. This is a pharmacotherapy that's a choice for you. It's not a vaccine, it's not, so, we could lump it together, because the Regeneron's cocktail, the antibodies that specifically bind against COVID, it's no different than a monoclonal aimed at the IL-4 receptor alpha subunit. But it's hard to know where that patient in their mind views these interventions as all the same. So I would let them know about it as a therapy. This blocks messengers of information, highly effective for your process. They may not want to touch it, and that's okay. But I think you did your responsible thing to let them know about it as an option, okay, all right?
Do you think it puts them at higher risk of a bad outcome should they get sick with COVID?
So that's why they added that vaccine piece. We don't know, okay? We can't say because there's no study, there's no data. By the mechanism here, if you look at the immune function, generating immune response to a virus, how much does IL-4 and IL-13 play a role with that? I have to be honest, I'm not an immunologist, I can't claim to have much information, but to me, I'm not batting an eye. Do you see what I'm saying, okay? So in that course of time frame, again, we saw no significant impact. There's only the message, be careful about helminthic infection. So that's why I think they worded it carefully. Carry on with age-appropriate vaccinations, that's important, right? So would I necessarily, me individually, I would tell my patients we don't have information, but I'm not worried about it. Would I necessarily do them the same day? No. Knowing that you get some side effects from either one of these interventions, better to separate, for a couple of, fine, but I can't say I individually have any worry in that regard, all right? Other questions, other thoughts? Great, well, thank you for your time and attention, gang. I appreciate it. You enjoy the rest of the conference. Everybody be well. It is nice to see colleagues in person, so good to see you guys. Thank you.
Thank you again for all of your attention. I know it's a long day, but I want everybody to get up and stretch and get the blood flowing in your limbs. Make sure that your chair is free and open as well too, because this afternoon session is going to be quick. It's going to be fast. It's going to be chock full of information. So we're very, very excited to get this going for you. Actually, Chris, do you have the adapter? we'll give you about 5 minutes just to get some drinks, to freshen up, to get a little bit of sunshine out there. For those with seasonal affectiveness disorder, for sure, get some sunlight, and we will start promptly at 1:20. I'll give an introduction to our esteemed guest, Dr. Zara Patel. So see you in about 5 minutes. Did you get some lunch?
I ate, yeah, we had ordered pizza last night, and I just ate leftover pizza this time.
Where'd you guys get pizza from?
Just like room service.
Oh, okay.
Which I love to do. No, I honestly thought usually, I have any of my notes from the last week, I was in you'll also be something mom on the shoulder, all the way, yeah. So I was texting her right before I left, and I was trying to anyway. Yeah, exactly. So I was happy to just peace out in my room while I managed all this stuff.
How's Luna doing?
Oh, she's great. So Andre and her out hiking, exploring the area, and then they'll come. If it's okay, he'll come to the reception.
Yeah, absolutely. And then come to dinner.
Yeah.
Good. Okay.
Okay. I have. What is the thing that what is the connector?
So this is a USB-C, so that should connect straight into yours.
Into it?
Yeah. So just pop your computer onto here.
Hey, how are you, Chris? Good to see you.
You and Andre got in okay?
Yes. Cool. Yes. I was just telling him it was there's all this stuff I've been trying to coordinate and manage. So
Yeah.
I was glad to just chill in the room.
No, for sure. I mean, this is the first time you've had a morning to yourself probably for a long time.
Yes.
Or no one could bother you at work.
Okay, cool.
She just had a sign in nasal melanoma as well too. Chris
Did
is
you just have one?
Are
you the melanoma king?
He is a melanoma king.
Oh yeah?
Yeah, it's insane.
For our population, I don't know how we have so many.
He's not doing my slideshow.
Yeah, so if you have notes, when you do slideshow, you should be able to see your notes here as well
There we
too.
go. It just took a minute.
Perfect.
I don't have notes.
Okay. Awesome.
I just go by the seat of my pants. Okay, so I will just end that and...
No, you know what? You can leave it on.
Leave it on?
Yeah.
Okay.
All I have is a beautiful picture of you, and they have you in front here, so that's all we need.
Okay.
So
Should I put it back on the thing or no?
Yeah. What I'll do is do slideshow, and I'll play from start. So you can advance using this.
Okay.
We also have a laser pointer as well.
Okay. You're PA and IT.
Yeah, exactly.
All wrapped in one.
All right. So,
Amazing.
well, yeah, so here's the laser pointer. It's just that little guy
Okay,
right
great.
there. There's going to be a clock that they hold up back there.
Who's they? Is it Eugene?
No, it's Sonia.
And I'll also put your keys to your car, and I'll
we really need a countdown clock. But anyways, there'll be little warning timers back there. We'll start to show it when it's around 5 minutes or so.
Okay.
Right.
Hopefully I will stick to it.
Do you need it more frequently than that?
No.
Okay, cool. All right, sounds good.
Y'all
Before
distract.
it was, I think there was a lady that had a picture of a
Like a half of a manila envelope
That
or
is
something.
too funny.
Yeah, so it's a little better now.
This,
Yeah.
and then I should just use this, or I should just use this?
No,
to
because
use that one.
Yeah. I mean, we could plug that in and
No, it's fine.
yeah, but it's probably just easier to navigate with that.
Sounds good.
A little tip about the microphone.
Yes.
You don't need to be your face doesn't need to be smashed into it.
Okay.
It's pretty sensitive. So you can say maybe like a hand, like a
About the
fist
way.
wave. Yeah.
Shall I test it?
Yeah.
Hello.
Yeah.
Hello. Is that loud enough or not? Hello. I have to really lean in.
No,
Maybe I'll
I
project one.
I also control it over there.
Oh,
Yeah,
okay.
you can speak louder too. But if you get your mouth really close to it, your lips when you do the
Yeah.
it'll start
Especially
to
with our masks. We all sound like crazy people.
Yeah, and then I also control the volume over there.
Okay.
So
he controls everything.
You have the control.
Can they give the shock valve where people can
oh yeah. I wish. Yeah, they should be here soon. All right. Cool.
Well, good afternoon, everybody. as we had mentioned, we are going to start the rhinology portion of ENT in the Desert. And again, thank you for all of us. Thank you for all of you guys for attending. I hope you find this extremely educational. I have the honor of introducing my good friend, Dr. Zara Patel from Stanford. She is fantastic both to work with as a colleague, as a researcher, as well as just a good friend who was fortunate enough to kind of accept our invitation. So thank you so much, Zara. As an introduction, Zara is an associate professor at Stanford. She is the head of the rhinology and skull base, or specifically the endoscopic skull base section within the Division of Rhinology. And more importantly, she's really interested in olfaction. So I remember coming to one of your talks, it was probably about 6 or 7 years ago. And to hear somebody and actually be enthused about somebody talking about olfaction is a gift. Because as we know, it's one of our forgotten senses, one that doesn't get that much attention, but she just did a phenomenal job. And I think, in the past 2 years, we've learned a lot more about olfaction. It's really come into our general focus. And more importantly, as really a healthcare worker, she's done a phenomenal job of really spreading a informative and positive message. If you don't know yet, she's very active on social media, on LinkedIn, on all sorts of platforms. And she's really helped kind of understand this challenging disease to both the lay audience as well as to otolaryngologists like myself. So thank you for doing that. And without further ado, let's hear you talk about olfactory loss for the otolaryngologist.
Thank you so much, Eugene. That was a very kind introduction, and I'm so happy to be here with all of you. I hope you've been having a wonderful time so far. And as Eugene mentioned, I have been interested in smell loss for a really long time before it became the sexy, cool thing to do research in and talk about in otolaryngology over the last 2 years. These are my disclosures. None of them are relevant to this talk. But as you all know, over the last 2 years, everyone is interested now in loss of smell and taste because of this pandemic and the fact that, very early on, I started hearing from my colleagues in Italy, Iran, people who knew that I did research in smell loss and had an interest in this. Before we even had any sign of a pandemic in the US, I was hearing from them that suddenly all the ENTs in Umbria in Italy had lost their smell. And so that gave me this really early sign, and of course having thought about smell loss and had treated post-viral loss for so long before that, it wasn't that surprising to me that COVID-19 could also cause something like that. And so we were able to ring the alarm, not just about loss of smell and taste related to COVID, but also for the increased danger to our subspecialty because we're working in and around the nose all the time. And I became a consultant for the CDC. We were able to push for this to be added to the screening symptoms, and they finally did that in April. So I think that, just having thought about this smell for a really long time, this sense for a really long time, helped us immensely deal with this interesting finding in the pandemic. But as Eugene mentioned, I have been excited about it for so long because, in addition to these very basic things that we know, it helps protect us against danger by smelling smoke and toxic fumes. It helps us to avoid eating bad food if it's gone bad. But really, the sense of smell is integral. It is an inherent component of all of our social interactions. I could give you a whole talk for an hour or two about all the different ways in which we relate to each other simply based on our sense of smell, whether that's on a conscious level or a subconscious level. But just briefly, I'll give you some highlights. You might think that you have chosen your sexual partners and life partners based on the way they look, on the way they interact with you, but really, if you take all that apart and sort of put it to the side, the similarity or difference of someone's HLA complex is what a woman smells, and that is how she chooses her sexual partners and eventual life partners, regardless of everything else that you think about a person. And so just the way that we smell to each other has made, your lives what it is. The way that we judge each other versus first impressions, we know things like the taller someone is, the more symmetric their face, these things give us our first impressions, but also the way that they smell to you. not consciously, but subconsciously. We can tell if someone is smelling anxious. We can tell if someone is smelling confident. All of these things relate to the way that we, interact with each other. And of course, if you think about the way that we interact with friends, with family, even with strangers, as you guys are doing right now, it's almost always over some sort of food and drink. And that, if you can imagine losing the ability to interact socially with each other across all societies and cultures, that's really where the impact of smell loss becomes much more distinct. So, these are all the reasons that I think smell loss is important, but when you actually ask people who have lost their sense of smell about their quality of life, they talk about things like fear for personal safety, paranoia and anxiety about their hygiene in social situations, obviously the major impact on taste and ability to enjoy food, social withdrawal because of that interaction we have over food and drink, and that definitely always leads to depression because we are social animals as human beings. And mortality in anosmics is 3.8 times that of normosmics. So all of those things should draw your attention to this sense and make you, understand how really truly important it is. Also, going on to the last part of the last talk, smell is really one of the most important things to people when they're considering interventions. And you can see this is an article from 1999. I lost my pointer. From 1999, where they were talking about malpractice based on anosmia after nasal surgery. And even though that was sort of sounded the alarm back then, you can see in 2014, there was another sort of review of this, and otolaryngologists are the most frequently named defendants in negligence cases in anosmia. The majority are iatrogenic cases related to rhinologic procedures, and 35% of those cases had to do with inadequate informed consent. So I'll ask you all to think about it in your own minds. You don't have to raise your hands. But do you always mention anosmia as a possible risk when consenting for sinus or skull base surgery? If you don't, maybe you should consider doing so. So, there are some types of cases that it's not going to be possible to save someone's smell. This is someone who came in, and in spite of this huge tumor that's an esthesioneuroblastoma filling their nose, they had normal smell, surprisingly. And so this is a case where you can only make the patient worse, but you're going to have to do that to save their life. And so, when the counseling that goes into talking to a patient like this before you do it, you have to take some care. You have to not just tell them that this is going to happen after you've done the resection and reconstructed their skull base, but you also have to, or it's a good idea, to try and speak with them about how that's going to affect their quality of life, commiserate with them how impactful that's going to be on their quality of life, and really let them know that you're there for them after. Because to go through this whole big procedure and have something taken out, it definitely makes people feel great that they didn't die, but the quality of their life that they experience after, like so many of the other cancer surgeries that we do, we really need to start paying more attention to that. And I'll sort of skip through here. You can see that after resecting one or both olfactory bulbs and reconstructing this entire skull base, you're not going to have any sense go through to the skull base after that. Now, I'm just going to back up a little bit because we're going to focus now more on sort of sinonasal pathology, because that's what the majority of people in here probably do, sinus surgery. And, it seems pretty basic. There's a 2 by 10 centimeter square on either side of this high part of your septum in the back, and it covers the superior and middle turbinates and cribriform region. These neurons coalesce into approximately 50 macroscopically distinct bundles. They look like this if you ever raise up your septum enough to go see that. But I want you to consider that by the time you have seen this bundle, there are millions of other neurons that have come together to form that bundle. So keeping in mind that just preserving that part of the olfactory neuron is not going to be enough to save your sense of smell. And it can be confusing because although I just told you it's this 2 by 10 centimeter squared patch of epithelium, if you go online and actually look at anatomic depictions of what that is, it can range from just this little top part to maybe up on the superior turbinate, down onto the middle turbinate. It's very difficult for people to understand exactly what is involved and what they should preserve. And I think this is a really helpful study where they actually they took tissue from all these different parts of the nasal cavity and said how many people in this study have olfactory epithelium on this given structure. And what's really, probably most of you know that the superior turbinate definitely is going to have olfactory epithelium on it. You should definitely preserve that whenever you're doing surgery because otherwise you have a high risk of losing smell. But what's interesting is that actually over a third of patients on their middle turbinate also have olfactory epithelium, especially in this posterior portion here. And so, although, it used to be sort of de rigueur to take out the middle turbinate at the beginning of sinus surgery, certainly when I was training in residency, that's the way that I was trained to do it. Now, over the last decade, people know that they should preserve the middle turbinate if they can at all, but it's not always that straightforward because there's different things that can happen when you take nasal structure. For example, certainly it can alter directionality of airflow, cause a dry nasal environment. If you guys don't know, the odorant molecules that you breathe in have to dissolve into a mucus layer before they can actually attach to your olfactory receptor neurons. So if your nose is too dry, you're not going to be able to smell very well. And then, of course, loss of some amount of that epithelium, and the amount likely varies between individuals. But there's also been studies looking at what happens if you take the middle turbinate in sinus surgery. And as you can imagine, if the middle turbinate is degenerated with polypoid epithelium, that olfactory epithelium likely is not very functional. And so when you have this balance between removing inflamed tissue versus trying to preserve functional tissue, it really does seem that as long as you are only removing that deranged polypoid tissue, you are not going to decrease someone's sense of smell, even if it's on the middle turbinate. So these are just sort of more nuanced things to think about as you're thinking about whether to leave or take a structure. And I'm just going to show you, we're going to talk a lot more in the next talk about CRS with nasal polyps. And so I'm not going to go a lot into this, but I'm just going to show you this example of when you're taking down polyps up at the middle turbinate and olfactory cleft. Certainly, if it looks like that tissue is not going to be able to function. It's not going to smell. But you do have to be careful that you just take this back to a normal mucosal sort of baseline. You can certainly cause a CSF leak by being too aggressive at the cribriform by taking polyps down there. And you can also, cause other problems like scarring of the middle turbinate if you don't take enough of it up at the very top of your skull base. So definitely things to consider when you're removing the turbinate. Now, there's definitely a correlation of mucus inflammatory proteins and olfaction in CRS in general. And this was a really great article by Tim Smith and a lot of other authors who really looked at a whole host, over 20 different cytokines, chemokines, molecules like IL-5, IL-13, IgE, so on and so forth. And there is definitely a relationship between the concentration of all of these different molecules and things like opacification of the olfactory cleft and overall smelling test scores, whether that's the sniff and sticks type of test or UPSIT that was mentioned before. And interestingly, there's even more to that than just what's locally in your nose and at the olfactory cleft. This is an article that came out last year that showed in an animal model gut cytokines modulating olfaction through metabolic reprogramming of glia in the frontal lobe. So there's so much more to this, and there's so much room for research in this area. It gets me really excited when I read things like this because we don't even know the first thing, I think, right now about all the things that can modulate the sense of smell. So going into a little bit of surgery, now I'm just going to remind you guys, here's that cribriform. All those holes are where the olfactory nerves go up through the skull base to the olfactory bulb. You can see your anterior ethmoid arteries on either side. And then I want you to notice the relationship between the posterior table of your frontal sinus and this cribriform and all these olfactory neurons. Because when you're going up into your frontal sinus for frontal sinus surgery, whether that's a regular sinus surgery, a draft 2B or draft 3, this is something that you should keep in mind. I'll say that, you know, the patients that I see in my smell loss clinic who are coming because they've had their loss of smell from a prior sinus surgery, it's almost, I would say, 50% of the time from an extended frontal procedure where they lost their sense of smell. So definitely something to consider. And I'm talking about frontal sinus surgery tomorrow, so you're gonna see these videos again, but I'm gonna skip to the important part where we sort of look at, this is the part of the middle turbinate that I'm resecting to start my draft 2B and the part that I'm drilling to go over to the septum. I want you to notice that I preserved the entire middle turbinate below just that very top, I would say 5 millimeters to a centimeter of tissue there, because you don't need to remove that to actually get to the frontal sinus or bring the frontal sinus more medially. And so I'll talk more about that, you know, frontal sinus technique tomorrow, but preserving as much of that structure as you can is really key. Similarly with the draft 3, again, I'm just gonna skip through because I'll go over this more in detail and in depth. But as you're drilling, notice this big hump of tissue that I'm leaving in place down at the bottom and really taking care not to push on with my drill, because that's your cribriform, that's your olfactory epithelium. I leave a much larger mound, I think, than most other people in that area, because you don't need it. You don't need to take that. You have the entire anterior aspect that you can take, and so really preserving that structure at the back is key. That's that mound I'm talking about. All right. And then here's where I'm just going to show you a couple examples. This is a small little tumor, a malignancy that's at the very back of someone's nasal cavity, and we're resecting it. And you're going to see that there's a slight CSF leak. Now, I know some of you may not do tumor resection, you just do sinus surgery, but there is obviously always a risk of CSF leak when you're doing sinus surgery. And I want to use this example to show you that you don't always need a huge piece of tissue just to fix a tiny little leak like this. The nasal floor is a really nice place to harvest a thin, pliable, sort of very appropriate sized piece of mucosal lining that you can use as a free graft when you just have a very small leak. So if you ever run into that problem in your surgery, you don't have to do anything to touch or manipulate the olfactory epithelium area by raising a nasoseptal flap. For just a very small leak, you can just use a mucosal graft off the nasal floor there, and that, you know, heals in really nicely, a watertight seal. Now, sometimes you'll have a much larger leak. This is a tumor case that we did that's a cellar tumor. You can see it's going down all the way into clivus and even hanging into the nasopharynx a bit. And it's also extending laterally on both sides, so needing a transpterygoid approach bilaterally and then having a pretty large defect at the end. This is something that you do need to use a nasoseptal flap for. And I'm just going to show you, if you guys ever raise a nasoseptal flap, whether it's for a skull base repair or if it's just that you have a much larger leak that a mucosal graft will not suffice, the way in which you raise it can help preserve your olfactory epithelium. You see, I'm not going all the way up to the top of the nasal cavity until I reach that middle turbinate level. Once I'm to the middle turbinate, then you can go all the way up to the top of your nasal cavity and go all the way up to that very roof of your nasal cavity and bring that forward. But at the posterior aspect, you really should not be that high. As long as you preserve that olfactory epithelium when you're raising it this way, then you won't cause any loss of smell. That's all I need from that video. Okay, so now let's start talking a little bit about, you know, what if you do have a patient come in with loss of smell, then what do you do? If it's from surgery, skull-base surgery in particular, but as an extrapolation, if it's from sinus surgery, and you haven't disrupted the olfactory epithelium, it's just from an inflammatory response after surgery, which sometimes can be the case. This is an example of a randomized controlled trial that I ran looking at my skull-base surgery patient population. I ran this about 5-6 years ago, and at the time there was a lot of data coming out about omega-3, helping with nerve regeneration in other areas, things like spinal nerve injury, peripheral nerve crush injury, carpal tunnel syndrome, things like that. And it was showing a significant improvement in neural regeneration. So I wanted to look at whether or not this would help our skull-base surgery patients. And you can see that before, we were having almost, a quarter of patients with some amount of long-term loss. Now, this is not necessarily going to be apparent to you unless you ask your patients about it. They're happy for the other things they got out of surgery. Otherwise, their quality of life usually is much better after surgery, regardless if it's sinus or skull-base surgery. So they won't necessarily report this to you unless you ask them of it. And that's why there's such a wide range of the amount of loss you'll see after skull-base and sinus surgery in the literature. But you can see that after putting them on an omega-3, a very high-dose omega-3 supplement, this dropped precipitously. And so these patients were on this for the whole 6 months after surgery. And so there does seem to be a real benefit, at least in the regenerative process that happens right after a large inflammatory event. Because we know, because of the rhinologic fellowship-trained surgeons that were all the ones involved in this study, at a multi-institutional study, and preservation of the olfactory epithelium was paramount to all of the surgeons involved, and so nothing was taken directly. We suspect that this is much more likely because of the inflammatory effect. This also holds true because the individuals that were more likely to get olfactory loss were people with functional tumors, meaning acromegaly, Cushing's, people who had either much more friable inflamed mucosa or had to have a lot more manipulation of their septum, for example. And this helps them. Because of that, I do actually tell my COVID-19 patients, my other inflammatory smell loss patients about this, keeping in mind that's an extrapolation from another patient population. So now give me a raise of hands. How many people have heard of or use olfactory training in their practice? Excellent. So that is way different than just 2 years ago. I think probably about 10% of each audience I ever asked before 2 years ago had heard of olfactory training or was using that. So that's amazing that it has spread and people know about it. So just for everyone who hasn't, it's just a structured smelling protocol. It's as if your patient had a stroke, they couldn't move their arm, you would tell them to go do physical therapy and rehab that arm to get functionality back. It's the same thing with olfactory training. You're using a structured smelling protocol to rehab the olfactory system. We tend to start with these 4 different scents. They're in different categories of smell, and that's why we use them, because they'll stimulate different types of olfactory receptor neurons in the nose. There are a lot of different protocols out there. The one that I do use is twice a day, every day, for 6 months. It does take a really long time to regenerate nerve, which is what I tell my patients, and that's why I have them do that for that long. The background rationale is what we know about the olfactory system is that it is unique in all the other cranial nerves and that it does have this inherent regenerative capacity, and we just need to turn that capacity back on. And what we also now know, which we didn't know even just 5-10 years ago, is that the adult brain has plasticity to it. We used to think that the number of neurons that were in the brain was finite and that once you reached adulthood, they didn't grow new ones or didn't change their synaptic path, but now we know that's wrong. We can form new synaptic paths and connections throughout our lifetime, and that's what this is really utilizing. There are many, many studies, and the best thing about olfactory training is that it doesn't seem to matter what the etiology of your smell loss is. It seems to help people from all etiologies. This is some of the most convincing data that I saw when I first started reading about olfactory training that convinced me we were really doing something real. This is a functional MRI of a patient who had lost their sense of smell, and before olfactory training, this is their sort of connectivity, this disparate, chaotic array of connectivity. It doesn't seem to really correlate with anything in particular. After doing several weeks of olfactory training, you gave that same patient an odor in the MRI machine, and they had a really wonderful bright light up right at the entorhinal cortex where it's supposed to light up for olfaction. So we really are doing something real here. Now, just to kind of briefly go over, I did a randomized control trial after I learned about this just to make sure that You know, in Europe, when I first started learning about this, they were doing it in very controlled settings, very pure odorants, very controlled concentration of the odorants. And I knew that that wasn't really feasible for our practice here in the US and for just a busy rhinology practice. And so I have done this randomized controlled trial just proving that any essential oil out there, it just has to have a smell to it. So if your patients are spending, some of my patients will come in, they spent $500 on a pure rose oil. That is totally unnecessary. So just as long as something has a scent and they can bring it to their nose and practice with it, that's really all that matters here. Now, I did another randomized controlled trial looking at budesonide. Probably all of you are familiar with our use of budesonide, a topical steroid irrigation for treating chronic sinusitis, especially with nasal polyps, but even without. And we have seen so much efficacy in our inflammatory patients. And I started thinking, even in these patients who you look at their olfactory cleft and you don't see inflammation, you don't see that it's blocked, there's not a bunch of polyps, just from what we know about the inherent underlying mechanism of smell loss in many different etiologies, we know that there are inflammatory cytokines and molecules in and around that environment, and nerves just simply do not function well when there's inflammation around them. So I decided to add budesonide rinsing to olfactory training to see if that would benefit people, and it did. It took about 30-35% of patients who would benefit from olfactory training up to about 50% of patients. Now, it doesn't help everybody, just like olfactory training doesn't help everybody. Things like age, things like duration of loss before definitive intervention, these are things that affect all of these things that we're trying to do to help them, but it definitely did have an important effect. And then finally, to touch on the fact that I did this review because a lot of people, when they first have someone come in with smell loss, the first thing they reach for is steroids, right? Oral steroids like a prednisone taper or a Medrol dose pack. And when I looked at the literature, there really was not great evidence. There's some good evidence showing perhaps systemic absorption in the week after a traumatic event, like a motor vehicle accident, that giving oral systemic steroids can be a benefit. Other than that very specific scenario, there doesn't really seem to be very good evidence for systemic steroids to help this. Also, a lot of what people reach for to give their patients is Flonase or some sort of nasal steroid spray. That also does not help. There have been lots of really good studies, randomized controlled trials showing that using steroid topically in a spray formulation does not help people with their smell. And the reason for that is that really it's basically not getting there. It's not getting there. And that's why budesonide was more beneficial, because you put it in a rinse and it can actually access that area. And then finally, we'll talk about this much more in the next panel, but biologics, certainly there are lots of biologics, you just heard about them before also, that can maybe help with people's sense of smell. Just to kind of throw it out there, therapies I'm often asked about a lot are these different ones. We can talk about that later if you guys have questions. These are not things that I recommend to the patients, and you can ask me why if you're interested. And then just to show you a little bit of the future of what's coming about in the future, PRP is platelet-rich plasma. Some of you may have heard of this in use for orthopedics, in cosmetics, for hair loss, regrowth. And it's basically the part of your blood that is high concentration of platelets and low concentration of the other cells. And I did a pilot study pre-pandemic times because it was showing actually in different neurologic studies that there was some help with neural regeneration. Same reason I started looking at omega-3 back then. And in my pilot study, I'll say that too few patients to make conclusions about efficacy, but definitely there was an improvement in threshold, and it was enough for me to want to run a randomized controlled trial, which I now am currently running for COVID-19 anosmia. So basically a series of PRP injections into the olfactory cleft. I'll have all of my data collected by the end of February, beginning of March, and then we'll do our data analysis, and then I might have something else to tell you guys about it at that point. This is lab data from I actually have no background in basic science, but I was so interested in whether this would help people, I decided to learn how to do a rodent study. And this is basically using electrical stimulation in the nose to see if we could stimulate the olfactory epithelium and olfactory bulb. And you can see, again, very preliminary data, but using electrical stimulation for an hour did affect food finding behavior in these rats. You can see that here, if you stimulated the rat for an hour and then a week later, they had somewhat decreased ability, and then by a month out, much improved ability. Versus if they didn't have any stimulation, much decreased ability, and they never actually came back to their own baseline for food finding ability, even though rodents have a very robust ability to regrow their olfactory epithelium. And this is just looking at that olfactory epithelium, looking at that. And then finally, just to finish out, hopefully you guys heard this in the news, really interesting news about genetic susceptibility for COVID-19 induced anosmia. I think this is going to be the new frontier where we start looking at different genes and what we can do to affect those genetic susceptibilities for people who seem to suffer more from post-viral loss than others. And with that, I'll be done. You guys, as Eugene mentioned, I'm on social media, so if you have any questions we don't have time to answer today or tomorrow, then certainly you can reach out to me on Instagram or Twitter. All right.
Thank you so much, Sarah.
So just to repeat for everyone, the question is about the dosing of the omega-3 in that post-skull base surgery study. It's 1,000 milligrams twice a day, which is a much higher dose than you usually find just at the grocery store. And so most of my patients will find this online.
Yeah, that was it.
How long? So I did it for 6 months after the time of surgery because I wanted to follow their smell out that long. And, really all of these things, like I said, nerve regeneration takes a long time. And we don't know if they continued using it longer than that, perhaps they would gain even greater benefit, but we just stopped the study at that point.
I think one of the challenging things for olfaction for us has been that, we like to test and we like to treat. And for many of us, testing olfaction is hard. We have clinical trials where we use upset studies, and honestly, my patients complain about that part the most because it takes like 15 minutes. It totally stinks up the room. From a practical standpoint, maybe banking on some of the olfactory stimulation that you have, are there any maybe 2 or 3 essential oils that we can keep in our clinic that we could just say, look, you obviously can smell this or you can't smell this, just so that patients have a baseline? And then in terms of treatment, I thought the omega-3 was fantastic and very exciting. There was a big disparity between 1.5 months and 3 months. So It looked like the patients that were on it for 1.5 months maybe didn't have as much of effect, but 3 months it jumped, I think it was 28% loss, and then it went down to 4%, which is pretty amazing.
And that probably has to do with both the length of time that they're on that as well as just the general healing process after skull base surgery. I suspect both of those things combine. To speak to your question about the testing, yes, I totally agree. It takes forever to test people. And it's funny that the upsit is the thing that you think takes so long, because I actually use the upsit in my smell clinic because it's the shortest amount of time that I can get real data from. But when I do research studies, I actually use the sniff and sticks, which is a larger battery of testing threshold and identification and discrimination, which takes even way longer. So yes, it is definitely a problem. And I didn't mention, but Stanford actually has filed a patent for me to both stimulate electrically but also record. And so hopefully we will eventually have some sort of actual objective measure, not the psychometric, testing of the smell, which is totally based on culture, society, what someone's been exposed to in their lifetime, whether they're literate. There are so many things that affect the upsit score. But if we could actually just place a multi-channel electrode in someone's nasal cavity and record while they're smelling things, I think that would be a great thing. So that's another thing I'm working on. And as far as if you could just have a small number of odors present in your clinic to test them, what I'll say about that is that people have tried to sort of cut down on the smells, and it really seems like right around 8 or 9 smells is necessary to actually truly test someone's smell. So There's something called a BSIT, that's a brief smell identification test. If you wanted to just have that in your clinic and give it to patients, that will at least give you a sort of yes or no, very brief thing. It will not give you the nuance of like how good their smell is or not. It'll just be like, yeah, you have a smell problem or you don't have a smell problem. So right around 8 or 9 is probably the minimum that you could use.
Any other questions?
Yeah, that's a great question. So for everyone, do I get any routine imaging or other labs in patients with anosmia? And I would say in general, no. But if I do an endoscopy and there are signs of inflammatory response, then certainly a CT sinus follows. If someone either has congenital loss or they don't have a really good reason for their loss of smell, like it's not like a clear post-viral loss, it's not a trauma loss, it's not any of those other very obvious things, then maybe an MRI brain is going to be ordered. And for me, just keep in mind, in my smell clinic, I'm usually about like the 5th or 6th doctor they've seen for their sense of smell. In general practice, I would say, hard to know if MRI is really going to be cost effective as far as, following up on people's smell loss. But if there's truly no good reason, and especially if it's been a gradual loss or they have other distortions like parosmia and phantasmias, I do think then it is worthwhile to get an MRI. And then as far as lab tests in general, again, like no across the board panel, but if during your history, because history is so big a component of evaluating these patients, you do come across things like any metabolic disorder, endocrine disorder, any past history of cancer treatment, not necessarily in the head and neck, anywhere in their body, like chemotherapy, any other deficiencies, then certainly specifically for those things, then I will order particular tests. Yes, I would totally agree with that. Thank you for bringing that up. So that's on that panel of things that I get asked about. And zinc is something that I see people on a lot. And, there was, back in the day, probably about 20 years now, a study done that showed there may be benefit. But that study was not controlled. It wasn't, the methodology was not very good. What followed was a randomized controlled trial looking at oral zinc in patients with smell loss. And in that trial, not only did zinc show no benefit, but in the zinc arm, there was actually a slight, not significant, but slight detriment to people's smell. So I do not recommend and zinc for smell loss.
Thank you again.
Yeah, so I can answer other questions after we move on.
So what a wonderful talk to start and lead us off. Next, I have the pleasure of introducing one of the partners that I work with in the laboratory. So I am a surgeon as well as a scientist, and that makes my job a lot of fun. I feel like I have the best job in the world because I get to train people like Narushan, who's in my lab. He's one of our clinical research coordinators. And over the next half hour, we're going to fly by on and review some of the things that should be applicable for everybody. So for surgeons, for allergists, for immunologists, for those that want to be a little bit of both. And so what we would like to do is really focus on chronic rhinosinusitis with nasal polyposis and review very systematically what the treatment options that we have so that you can make an educated and informed decision in the future. So again, Naru is one of our postdoctoral students that's in the lab. He's in the clinical and translational sciences. We're going to piggyback. We're going to tag team this lecture a little bit. So I'll talk a little bit about the clinical side. He'll go over his review, and then we'll bounce back to surgery as well as biologics. So our goal is that by the end of this lecture, you will have a clear understanding of how to evaluate these patients that compose so much of our practice. And these are the ones that I think we can make a huge difference on. As you all know, chronic sinus disease, probably one of the most common patients that we see, affecting anywhere from 3 to 7% of adults in the US. I've actually seen numbers as high as 12%. And about a quarter of those patients will come into us and they will have nasal polyps. And so what do nasal polyps do? Well, when I describe this to my patients, I tell them it's kind of like a chronic irritation in your nose. So imagine if you took your hand and you started rubbing the palm of your hand every day for 30 minutes, several times a day, what would happen? You'd get a big blister, and so you'd get a lot of inflammation. And I think the same thing happens in the nose. So we have these epithelia that get chronically inflamed, and they evaginate, they become fluid-filled, and when they get large enough, they can cause symptoms such as nasal obstruction, so they can block the breathing in through your nose. They can block the normal ostia of the sinuses, so they can then contribute to infection. And then, as Zara had so eloquently pointed out, they can block those pathways to the olfactory nerve fibers. And what she stressed is that that area is so small, and it's very specifically located. So if we have polyps in that space, it can certainly impact patients' loss of smell. And that's what's called a phenotype, right? So what we can see in the clinic with our endoscope. What we now have known really from our much better educated pulmonology colleagues who have dealt with asthma as well as our immunologists is that there are molecular components to this disease that we can now describe, and that's what's called an endotype. In my practice, as well as probably in yours, we see a very high concordance of patients with CRS with nasal polyps as those with asthma. And what we found is that when you look at the biomolecular composition of these patients, they tend to have what's called T2 high inflammation, or T helper 2 mediated immunity or inflammation. And this is characterized by elevated levels of IL-5, IL-4, as well as IL-13 downstream, as well as high eosinophil levels. Those patients without nasal polyps tend to be a little bit more what we consider infectious, more Th1 mediated, with typically low eosinophils. And so the first step to measure how we're doing in this process is to subjectively and objectively look at our outcome criteria. So what do we have for our outcome criteria? Objectively, we have what's called the nasal polyp score. If you don't know about the nasal polyp score now, I highly recommend that you read up about it, because I think it will become a standard of what we do to document our physical exam in the nose. And so to give you a little bit of an idea here, this is the middle turbinate here, right there, and this is the inferior turbinate. So this is graded on a scale of 0 to 4, and if it's within the middle meatus, it's a 1, 2 if it's below the level of the middle turbinate, 3 if it's at the level of the inferior turbinate, and 4 if it's actually touching the nasal floor. And so obviously there are two values to this. You can get a maximum score of 8. And why this is important is what I had mentioned during David's talk, is that insurance companies are looking at this as well too. You know, you may need a score of 3 on one side and a 2 on another, or maybe a total of 5 or greater, in order to be eligible for some of our more potentially advanced treatments. Many of you are familiar with our Lund-Mackay CT scoring system. Again, if you're not, it's, every sinus is scored on a score of 0 to 2. 0, no mucosal inflammation, 1 being less than 50%, and 2 being greater than 50%. Certainly, this is not a measure of polyps, but what we do tend to find, and many of your patients will look like this, right? Those patients with horrible nasal polyp disease, although these may not be all polyps, the polyps are obstructing those ostia and causing mucosal disease. We also have subjective tests like the UPSIT. So we actually use the UPSIT 40. It's a 40-item question. Remember when you were kids, you take your quarter and you kind of scratch that sticker, and then you take a deep smell. We also do that, and there are multiple choice questions. But that being said, some of these questions and smells are really hard. Like, I've never smelled turpentine or leather, or I mean, it's like oiled leather. And so, you know, some of these patients will come back to us and they'll be like, what is gasoline, or what is, you know, saffron? Or some of these are very common odors, but some of them aren't. So it does make it a little bit more challenging. And then we have what's called the SNOT 22 test, very aptly named. Again, 22 questions, many of them being the common symptoms that we see with those patients with chronic sinus disease. And it's graded on a severity level of 0 to 5, with 0 being not really affecting me, and then 5 being a very, very severe problem. So again, these are both objective and subjective measures of how we can measure this disease. So what are the current therapies that we have so far? So we know that steroids are a huge tool in our toolbox for nasal polyps, and the reason is that this is inflammatory driven. And so we have topical nasal steroids, whether they be in steroid sprays, whether they be in exhalational nasal delivery devices, or in irrigation solutions topically. We can also use oral steroids as well, but they do have systemic side effects, as you all know. And then we have antibiotics in those cases where the inflammation also predisposes to sinus infections. We have surgery in our armamentarium, typically after patients have completed or maximally medical treatment. And then relatively recently, in patients who have had surgery, we now have steroid-eluting stents where these steroids can topically leach into the epithelium in the sinonasal cavity. And then much more recently, we have biologic therapy. So we have 3 biologics that are currently approved: Xolair or omalizumab, Dupixent or dupilumab, or Nucala and mepolizumab. And we have corporate sponsors here right next door. All of them are represented. So if you have specific questions, please feel free to go ahead and talk with them as well. So for one of Naru's thesis projects, and this is, I promise I don't torture all of my students like this, but I wanted him to look at what therapy is best for patients with CRS with nasal polyps. So over the next 10 minutes, he's going to tell you about what he found. Go ahead, Naru.
Hello, my name is Narushan Narendran. I am a clinical translational sciences doctoral student. And before I proceed any further, I actually want to thank our team, James Patterson, who is a fellow medical student here at the University of Arizona, as well as Dr. Burite Gautama, who is a resident surgery fellow here as well. And we went through this task of going through and trying to figure out the best treatments for CRS with nasal polyps. So in order to do that, we actually needed to go through and determine what our outcome measures were. And we evaluated first the outcome measures in surgical groups, as listed right here, as well as in the biologic groups. But in order to compare them head to head, we needed to find similar outcome measures. So we found that nasal polyp scores, Lund-Mackay, nasal congestion score, SNOT-22, and smell tests were the most common between the 2 groups itself. So using that information itself, we worked with our librarian here at the university to determine the best way to tackle this problem. So we did a pretty comprehensive search through multiple different databases, such as Cochrane, PubMed, clinicaltrials.gov, and we found almost 12,000 articles, which is a vast amount going through all these different therapies itself. And going through that, we did a screening process, and we found about 800 of these articles that met our outcomes for CRS with nasal polyps undergoing these interventions. And right now, we are currently sifting through about 800 of those articles to see what works best and what we can determine the best treatments for these patients itself. And in order for us to go through, we actually will be discussing some of these outcome measures in the medical, surgical, and biologic outcomes.
So I challenge you all to look at 800 articles. We are doing the hard work for you guys so that you can get the 5-minute synopsis. But these are all high-quality studies. So these are randomized, usually multi-center, placebo-controlled. And what that means is that the patient doesn't know if they're getting the therapy, and usually the physician doesn't know if they're giving the therapy. So these are relatively, what we call the gold level standard of studies. And we're going to briefly zip through all the therapies that we have for CRS with nasal polyps. Nasal steroids. So something that we all have been using either personally or through patients. And I've always wondered what the efficacy of this was, right? I tell patients, yes, you do need to be on it. You do need to be on it. But what we have found is that nasal steroids actually do work. So both at a single-day dose as well as a twice-a-day dose, it did change nasal polyp scores. So nasal polyp scores did decrease, as well as this nasal congestion score. So again, a subjective measure of how patients are feeling when they're breathing in through their nose. There's symptom scores. So these are classified from the SNOT-22 in terms of the most important symptoms that patients mentioned, and it does improve smell, anterior nasal drip, and posterior nasal drip. But I think part of the challenge that we have found is that when patients come in with grade 3, grade 4 polyps, you give them a nasal steroid spray, and honestly, you tell them, look, it's probably not going to work that well. And why is that? Because the nasal spray is atomized, the patient squeezes it, and that nasal spray probably just hits a turbinate, and that's about it, because the nasal polyps are blocking the entire nasal airway. And so companies have come up with this exhalational delivery system. The commercial version of this is called Xhance. And this is actually really interesting. So there's a port that goes into the mouth, there's a port that goes into the nose, and patients then breathe out. And this achieves two things. So one is that it closes a palate, so it creates a closed chamber, so that you want the particles to get into the nose, they should only get into the nose. And not only that, these are particle deposition studies coupled with computational flow dynamic studies, and what these show is that when patients can blow out, the nasal steroid spray can actually get to the areas of the skull base, which we think is important for olfaction, as well as the area past the polyps and the base of those areas. And what they've shown is that they do tend to decrease nasal polyps to a greater degree than nasal steroid itself, and that makes sense, right? So if we want to get steroids, we think that they work, we need to get them to the site of action. And so we have found Xhance to be helpful. The one challenge that we have had is that coverage is challenging. It's expensive, and so we really need to do due diligence in terms of documentation. For nasal congestion scores and symptoms, it has also shown similar findings. And then finally, endoscopic sinus surgery. So this is the reason why I went into rhinology. I thought this was the most satisfying surgery. You go into surgery, patients have polyps everywhere. They come out of surgery and they have no polyps. And they are profusely thanking you in the postoperative recovery area, and you feel like a champion. And you can tell your mom, you're like, I saved lives. I mean, I didn't save lives, but I saved somebody's sense of smell, or I saved their nasal airway, and it makes you feel really good. The problem is that these patients come back, and their polyps tend to come back as well too. And so Klaus was one of our guest speakers a couple of years ago, and he was very honest, and he said, look, over 12 years, I've looked at these patients, and I've looked and measured them and monitored them, and what he found was that yes, smell, nasal obstruction, rhinorrhea, all those symptoms that these patients complain about, we do great in that first year. But every year subsequently, particularly over 12 years, it gets worse and worse. Same with nasal polyps here as well too. And although we throw around this number of 40%, and all of us can say, well, look, I'm better than average, I'm probably better than 40%, Klaus is a really good surgeon. And he told me that 60% of his patients are actually having recurrent nasal polyps, and 40% needed revision surgery in 12 years. So if you're thinking about economics, you're like, hey, this is a gold mine. This is all I want to do. These patients keep on coming back, but if they're not satisfied, it's an issue, and this is an opportunity to where we can get better. So this is where our steroid-eluting stents come in. So we've opened up the sinonasal passageway. I've drilled into your head that steroids are good as long as we can get them to the area without causing systemic side effects. Well, what if we put a steroid-eluting stent in there? So this is a steroid-eluting stent by Intersect. This is mometasone. It's in a vicral suture, so it leaches out over time. The thought is that this typically tends to dissolve in anywhere from 3 to 4 weeks. And nasal polyp scores decrease, and nasal congestion scores decrease as well. This is its slightly scarier older cousin, Sinuva. And so this is a much thicker vicral solution. This typically lasts for anywhere from 2 to 3 months, much higher dosage, and it's thought to be used in postoperative cavities where patients you may be able to delay that surgery. So again, really innovative. You're taking the steroid and you're delivering it topically where we need to. And finally, biologics. So biologics are exciting. As a surgeon even, it's exciting. I do think this is probably going to decrease my surgical practice, but as a fundamental patient advocate, I think it's important for all of us to know. And why is this? Because this is really the only therapy that treats a primary molecular reason for why these patients develop nasal polyps. So what ends up happening? Well, this is our nasal epithelia. All of us breathe in fungus, bacteria, viruses, allergens, but in this subset of population, the epithelia becomes hyperactive, and they secrete what are called alarmins. These alarmins then stimulate T-mediated cells, mast cells, as well as ILC2 cells, to then secrete these big bad boys, so IL-5, IL-4, and IL-13. And then these cause that inflammatory cascade that we think is one of the primary mechanisms for why nasal polyps occur. So with biologic therapies, we now have targets that can specifically block this cascade either at the IL-5, 4, 13 level, as well as many that are coming down the pipeline that might even be more specific. So now I'm going to give it over back to Naru, who's going to talk us about specifically the biologics as well as the studies that have been shown for them.
So thank you, Dr. Chang, for going over a brief overview of our inflammatory responses. So we see right here there are multiple different biologics right here, starting with omalizumab, mepolizumab, benralizumab, and dupilumab. And they've all been approved for other indications such as asthma, atopic dermatitis. But specifically for chronic rhinosinusitis, we see that 3 of the 4 are approved at this point. And they target different components, as mentioned earlier, in the type 2 inflammatory response. So in order to go further, we actually wanted to see what the study design entails, as well as evaluating the subjective and objective outcomes. So we see right here, almost all these studies are randomized controlled trials. They are evaluated for polyp scores, nasal congestion scores, and SNOT-22s at baseline. Patients will be given background therapy of mometasone furoate throughout the entire course of the study itself. Once they meet certain criteria, they will be randomized into one of 2 groups, either the treatment arm or the placebo arm. And the study designs will vary based on the duration of the studies itself. Following the completion of the treatment, they will undergo a safety follow-up period and also be evaluated to see how their baseline scores, how it's compared to their baseline scores. So we first want to go through and see what their nasal polyp scores look like. And on our y-axis right here, we see that there is a change in their baselines, change in their polyp scores. And then on our x-axis right here, we see the duration or the time of change that's occurred in all 4 studies. Each of these studies have a different time point, so I'll go through them quite briefly. We see that in omalizumab right here, we see almost a 1 to 1.2 point change at week 24. We continue to see almost a 1 point change here at week 52 for the mepolizumab study, and we continue to see this here at a 0.5 change in the benralizumab study, all going for 6 months to a year. In the dupilumab study right here, they evaluated for 2 different things. They evaluated at week 24 following patients being off treatment, and then they had a sinus 52 study that evaluated for the duration of 1 year. With this being said, we see significant changes occurring as early as 8 weeks in these patients, and seeing what the scores we have right here, patients who are off treatment at week 24, we see these scores slowly going back up to their baseline values, showing that these are relatively reversible. So we wanted to see how this varies with SNOT-22. We see a very similar trend like this as well. There are SNOT-22 scores in omalizumab, decreases about 20 points, as well as in benralizumab, and we continue to see a much higher score increase in mepolizumab as well as in dupilumab right here. In the dupilumab study, when they were off treatment, their SNOT-22 scores did gradually increase up, but still all these SNOT-22 scores did meet the minimal clinical important difference, which means a range of greater than 8.9 points. So we also wanted to see what nasal congestion scores. Nasal congestion scores were not evaluated in all the studies that we saw. However, they were reported in 2 of the studies. So we see almost a 1 point change here at 24 in the omalizumab study, and we see almost a 1.3 to 1.4 change at week 24 for the sinus 24, as well as at the sinus 52 study. However, when patients were off treatment here at week 24, they still maintained for a few weeks. However, it still went back up closer to the baseline values. Still going forward, it's still very similar to what we saw in our nasal polyp scores as well as in our SNOT-22s. So we wanted to see what smell looks like, as it seems to be a very common issue for CRS with nasal polyp patients. Again, we see that omalizumab had an improvement in their smell scores, as we see in our y-axis right here, as early as 8 weeks, and that score is almost 4.4 points high at week 24. In the dupilumab sinus 24 and sinus 52 studies, we see that their smell scores increased by almost 10 points at week 24, and it still continues to be as high as 10 points at week 52. Yet when patients were off the treatment for dupilumab, we see them decrease at week 58, still confirming what we had seen in the past few slides, that these changes are reversible. Now, with the mepolizumab and benralizumab studies, they did report very minor changes in their sense of smell for almost 1 to 1.5 points. So we see in our Lund-Mackay, or the sinus CT scans, at week 24 in the sinus 74 study, we do see almost an 8.5 decrease in their sinus scores. However, at week 48, when patients were off treatment after that week 24, we see that the sinus scores was not as high as we saw here at week 24. So knowing all what we...
Thank you so much, Nuru. So what we found were that the biologic studies certainly helped with nasal polyp scores, congestion scores, and symptoms. But what we didn't find was a real head-to-head study, right? So what happens when you take half your patients, you undergo them, they have surgery, and then half of them undergo biologics, and how can you compare those two studies? So this is something that we were really interested in, and we also wanted to leverage our expertise in kind of molecular science. And so what we proposed was taking some patients that were on biologics, some patients that were on surgeons, using the same team, and comparing subjective, objective, and molecular markers, and also comparing how we're doing compared to what others have performed. So these are the 3 patients that we enrolled in the study and the biologics. As you can see, they all have significant Lund-Mackay CT scores, and on the bottom are our surgical patients. So it's a 3v3 study. And we've been looking at upset, so these are objective measure or subjective measures of smell. And what we found was pretty interesting. So in those patients with biologics, as expected, their smell did improve. And this is similar to what biologic studies have shown. This is kind of the average of all the biologics in terms of their relative improvement. And we see this being durable, and we have one patient at 6 months, and it looks like they might slightly be going down. For surgery, we saw a pretty dramatic increase, but then it tends to go down after 6 months. And so I don't know if you folks see this. This might be recurrence of nasal polyps. This might be recurrence of nasal inflammation. Those patients tend to be really happy during that first kind of 3-month period. They're able to smell, and then they kind of come back and they say, well, maybe I'm not smelling as much. And this is, again, us testing them. They didn't necessarily complain of smell, but this is subjectively what we could find in our studies. And then in terms of the SNOT-22, again, this might be a surgical placebo effect. You know, we did something. You took them to surgery. They took a week off of work. But what we found were that their SNOT-22 scores did go down significantly at 3 months and then started slowly rising. But with the biologic therapy, they continue this downward trend. So it seems to be a little bit more durable. The biologic therapy itself might take a little longer, obviously. I mean, you're not removing polyps in bulk. But it might be treating those molecular mechanisms. And then finally, for the SNOT-22, so these were the 6 most common symptoms that patients had described. And what red here is this is the most severe for them. And so this is all of them at baseline. And fortunately for us, they do tend to improve at 3 months, and we're still awaiting 6-month data. Same with the nasal polyps. As you can imagine, for the surgical patients, you know, that's a rapid drop in nasal polyp scores and nasal polyp size. And we do see those with biologic therapies as well. So what we hope to report to you next year is the molecular data. So we've been taking molecular brushings on all these patients. We're now starting to look at the specific molecules, the cytokines, the inflammatory mediators of these patients, and seeing how they can change those individually. Because what we hope to find is that, you know, in the next maybe 5 years, you can bring a patient in, you can brush their nose, you can give them a test, you can maybe give them a blood marker, and then you can say, look, you are the perfect person for surgery, or you're a perfect patient for a biologic, or potentially even a combination of both. So I want to thank you for your attention. I know we covered a lot in half an hour, but we have a fantastic panel of guests that I'm going to bring up here in just a moment that cover both allergists, pulmonologists, and ENT surgeons. In the meantime, while they're coming up, can I ask, do any of you have any questions about the data that we've talked about so far? Yes. Yeah, so that's what we're going to talk about for our panel. So I don't want to spoil the surprise. I don't think there's a right answer. I really don't. There are differences. There are different targets. There are different dosage mechanisms. and there are different therapies. But what we have shown is that all of the biologics help with symptoms and with nasal polyps. Some might get there a little faster than others, but some might also be more convenient to some other patients than others as well too. Yes?
COVID, have you seen the drop in the number of patients you've seen? You've seen less patients overall. I feel like there's less complications.
So the question is, with COVID, so over the past 2 years, have we seen a drop in the number of patients that are coming in with nasal polyps? Yes, absolutely. But I don't know if that's epidemiologic or if that's patient-specific. So I think a lot of our patients fear coming into our doctor's offices, right? Many of them have minimized and many of them have pushed things back. What I am seeing now is that during lulls of COVID, when we do see patients, we're not seeing the grade 2 polyps. We're seeing the grade 4 polyps. And that's because these patients have been waiting for a significant amount of time. Or these may have been patients that we've operated on that are now coming back at a later point. So we've got an illustrious panel here, an all-star panel. If I can have all of you come up here, that would be wonderful. So we have, I'm going to introduce them kind of in order of appearance. We have Dr. Chris Lay, who is my partner. I am so lucky to have this guy as my partner. I mean, he has been amazing. He was our first fellow for neurorhinology. So just to let you be aware, neurorhinology is a very subspecialty focus. We do sinus surgery, we do skull-based surgery, and he, in the span of 6 years, is now associate professor. So congratulations. And he's our new neurorhinology fellowship director. So thanks for all of that. He's done an amazing job from that standpoint. We also have Dr. Monica Kraft, who's coming up to the stage. Monica, thank you so much for coming and taking time out of your busy schedule. Dr. Kraft is our chair of medicine here at the University of Arizona. Both herself as well as Dr. Carr, who I'll be introducing shortly, are both physician scientists. Monica has a great experience in severe asthma. She was actually one of the first founders of people, or looking at patients with severe asthma and understanding why do these patients have asthma. She developed this really interesting connection between mycoplasma and is now developing therapies that can help these patients. She's also got a really vast knowledge on biologic therapy in asthma, and hopefully can tell us a little bit more about which one might be appropriate for our patients. Dr. Carr, who's coming up here, a great friend of mine as well. So she's the head of the Allergy and Immunology Division. She trained at Northwestern, which is a huge sinus center, comes to us with a huge amount of experience. She also just recently got awarded as a co-investigator for asthma and diversity. So congratulations on that. That has been fantastic. And she works so closely with our patients as well. And then finally, last but not least, Dr. Schroff, who's coming up to the stage. And so he is our Associate Clinical Director for Allergy. Dr. Schroff is unique in that he has training both in allergy immunology as well as in rheumatology. And so he has got experiences using biologics for both of those diseases in those specialty focus areas. So again, thank you for all the level of expertise here. I'm really, really looking forward to the next hour where we'll go over your own personal experiences, some patient case scenarios, and some of the data and some of the knowledge that you can impart to our audience. So these are the 3 biologic therapies that we have now for patients with chronic sinus disease with nasal polyps. As Niru had mentioned, there are several that might be coming down the pipeline here in the near future. These are relatively new for us, right? So dupilumab, September 2019, mepolizumab and omalizumab shortly thereafter. And these are changing the way that we impact our practices. What I would love to ask the group that has had more experience, when biologics started coming into your field, in asthma, in allergy, in rheumatology, how did that change your practice? What was your first introduction? Because this is new for us. And how do you foresee, reflecting on your disease processes, how do you foresee this changing the management of our patients, our mutual patients with chronic sinus disease with nasal polyposis? And so all of those mics should be on. They should be on.
All right, should I jump in?
Please,
Okay.
Dr. Kraft.
All right.
Eugene, thank you for having me. It's great to be here. Love to have meetings at the Lowe's Ventana. Very nice. And so this is a topic near and dear to my heart. I think it's a great time to be in the field of sort of airway immunology, because not only has our understanding of the mechanisms of disease just exploded really over the last 20 years, 20 to 30, we now have therapies that we can offer our patients that we really didn't have before. So I like to say it's a great time to be in the field. You know, I'm probably one of the oldest people sitting here, and so I remember when Xolair was approved back in 2003, and it was a real game changer back then. We were using, inhaled, my practice is mainly severe asthma, but with severe asthma comes chronic sinusitis, nasal polyps. It's one big airway, right? And so the beauty is when Xolair came on board, we were thrilled because, we had a lot of patients on high-dose inhaled steroids, oral steroids. Now, some of the potency of the inhaled steroids had improved, and so that was a real game changer as well. But we didn't, having a biologic that targeted a pathway relevant to that patient's disease was very exciting. And of course, Xolair, focusing mainly on the atopic side of things, was wonderful because we saw that a lot. Type 2 asthma, allergic asthma, eosinophilic asthma, and so we had options. And for many patients, it really improved their asthma. Not everyone, though. And so, so I'm going to just start, and I'm going to let my colleagues take over because I don't want to hog the mic. But over time, certainly the next set of biologics didn't come for another over 10 years later. And then we're looking at the interleukin-5 pathway, focusing on eosinophils. And now we have Dupixent, which of course you all are familiar with. And then now we've just had a recently approved biologic, tezepelumab, which actually has benefit in type 2 as well as non-type 2 asthma. So the indications for biologics have really broadened. So I think it's a very exciting time to be in the field. And I would say, I'd love to hear what my colleagues have to say about what they think about the biologics. But for me, I feel like it offers, really nice alternatives for folks who are very symptomatic, either upper, lower airway, or both, have frequent exacerbations, daily symptoms, low lung function, and really have a pretty poor quality of life. So I think for the right patients, they're wonderful. I think one of the drawbacks is some of our biomarkers that Eugene and Naru talked about. We're a little bit limited in our biomarkers, and so while we think we can predict responders, we're not always the best at it. So we can give you where we are today, the state of the art, but we're really hoping that the whole biomarker field advances. I know personally from a clinical perspective, I'd love to see that, and I'm involved in some research to hopefully make that happen. So I'll stop there and let everyone else take a turn.
Hi, I'm Tara Carr. I definitely share your enthusiasm for biologics, Monica, because it's given us so many more options when treating our patients, and there's different components of the different treatments that we really like. But I think reflecting on your question, Eugene, in my fellowship program, as advanced as the sinus program was, when I was there a little more than 10 years ago, we didn't use biologics. We barely prescribed Xolair for our patients because it was such a pain to get approved and authorized, and our nurses hated it, so we kind of didn't do it. So when I came here to the University of Arizona and I established the allergy clinic for adults, it was kind of a brand new thing that I had to learn and become a little bit confident with and figure out the processes with our nursing staff and with our, the billing people and pharmacy, and just kind of sort out all those little details, and also really become comfortable with not only the mechanism of these drugs, but the potential side effects, and really understanding what our patients should be trying to be expecting from the medication. And that was a bit of a process, really. It was a learning process. And I think for all of us, as these new drugs come on, with each one, you have to kind of redo that process. And so there's definitely effort to it that I don't think our patients really understand, but that we're trying to do to be their advocates. And I'll just leave it at that. I will say that participating in the clinical research studies, the industry-funded studies, the phase 3 studies, phase 2 studies, has been really helpful for us in our center to not only become familiar with these interventions, but really understand them well. So if you have the opportunity to participate in clinical research as a site, that can certainly help.
Benny, tell us your experience. We'd love to hear it.
So I'll share a little bit of a different experience. So
probably similar to Tara, it was the excitement of Xolair when it first came out, having an option. And I suspect many of you have already used Xolair or some of these other biologics in your patients. But for those of you that haven't, I still remember a young man who came to see me. This is when I actually worked as an allergist with some ENTs, and who came to see me and basically had AERD. And I remember him telling me vividly about his alcohol sensitivity and all these, kind of what led to his diagnosis. And I can say this now because thankfully Xolair is approved, or omalizumab is approved in nasal polyposis, but at that time, we were still emerging and using these treatments initially for just atopic asthma, but starting to realize their benefit in several other diseases. And I still remember once we got him approved, not surprisingly, of course, he had airway disease, the association that we see so much between the upper and the lower airway in these variety of diseases, and he responded amazingly well. And I still remember just how grateful he was in his journey of having had multiple sinus surgeries. And again, this is almost a decade ago. I'm dating myself as well. But it just shows the power of these therapies in specific patients and the need to continue to progress. And on that latter note about aspirin sensitivity, I'll just also share, this is why I think this is such an exciting time for not just allergists, pulmonologists, but all of us as you all as ENTs to we are managing these patients one way or the other, and the co-management of it is so important, and I treasure that in our own center. But hopefully, even within the community, and this is something we need to continue to work towards for the betterment of our patients. So.
Very, very well said. Zara, do you have some comments?
I mean, I think that the experts have already spoken, but I will just add that, similarly when Xolair first came out, was when, just to sort of tag on to what you were just mentioning, when we in rhinology at least really started beginning to think about things like the unified airway, where before that we had kind of been in our little silo of sinus disease, and then we realized, of course, there's this whole mucosal surface that goes down into the lungs, and the same things that cause reactivity down there cause reactivity up here, and it really opened this whole world of not just benefiting from the medications that pulmonologists and allergists were using for the lungs, but also learning from their research, understanding how to do better methodology studies that affected the sinuses versus just the lungs. And I think just that connection when omalizumab first came out opened up a whole new field of research really in ENT.
I don't have anything to add, but I think for my career it was Dupixent, because that came out in my third year of practice, and that really, we were fortunate, Eugene and I, that we work with such a good team here that we have collaboration. But I think in the community when Dupixent came out, it really showed more collaboration between our community providers and our pulmonologists and allergists that worked more in unity, similar to what we have at the academic center. And I think that really has just improved our outcomes. Like we've all stated already, our polyp patients, no matter how good we do, there's a 50 to 60% recurrence, and really with these biologics have helped us get outcomes that we never did in the past.
Yeah, I think to echo that, for me it brought nightmares, because I thought, how am I going to fund my kids through college? And man, I really sucked at immunology in med school. And so it forced me to really learn about it, and then also to reestablish these relationships. So we are so lucky to have all of you here. But in your communities, you also have very fantastic allergists and immunologists. And if you're not an immunologist, that's okay. But forming these relationships, I think, can be synergistic and can continue to build your practice. So I think that's been very helpful, and one thing that I've learned. I'm going to start with the thing that's hard for everybody. So this is like when you go to church, and the pastor says, our funds are a little low this year, right? And so it's one of those talks in that biologics are expensive. And they're really expensive. And they might not be expensive for us. They may not even be expensive for patients, but there is a huge overall cost in this. And so I'm going to give a sample patient that, that comes into our clinic. So, Bob, he's 50 years old, new diagnosis of chronic sinus disease with nasal polyps. He doesn't have asthma, But you're thinking that this is going to be a patient that's going to be a friend of yours for a very, very long time, knowing that the recurrence rates, knowing the potential possibilities of biologic therapy. And so he asks, you've done your due diligence, you've talked to him about biologics, you talk about asthma, and he says, look, I'm really interested, what is the overall cost of this to society, to himself, to our practice and whatnot? And so, a challenging question, but the group at Harvard actually came out with a really cool study of a cost analysis. And so what they did was they used what's called Markov modeling or economic modeling, and they took a sample of real patients in their own practice, 197 patients with nasal polyposis, and they looked at them over 36 years. What was the cost of their surgery, the cost of their medications, the cost of them going back to surgery, the cost of potential complications during surgery. And then they took the data from the biologic studies. This one was a 2452 study from dupilumab, and they looked at those costs. And then they looked at the incremental cost per quality adjusted life year. And what they found was pretty dramatic. So over 36 years, the cost of biologic therapy for Bob was going to be 10 times higher than that of surgery alone. And that's not unheard of for a new therapy, right? We know that there are new therapies, and new therapies only happen because of years and years of R&D costs, of development. But this is a big issue. And so I think for these new therapies, it's a little easier to swallow if it's for like CF, or if it's for HIV, or if it's for hepatitis C. And I think we're now coming around to CRS with nasal polyps as being a big quality of life issue. So this has really been one of the driving factors and why this lecture series is important. How do we choose between biologics and surgery in a very ethical manner, and how do we figure out those right patients? And so I'm going to talk to you about two consensus statements, one that came out from Europe and then one that came out from, it's IFAR, so mainly US-based in some of the recommendations. And what I'd like you to focus on is that they tend to be quite surgery-weighted, and I think it's because of the cost. But there's a different attitude between both of them. So this is a Euphoria consensus. And Tara, I know that you've reviewed these articles and you've discussed them. Were you on the Euphoria panel as well too? So you weren't, but this is really interesting in that, you have a patient with nasal polyps, and those, if you're going to do surgery, those patients that they recommend for surgery need to have a higher level of severity or more criteria than a biologic therapy. And so what I'd like to ask you all, particularly Chris and Zara, when you're seeing these patients, because oftentimes we typically tend to see these patients first, not all the time, but typically tend to see these patients first. How do you decide between biologics versus surgery? Looking at both the Euphoria consensus here, and then I'm sorry, I'm going to take, this is a little bit harder to read, but the IFAR consensus essentially says, do absolutely everything you can except for a biologic until you absolutely need a biologic. And so how has that changed your practice? And then I would love to get the input from our allergists, immunologists, and pulmonologists about what you think about for biologics in CRs with nasal polyps and how to weigh that choice. We'll start with you, Zara.
So I'll start. So I would say, not surprisingly, I'm a little more in line with this last statement. I think something that we haven't quite touched on as much when talking about this entire disease process, in addition to just surgery and biologics, and you guys touched on it in your review a little bit, but what topical steroid irrigation has done for management of these patients is also, I think, groundbreaking. When that first came into our practice, that was a huge sea change between just taking patients back over and over and over for surgery versus doing a very good, complete, thorough surgery. And I would say in my hands, with the patient population that I see at Stanford, I would say 80 to 90% of patients with good, complete sinus surgery followed by topical budesonide irrigation, plus minus other medical therapies not biologic, will be controlled. That leaves the 10 to 20% of patients who are much more a selective group, like AERD patients who have a much greater underlying inflammatory drive, a systemic inflammatory drive. And the case that you just put up there, I think it's important to think about a patient with CRS and nasal polyps who does not have asthma. That's a little bit of a different patient than someone who has this global inflammatory response throughout their upper and lower airways. And so in that particular case, I would say I would definitely take to surgery first. I would make sure that they're doing proper topical therapy. Sometimes it's difficult to get things like budesonide approved, but we have different ways of going about that. And then really only in that select group of patients will I then say, you know what, we need something more. We need to bring out the big guns, and that's where Dupixent comes in.
Yeah, I agree with Zara. I think a lot of us in the room probably fall in line as ENT surgeons with IFR. I think a big deal is like the AERD patients. Those are the ones that we share with our pulmonologists and allergists and neurologists. Those are a different subset of patients. And I'm sure when all of you counsel your patients, we talk about CRS with nasal polyps, there's a scale of them. You know, there's patients who have really mild polyps and bad polyps, and there's patients who you know you'll do well, like Bob, he'll probably do well. CRS with nasal polyps with no asthma, versus an AERD that's had, 5, 6, 7 surgeries since they were 30, 35 years old, and now they're 55. So those are totally different patients, and I think we all approach them a little bit differently. For Bob, I think he's a patient that we'd probably offer surgery up front, get really big openings that we'll talk about later, and try topical medazone or budesonide before we send them to our colleagues to assess the biologics.
I would just add, just because we brought up AERD a couple times, that, when we're talking about cost, and certainly the story of, allergists, pulmonologists, ENT really dates back, of course, many, many decades, but the classic example of aspirin desensitization or nasal polyp removal and then aspirin desensitization thereafter. So that is actually a very cost-effective procedure, when studied, given the cost of medication. Obviously, there may be populations in which that wouldn't, you wouldn't want to necessarily use that treatment. And so, some of these same issues about age do come into play, among others. But just since we're talking about cost, and it does matter, of course, as this case presents, where we're meeting the patient, right? These patients need to be identified earlier, with a lot of the tools that we have for understanding and making the diagnosis of chronic sinusitis, and especially those with nasal polyps, so that we can intervene with, effective saline irrigation, effective nasal care, and that we're not meeting them at the point that they are, already, so far advanced that we have to have some of these conversations. That's obviously a little bit of, wishful thinking, but I still think it's quite important in our advocacy and education.
I will say, though, you guys have it kind of nice because, as you acknowledged before, you do surgery and the patient is cured. Might be a temporary cure, but they feel great, right? So for me, it's very satisfying when my patients come back and I've started them on a biologic for their nasal polyps, and they're so proud to tell me, like, Dr. Chang and Dr. Lei told me that my sinuses have never looked more beautiful, right? And I love that because the patient is so happy, and I know that we're doing the right thing to keep them healthy, hopefully, and you just have to kind of eat the cost of it to some extent because it really is improving that patient's quality of life. And what might not be captured in some of those economic studies is the day-to-day life impact on the patients. And you guys know that these patients really suffer with the sinusitis when they have, polyps, but also non-polyp sinusitis. They lose productivity, they're out of work, they're just non-functional with their families, they don't sleep well, they don't live normal lives. So I think that potential cost-benefit analysis needs to be considered as well.
All right, well, I'll come from a little different perspective. So, starting out with the lower airway and moving up, I actually have a healthy respect for the cost of biologics as well. And certainly if one wants to treat, severe asthma with sinus disease, whether it be chronic rhinosinusitis with or without polyps, it really is a multidisciplinary approach. And I was lucky, I was very thankful to have my training at National Jewish where we were able to see, the most severe patients. So in that setting, a biologic was a logical step because these patients already had maximal medical therapy, they were adherent, their comorbidities were being treated appropriately, and there were asthma educators. If you're not at a place like that, those are the factors that you need to make sure of, and that's what I do every day in practice, is really look at all the other pieces before moving to a biologic. So that's one. And then also making sure that the biomarkers really point to an appropriate biologic that it is likely to be effective. And like I mentioned before, that's sometimes not 100%, certainly. But I think from an asthma sinusitis perspective, at least the cost benefit that I've seen because of the exacerbations, loss of work from school, loss of work and loss of school time, that there actually is in certain populations an economic, it's economically positive to use biologics. But I do agree with you, Eugene, when you have a patient where you just start out with just polyps and no asthma, I think I would agree to really see how far surgery and maximal medical therapy can take you before moving on to that biologic, because you may ultimately not need it.
Thank you so much. I think you've led us really deftly into a couple of topics of interest, and I'll go forward with them. For AERD, so Chris spoke about this beautifully. I mean, these are our most challenging patients, and I think all of us know them on a first-name basis, and they've all been through all of our clinics. And part of it is diagnosis. So Puneet had touched upon this too. This is now becoming more and more known, and that's why I put these diagnostic criteria here. And these are, they aren't hard and fast diagnostic criteria, but typically these patients have really high Lund-Mackay CT scores. They've got asthma as a criteria, and typically severe and persistent. So these might be patients, Monica, that you're seeing in your clinic as well, who've kind of hit that maximal threshold of steroids. They typically almost have no sense of smell. They might have seen us and it's our 4th or 5th surgery. I mean, wouldn't you agree? Many of these patients are coming to us from the community or from ourselves even, and they've had multiple surgeries. And then from a patient population standpoint, I tend to see these as more adults. I don't know what your practice has been, but usually, I don't know why, there tends to be, for me, a female preponderance, usually in their 40s. And many of them, some patients have polyps, right? They've got childhood asthma, they've got allergic rhinitis ever since I was a kid. But these patients, some of them say, look, I was fine until, Thanksgiving of last year, and then all of a sudden their nose just looks horrible. And I wanted to touch on this alcohol thing too, because I want you to expound on that, because a couple of my patients have said, look, whenever I drink red wine, whenever I have whiskey. So Puneet, do you mind just telling us a little bit about that? And the other side of follow-up is that all of them ask, what can I do so that I can drink again?
Well, I believe it's reported, I think, up to 70 or 75%, and I believe it's related to, salicylates, the response to that, and of course we see on the other side the hope that when patients do get treated adequately, either desensitization or biologics, as we're having in this discussion, or sometimes both, that they do actually improve with that specific, that specific outcome that is also a quality of life issue in many of these cases. So just touching on that briefly, that's my understanding of it.
Desensitization to aspirin is essentially therapeutic for the alcohol-related symptoms as well as the aspirin-related symptoms. So I have had patients undergo aspirin desensitization purely for the purpose of being able to enjoy a drink, which I think a lot of us could feel very reasonable. I mean, it's an aspirin, 2 aspirins twice a day. It's a lot. Aspirin desensitization, you desensitize to 650 milligrams twice a day, which is 2 full-sized aspirins twice a day. You can taper down from that dose, but it's less likely to be beneficial for the patient the lower dose you go. So it is a high dose, and you do need to pick your patients very carefully. They do need to be compliant. They do need to have, low risk for falling and low risk for having GI bleeds. It's great for people who need aspirin for other reasons, like rheumatologic disease, cardiac protection for coronary disease. And most of our patients tolerate it very, very well.
Well, I was just going to add, I think this is a great example of a multidisciplinary approach to treat a disease process that really takes all of us. And I will say, I was talking a little bit about the model that I was able to train under at National Jewish. I think we've taken that model to Arizona and really maximize that, because I don't do the aspirin sensitization. I'm the token pulmonologist in the crowd that likes severe asthma. However, I really appreciate what my allergy and ENT colleagues can do to really maximize obviously the sensitivity to aspirin, the upper airway function, so it makes my job a lot easier as a pulmonologist to really treat their lower airway disease. So I just wanted to comment on that. It's a great example.
Yeah, and I would just add one other thing. You know, the slide says biologic or surgery plus aspirin descents, and you guys are probably, like us at Stanford, it's becoming more of a three-pronged question. Is it biologic or surgery plus aspirin desensitization or surgery plus biologic? There's sort of like another branching point there. And I am also very grateful for my allergy colleagues because I certainly, you know, don't do aspirin descents. I don't prescribe the biologics. I completely depend on my allergy colleagues to do that. But it is a new conversation, I think, that they're now having with the patients about whether aspirin desensitization or a biologic, it seems like the best choice for them after surgery. And there's so many things like, you know, if there's someone who already has gastritis or has suffered from an ulcer, maybe a biologic is a better option for them, versus there are some people who, at the first word of a possible risk of any immunosuppression, they run towards aspirin descent. So I think that each individual patient, we're becoming more and more nuanced, more and more personalized about the way that we can treat their disorder.
Just really quickly about that, we always prefer to do aspirin desensitization after somebody's had surgery because, like Larry Borish, as many of you probably have heard and know, has said, they're basically bags of leukotrienes. And so if you give a bunch of aspirin to somebody who is a sinus full of leukotriene, they're going to have significant problems. So after surgery, when you've done that leukotrienectomy and they have much less inflammation in their sinuses, they're more likely to tolerate the aspirin. And we love the idea of giving biologics after surgery for some of these patients to prevent recurrence of their polyps. Our major limitation is the lack of data really supporting doing that, but also that the insurance companies don't like to pay for it right after surgery because until the polyps have grown back, they technically don't meet criteria.
Yeah, and to add to that, so we're part of a clinical study now that actually allows patients to be on both biologics as well as surgery. So that might be a combined algorithm. Looking at dosages, maybe even looking at cessation of one of these therapies as well. So I think we've shown that AERD is a hard disease and the one that requires multidisciplinary care. And my cases don't get any easier. So the next one is allergic fungal sinus disease. And this is something that we commonly see. It typically tends to be geographical, although I think, Chris, both you and I see a fair amount, even though we're not typically in the southern region. Thought to be a type 1 hypersensitivity, so an IgE reaction to the specific allergic fungi, also have severe nasal polyps, really characteristic thick eosinophilic mucin. And many of them might have asthma. I think we've taken care of a couple of them together, as well as the classic Charcot-Leyden crystals, which essentially are degranulated cells. And so in these patients, we have surgery, we have immunotherapy, we have antifungal therapy, as well as biologic use. What has your experience been for all of these? And I'm going to ask you to hold on that question because Chris has a beautiful surgery of an allergic fungal patient, and I'm going to ask you to just maybe narrate it and then also discuss about what you do for the extent of surgery in these patients. So how much do you take?
Okay. I think, yeah, this is one of our allergic fungal sinusitis patients. We actually share this patient with Tara. And she actually had surgery with our community providers who did a really good surgery about 10 years before. But she presented back with really bad polyposis, and you can see that thick purulent drainage here. But really, I think it's probably similar to Zara and all of us there. I think allergic fungal sinusitis, that subset of CRS with nasal polyps, you need big, wide openings because we really need to access and get that thick allergic fungal mucin in. So these are the patients where we really need to get the maxillary sinus open, we really need to get the sphenoid open, we really need to get the frontal open. And these are the ones we probably sometimes do extended procedures on when our community providers have done excellent standard antrostomies and openings. But it's really, this is what you have to get out here, this thick allergic fungal mucin. If you leave that in there, you see them like 2 months later, like, oh my gosh, why the polyps come back? And then you see, and you're suctioning them out, and you see that allergic fungal mucin, that's why. I mean, that's exactly what it is.
So in these patients, we talked about maximal therapy, but then Zara, you also talked about kind of making sure that you don't do too much because you want to preserve their areas of olfaction as well too. How do you weigh that? Do we want to be aggressive, like agro-aggressive? Do we want to be like minimal? How should we approach these types of patients?
Yeah, so definitely aggressive in the way that Chris just sort of described that, surgery is not getting at the underlying process here, really the medical therapy that you can then bathe the sinus lining with after surgery is what's going to prevent polyps from coming back, right? So if I make a tiny little hole into the maxillary sinus and then I try to get that patient on budesonide irrigation, it's going to maybe go in a little, maybe come in a lot out. But if you really widen that entire opening and you're able to get the rinse completely in, bathe the entire lining, get it all the way out, that's going to be much more effective. So I would say, similar to what that surgery just looked like, big maximal openings, of course, preserving olfactory function and the olfactory epithelium, keeping in mind that if there is degeneration, polypoid degeneration, then maybe that lining is not functional and you can remove it because that's not going to help the patient to leave that in there. And then one last thing I would just mention specific to AFS, I'm in Northern California, so we get this entire population from the Central Valley, the agricultural valley of California coming up to see us. So we do see some AFS there, even though I'm in the northern region. And although there is not great data, for people who have had maximal surgery like this and have been on budesonide irrigations and they still continue to grow polyps and have that thick mucin and you're sure you got it all out, putting them on a course of Sporanox in some patients can be magical. And it's not, I want to make clear that this is not a fungal infection that you're treating. It's just a fungal spore that your body is reacting to, right? But somehow, perhaps just decreasing the load of the fungal spores that are sitting there in the lining that they're not able to clear seems to do a lot for some patients. So that's a very select, not great evidence base for doing that, but in a very select group of patients, that seems to help also.
Tara and Puneet, can you talk? So, we often send these patients to you. We say, look, we speciated the fungus. Help us. And what is the role of immunotherapy for that specific fungal antigen? Is there a role? We have, just as Zara had mentioned, topical budesonide. We sometimes even use topical antifungals. You had mentioned other antifungal therapy. If the whole goal is to dampen that immune response, is there a role for immunotherapy in these patients?
Yes and no. This is very similar to what the allergic bronchopulmonary aspergillosis is in the lungs. It's a very pronounced inflammatory reaction to exposure to that mold. And not only is there IgE, but there are also IgG antibodies. There are other cells that contribute to the inflammation. So immunotherapy, I think, has a role and can be helpful, but sometimes medicines like the biologics can be even more helpful. Even though largely these patients are excluded from the biologic clinical trials, I think you could extrapolate to use those medications for these patients. For immunotherapy, if we can confirm that the patient actually is allergic to the mold that was in their sinuses, that's really helpful because that really tells us that we're doing the right thing by giving shots to those molds. If we can't confirm that allergy, then it's harder to convince yourself to do the immunotherapy and you wonder whether it's the right mold that's been speciated, that sort of thing. But after surgery, once they've been completely debrided and they have less antigenic load, we'll give them immunotherapy in hopes that it will prevent the recurrence of that inflammation with subsequent exposures.
I would just add to that, depending on if they meet criteria for ABPA, of course, having elevated IgE, allergen-specific IgE against aspergillus, a positive IgG, central bronchiectasis, mucus plugging, then in general, their IgE levels tend to be very high. And when Xolair was first approved, we actually couldn't get it for these patients because their IgE was too high. That has changed over the years, and now we can. And it actually doesn't really, the idea with Xolair is you want to lower the free IgE to less than 10. Of course, we don't have any way of measuring that. And that's where the dosing nomogram comes from. We now know that even if the IgE level is significantly elevated, even lowering it by even 50% or more can be quite efficacious for the patient. But I do agree with what was also said about the antifungal. So I tend to go with in an ABPA chronic fungal sinusitis, go with the Xolair approach first, assuming everything else is medically maximized. But I will consider an antifungal, especially in those patients who are steroid dependent as well. That's actually where the data are available and do show a benefit. And even if they're not oral steroid dependent, there is sort of anecdotal role for antifungal. I wouldn't say the data are as clear. However, in combination with the biologic, I've seen some nice responses that way.
Yeah, we don't do immunotherapy for severe asthma, so I should have mentioned that. That would be an exclusion criteria and somebody that we would skip over that option and go right to the biologics.
Going back to one of the questions of the participants, so I'm going to go back a couple slides, I apologize. These are the biologic therapies that we have, and you're talking to an audience, me in particular, where my physical exam is patient walking, skin warm, and then I spend about 2 paragraphs on the nose. And so, you had mentioned specific workup, labs, and much of that goes over our heads in terms of, which biologic to use. And what I see is, different targets, different dosages, different frequencies, so potentially patient compliance as well too. But when you look at these patients and you try and decide omalizumab, mepolizumab, dupilumab, what data can you use to help direct a specific patient to a specific biologic? Or is there that data?
All right, who wants to start?
Yeah, I mean, I'm glad you came back to this because, obviously you guys nicely presented some of the data with respect to nasal polyps, but I think, you can also take a thorough history and you'll find out that they often have urticaria. They often have atopic dermatitis. And in fact, for dupilumab, that was, initially how it was approved for atopic dermatitis. And similarly, it was a lot of our asthmatic patients where we saw, back in the early 2000s, that their urticaria also got better. And so these drugs have therefore obviously developed other indications that have included chronic sinusitis and nasal polyps. And I think it's helped us in our decision-making, in addition to among a lot of the other discussion about disease phenotype, biomarkers, but helping to kind of direct where we've had experience with some of those other disease states where it's also approved.
I agree. And whereas in asthma, we clearly have a spectrum of inflammation where there's lots of patients who have non-type 2 inflammation in asthma, in addition to the lots of patients who have type 2 inflammation, and you really want to do blood testing to try to sort that out. For nasal polyposis, like you showed on your first slide, Eugene, there was that nice kind of heat map almost that showed the clustering of inflammation in the polypoid disease and the non-polypoid disease. And it's pretty consistent that patients who have nasal polyps, most of them are going to have type 2 inflammation in the polyps at least. So I think for that reason, and maybe recognizing that ENTs don't routinely do labs on patients, the drug companies did not require any biomarkers to be inclusion into those studies other than having large polyps. And so that might be why there's more consistency in the response.
And I would just add one thing. Again, that's all over my head too, Eugene. but what I do know, because harking back to my love of the sense of smell, is that if smell is a major component of your patient's complaints, then mepolizumab is not going to do as well as the other two. So that's what I know.
That's interesting. I didn't know that. That's good. That's great. So from my perspective, I'm a heavy user of clinical history and trying to really determine the driver of the disease, upper, lower airway, and using the biomarkers accordingly. And so really because of the biologics we have, certainly Xolair would be focusing more on this allergic driver and IgE being really important. Whereas the mepolizumab and of course benralizumab are looking at the eosinophil. And really, so I measure blood eosinophils frequently in my world. And so generally, you can get these biologics even if you have an eosinophil count of 150 or more, which is actually on the low side. The data tend to look the most compelling when the eosinophils are higher. And that would go for certainly 300 or more. And so, but really in the setting of lack of allergy. So mainly an eosinophilic driver without really a big allergic component. The anti-IL-5s tend to work a little bit better. And those patients tend to be older. And they have obviously lots of sinus disease, but atopy isn't a prominent factor. And then of course Dupixent is kind of an interesting combination of both, in that it really, because of its effects on IL-4 and 13, it actually affects it affects allergy, but also affects some of the structural changes in the upper and lower airway through its effect on IL-13, mucus production, collagen production, things like that. So the structural changes and products in the lung and upper airway. And then, of course, our newest kid on the block, tezepelumab, which hopefully will come your way down the road, It has really great benefits in type 2 asthma, so that's great. But it also, the data from the New England Journal paper last spring showed some really nice benefits in non-type 2. So that's exciting to somebody like me because we have about half of our severe asthma patients who really don't qualify for the type 2 biologics, the type 2 high biologics, if you will. So it offers another option. So, from my perspective, I think using biomarkers can be very helpful. They're just a little bit limited right now, as I mentioned, and so there's a lot of movement afoot to increase our armamentarium in that arena.
That was wonderful. A really nice synopsis. I guess that means that we can't look at the red and black anymore, with like red being high and black being normal. So we'll have to take a more nuanced view of our lab studies. So I'm going to ask a couple thoughts to the surgeons, a couple thoughts a couple questions to the allergists, immunologists, and pulmonologists. We'll review a little bit of a shared decision-making tool, and then we're going to open it up to questions, as I'm sure you have many. So for the surgeons, how do you discuss this with patients? In your experience, are there optimal patients? We had talked about maybe some classifications, but you might be able to highlight some other ones. The extent of surgery, so polyps, how aggressive are you? I think we might have discussed that. And then the patient outcomes that you've seen both in the short term as well as the long term. So I'm going to send this over to both Chris as well as Zara.
Okay, so, my discussion in general with patients, the point at which I'm basically discussing this is at the point where I've already done appropriate medical therapy and I think that they're surgical candidates. And at that point, I will bring up biologics, even though I'm planning on proposing surgery, just because I do think it's important for patients out there to know that that's an option. It's not that you have to do surgery, that there are other things that could potentially help them even without surgery. But then I do also bring in the data about cost effectiveness and the fact that I think that a good appropriate surgery before thinking about a biologic would be the way that I would go. And then for that specific group of patients, AERD patients, who I think will need either aspirin desensitization or a biologic, this is a longer consent discussion than for my non-polyp CRS patients for sure, because then I really go into detail about how without either of those two things following surgery, they are definitely going to relapse. They will definitely recur. There's no way that they won't have polyps come back, and it's only a matter of time, and that it could happen within a month. And so I definitely need them to see our allergist preoperatively so that they can establish whether they think they're an aspirin desensitization candidate or a biologic candidate, and establish the date after surgery on which one of those options is going to start. And I won't move forward with surgery until that visit has happened. So that's what I do as far as counseling and sort of talking about that. And then as far as the patient outcomes and satisfaction, if you take the time to have this entire discussion preoperatively, then your patients will be phenomenally satisfied because they knew exactly what to expect. They knew exactly what was going to happen, and they're going to have very good outcomes because you prepared them for it.
Very similar to Zara. I think that these patients, when they come to us, they've been worked up very appropriately, and they usually have appropriate medical therapy, especially the revision sinus surgery, being sent by our providers in the community who've already done a really good job at medical management and or surgery. And so AERD, for sure, they always get a proper evaluation by our pulmonologists and allergists and immunologists. And I do also want them to see them before I do surgery on them because I want them to really buy in to the long-term treatment for adequate outcomes. Because I tell them, I was like, whatever surgery any of us do, it's going to come back. As much as we like doing surgery, we want to have good outcomes. So I tell them that you have to buy in long-term with me and with Tara and Puneet and Monica, or we're not going to do well. So that's like a must. And I will offer them surgery if they come up worked up from our colleagues as well. But I think that's really important. As far as patient outcomes and satisfaction, I always ask them, and we learned this in medical school, what are your goals? What do you want to get out of this? Because not all patients need surgery, not all patients need biologics. You know, if it's someone who's lost their smell for 25 years and their goal is to get smell back, I'll send them up to Stanford and say, hey, maybe Zara can help you because I cannot.
Zara's going to electrocute your nose.
Exactly. But, you know, so, I mean, that, and we've had one recently that's from the community. I told this guy, you know, you're 70 years old, you've had polyps for 25 years, you're not getting your smell back. So what is your goal? So we actually didn't offer him surgery, even though he had, you know, grade 3 polyps, because he told us his, you know, the rest of quality of life was great.
Very good. And I absolutely agree. I think having an informed discussion is important. Kind of expectations. I think for all of our patients, as long as painful it is to discuss, you know, potential complications, because they're always like, I could die. I could lose my sense of smell. I could, you know, but if you, what I always say is, look, you would want to know this before rather than after, and the chance is exceedingly low. And we'll talk about some complications and how to avoid them tomorrow in our surgical talk, but I think having that knowledge is very, very important. For our allergists, immunologists, and pulmonologists, we talked a little bit about the pre-biologic workup and how our workup has been dumbed down just because we don't often use lab values, but that's very important in terms of the phenotypes. In terms of symptom improvement and timing, what can you take us through? Like, how quickly do patients get better? Do you have any stories of taking patients off biologics and having them kind of have durable effects, or do they tend to relapse? And then talk to us a little bit about side effects, because for us, we have seen some side effects, rare, but you obviously have more experience with them. So how do we counsel our patients effectively because some of our otolaryngologists here in our audience are actually the ones that are primarily giving the biologic therapies.
I'll just quickly start. I also have to run. So I think the first thing that, you know, is important, we've talked obviously being multidisciplinary, but one of the key things is really assessing that history and finding of asthma or not, because I think we know it's associated with more severe outcomes related to CRS, and we want to help these patients early. So that's one key thing. And then using the tools like are suggested here in the workup, whether that be a pulmonary function test, but more specific to the type 2 workup, the exhaled nitric oxide. We've talked about blood eosinophils. I know Eugene mentioned about, you know, tissue eosinophils and other biomarkers there, as well as, of course, IgE levels and where appropriate, you know, allergy testing, and we know that there's a high association there as well. So from that perspective, I think things that we're all familiar with. In terms of, I'll just touch on, you know, maybe a little bit about symptom improvement and then turn it over. But I mean, we've seen the clinical trials, we've seen some of the data. We know that, you know, for example, with dupilumab, once patients start, they can find symptom improvement relatively quickly, and then when they are often stopped, it can, you know, recur and deteriorate, and we've seen that in our own practice. For a handful of patients that I share with all of my colleagues, you know, we'll have these patients back within 3 months, and I can tell you there's quite a number that are already doing better, certainly symptomatically based on SNOT scores, et cetera, but also even, you know, because we have such an amazing team that when they're getting their nasal endoscopy, their polyps have markedly already declined in size. So, you know, I would say, you know, as early as, from just offhand, early as 3 to 6 months, but I do think that question of long-term does come up because our patients, by and large, are doing better with respect to their nasal polyps, their asthma, maybe other comorbid disease that they may suffer. I don't have a lot that I end up taking off of therapy as long as they're tolerating it well. And then without jumping too much into side effects, overall these drugs, I think a lot of it is education and making the patients aware that these are not immunosuppressants as to what they might be expecting or have heard from you know, other you know, drugs, and especially wearing a rheumatology hat, often hearing about other immunosuppressives and things of that nature. But that is, you know, there have been some, you know, one-off side effects, hypersensitivity reactions, or other, you know, immunologic pathways that may get altered in some of these patients, and that, you know, is a case-by-case scenario. So I'll just leave it there. Thank you for letting me join. I'm sorry I have to run.
I can add a little bit, I think. Certainly, when patients come to see us, sometimes it's, Dr. Lay told me to come see you to get on Dupixent, and that's like, you know, the whole thing. But a lot of patients also kind of want more information about why they have polyps, and I think to some extent we'll offer them the blood testing for eosinophil levels and allergy testing to look for sensitizations because they're interested in that information. But like I said before, it doesn't really right now influence how we select biologics for patients who really have just nasal polyps. If they have asthma, we might look at those things from the asthma lens and try to understand which one might be best for the asthma that also would help the nasal polyps. Although I will tell you that I have patients who do not benefit both airways from one drug. I have a patient who's on 2 biologics, one for her sinuses, one for her asthma, and it's totally required. I guess that said, you don't have to do blood work biomarkers before starting a drug for nasal polyps. One thing that our patients will be interested to know is that all of these 3 biologics that you see here are available for home dosing. So people can do them at home. Sometimes that's an insurance issue because of copays and things that make it more difficult for the patient to afford it at home. But Dupixent, for example, is given at home. The other drugs, the Nucala and the Xolair, can't be given in the office. They can be given at home. For Xolair, that was a new change during the pandemic where we received approval to actually do it at home. There were always long-term concerns about the potential for an allergic reaction to the injection, which led us to watch patients for half an hour after their injections. This was historical, and Tom Platzmills can go on and on about it from when the FDA approval was first going in all those years ago. But essentially, we consider them to be so well tolerated that we let people do it at home. And I agree with what Puneet said. They're not really immune suppressants. We don't see increased risk of infections. We don't see increased risk of cancers. We don't see parasitosis. We don't see valley fever. We really don't see those things for people who are using these drugs, which suggests that there's other pathways of the immune system that are important for treating the other infections, and that the allergic inflammation is really specifically treatable.
No, I'd agree. I think Tara and Puneet gave a great overview of the major issues. Just a couple of things to add. I would agree that biologics tend to be amazingly well tolerated, and I think the home use has added a really nice dimension for patients. You know, initially when Dupixent came out for home use, I was worried that patients wouldn't embrace it. They wouldn't want to give themselves injections. I was very wrong. They were very happy to do that. Once we taught them how, they were great. You can see some injection site soreness. We see some conjunctivitis sometimes. There actually is a phenomenon with Dupixent where the eosinophils may rise transiently. And so depending, and that's one of the reasons I measure them, just because if they're very high to begin with, I might choose an anti-IL-5, depending on whether allergy is prominent or not, in that patient who has polyps and asthma, which is usually my scenario. And the reason that the eosinophils go up transiently with Dupixent is it inhibits eotaxin. So it's just an eosinophil trafficking issue, and it's transient, but it's something that I just tend to monitor. It doesn't happen a whole lot, but that's something unique to Dupixent. But otherwise, like Tara mentioned, there's not a lot of lab monitoring necessarily to be done while they're on the biologics, other than sometimes we want to be sure their eosinophils are low with the anti-IL-5s, because they should be if the drug is working. You know, long term, I have taken some patients off biologics. You know, because Xolair's been around such a long time and we focused on that for many years, there was a time when we felt that it wasn't as efficacious for some patients. Over time, there was almost a tolerance, if you will, to it. And then when we would take the patients off, they would develop this rebound where they would have a very significant increase in symptomatology. So clearly there was some benefit. It just wasn't necessarily quite as robust as it was earlier on in the course. And so I haven't seen that with the other biologics. They haven't been around as long. And so I like the fact that, Tara, you have patients on too, because I do think there's a place, depending on indication, you have to consider cost and what the patient needs. I would see a combination would be very nice. Just because even a single round of oral corticosteroids can increase one's risk for sepsis, and there's a realization now that oral steroids, however, it's really a lifetime exposure, but even one course is actually quite detrimental long-term for not only the risk of sepsis, but, bone, eye, things like that, that really do, that are clinically significant. So I take any time a patient needs a round of oral steroids is quite serious, and I consider them for other therapies.
Very good. Well, I wanted to leave some time for questions, but I just wanted to give this excellent resource, particularly with Zara here. So Zara's on the committee for the allergy and immunology for our ARS Society. And so the group as a whole came up with this handout, so these questions on shared decision making. And I think this is important. So if you're uncomfortable asking these questions or giving this information, there are handouts that are available. I would lobby the ARS to actually make like a physical paper handout, because I think it is important. I had to kind of look through the newsletter and find these areas. And this was in conjunction with, I don't think it was with the Quad AI, it was with another allergy association, I think. But yeah, it was very helpful to take a look at. So now, if there are any other questions, we have about 5 minutes. We'd be happy to take them. We've got an expert panel here to help answer them. Yes, up in front, please.
So what is the role of systemic steroids? Are we done with them, or perioperative use, or do you have to use them at all? Or?
So the question is, what is the role of systemic steroids, specifically for sinus disease with nasal polyps? I actually use them quite extensively, to tell you the truth. I probably use them more than I should, especially now having heard Monica's talk as well as other talks. And this is coming from a person who gives lectures on informed consent for steroid use, right? But, when you get to a point where people are so symptomatic, it's so tempting to go to that because it'll work. And oftentimes, at least for me, for biologic therapy, it can take anywhere from 6 to 8 weeks or maybe even more to get to that point. I always caution patients. I don't know if this is correct or not, but I always tell patients, my go-to is a Medrol dose pack. I always tell patients to kind of take that day's dosage in the morning, because otherwise they have severe insomnia. But I also look at my patients quite extensively. So I think there is a little bit of a difference for like a 45-year-old male, relatively healthy, versus a 95-year-old female, osteoporotic. And so, yeah, I think I should use it significantly less, but I do use it. How about you all?
Well, I think to some extent, you can't always avoid it, because some of these patients come in and see us and they just can't breathe. And breathing's really important. And so I was talking to a patient about this like 4 hours ago. She said, well, what do I have to worry about the steroids? And I told her the long-term effects. I told her the short-term effects. And I said, but right now, this is the best thing that we can do for you to make you breathe better. And so I think you can treat people when they need the treatment, but adjust their maintenance therapy so that they don't need the steroids as frequently. And I think that's really our approach.
Right, I think you're right about that, Tara. I have a love-hate relationship with oral steroids. I have a patient right now who I'm really trying to get approved for Dupixent, so he's on. But he goes away for military service intermittently, and he exacerbates about once a month. And I need to have him in one place long enough to get him the Dupixent approved and get it in before he leaves again. And so this is a real challenge. And so, I had no other option. He was so symptomatic. And so you do what you have to do to treat acute symptoms and try to minimize that exposure. And then, like Tara said, really alter their maintenance therapy to try to avoid it in the future.
So I'm a little different than you guys in that I really do avoid systemic steroids at all costs. I certainly sometimes still give them, but I would say it depends on which symptoms you're trying to manage that you can't manage any other way, right? So if it's a lung issue, then certainly, that's what you got. But if it's a nasal breathing issue, then I'm much more likely with that particular patient to have a conversation about the risks of a steroid taper, the lifetime cumulative risks, keeping in mind how many steroid tapers they've had before they even saw me, which in my practice is usually quite a few. And I'm much more likely to offer an office-based procedure where I just mow up the polyps, which is like very low risk in my hands. I can numb them up and they tolerate that really well. They don't have to take off work. They just see me and they're going home the next day and they can smell again, they can breathe again, and those tend to be the major symptoms. you know, obviously it's not going to fix their CRS with polyps. If you haven't opened the sinuses, or if they've had surgery before, you haven't taken out all the sinus from every nook and cranny, then that's not the same thing as sinus surgery, like a good complete surgery. But I do a lot of office-based procedures, and for some patients, in particular these patients, I think that's a much better option for them, a much lower risk profile in my hands.
I think I'm probably in between Eugene and Zara. I still like steroids. I don't do preoperative steroids. I haven't done it for the last 6 years, even with the worst polyp disease. I think that's, in my head, it just goes into the cumulative dose of steroids I have. And sometimes the residents ask, why don't we give steroids? If we went to talking, it would make the surgery easier. I was like, well, it would be, but then, you know, we got to think about the amount of steroids that we're getting for polyps and that they're getting for asthma as well.
Yeah, and I would just mention that the studies that suggest that preoperative steroids make surgery easier don't take into account the fact that almost all rhinologists, I think at this point, have switched to using topical epi during a procedure, which like completely cuts down really any blood loss. You have a great field. You're not, you know, operating on a bloodbath regardless of how many polyps you have. So I don't actually think that data is current anymore.
Very good. Any other questions? Yes, sir. In the fourth row. Yeah, and then you'll come afterwards. Yeah. Yes.
Yeah, not that I want to pin Dr. Carr down, but you know, it's the AERD patients we have the greatest trouble with. And if you had an AERD patient, and the major problem was their polyps, not the asthma so much, and you're at the point where you're going to choose a biologic agent, which one are you going to use?
Dupixent. Yeah, this was the first one that we started using for nasal polyps that we kind of developed a love for because it worked so well for so many of our patients. Not that it's magic for everybody, but it does work so well for so many of our patients. The data for AERD is really good. It works for those patients as well as it works for other patients, at least in my population. So it's kind of an easy choice. Yeah.
It's interesting when you look at those first studies, AERD patients were actually initially excluded because they thought, man, if we're going to get this through FDA, we don't want to pick the hardest patients. But then I think what we found is that, you know, the most difficult patients get the best relief, right? And so, yeah, very good. Yes, sir, the gentleman behind.
Dr. Carr, is one of the biologics better for chronic idiopathic urticaria? Which one do you use for that?
Yeah, so omalizumab is our go-to for chronic urticaria right now. I think some other biologics are being studied, but our data and our clinical experience with the omalizumab has just been very strong for now almost 15 years that we've been using the Xolair, and a little bit less than that for the urticaria. But I just put a patient on it this morning for urticaria. I had clinic this morning, that's why I was here late. Yeah, I think it's a really great medication. It, again, doesn't help everybody, but for the people who it helps, it's really kind of life-saving. I look forward to seeing data for other biologics because there are people for whom, you know, the Xolair just doesn't fix the hives. So not excluding them, but just haven't had that experience yet.
Yes, sir. So the question again was, in those patients that have shown either via history or maybe even antigen prick testing, a significant reaction to an environmental exposure and with severe nasal polyps, would that change your management one way or another?
I can start with this because I do see this all the time. We have people in the Air Force who have chemical exposures that drive their disease. I have plenty of, you know, tree maintenance workers who work outside all day long, and people who have other occupational exposures that they can't really change their occupation. So it becomes a question of how's the best way to keep them healthy and make them able to go to work like they need to go to. So I think for those patients, we try to do environmental remediation where we can, but it's just not always an option. For some patients, if their disease is not too severe, we'll offer things like immunotherapy if we think there's an IgE mediated, like an allergic component to that exposure. A lab worker who works with mice and is allergic to the mouse urine will offer immunotherapy for those patients. But for some of these people who have really severe disease and it's just being driven by their day-to-day exposure, for me that's even more of a reason to consider a biologic because of the more kind of global anti-inflammatory effect that will hopefully keep them healthy.
And as a surgeon, I would just say those types of exposures just make me sort of push even more for them to see an allergist, because I definitely have the conversation with all my patients, but in particular those patients that surgery is great and maybe the next best step in their management, but surgery is not going to do anything to change their underlying physiology, their underlying reactivity to everything that they're around on a day-to-day basis. And so they have to think of surgery as just the next best step, and there's all these other parts of management, and they have to think about this as sort of a chronic inflammatory process that if they do something about it and they work with our allergy team, that they're hopefully going to get to a better place. But without all of those other extra things, just surgery is not going to cut it.
Well, with respect to our speakers and guests, as well as to our feet, I'd like to conclude the session. I wanted to thank you all, truly an all-star cast. A big round of applause for these folks. They took time out of their busy days to come out to visit us, so I really, really appreciate it. And we will be available for questions if you have specific ones on the Socio app as well, too. You've got my email address as well as Chris's email address, so if there's a burning question that you think of at midnight tonight, feel free to contact us. We'd be happy to get to it. Thank you again.
Thank you. Feel free to find me.
Thank you. Yeah, of course. I'm glad you could make it. We invited you last time, but you had a big talk.
I don't know what it was. This is great.
Now, are you done for the day, or?
No.
No.
Although just a little bit more. It colors and makes. So I picked them up about 6. Thank you for that.
such faith in you. I think this person can't be telling the truth. Wow. Do you do the warm shower? No.
Does that help? I used to put caffeine in it all the time too until I learned that. But like anymore, I just said I just feel like dinner, but I'm looking at them. I don't need to take them out. They're expensive. Once you do it, you got over the, you got to get over like 3 of them. I love that sushi too.
But the purpose of that is just to medialize the material. Right, but you don't use any of the, the Flow or Sign Flow or any of that? Because I use that. Because of,
So we're almost through our first day. Boy, this has been a terrific day. We've gone through and covered a lot of great, interesting topics. For the last session of today, we're going to devote it to COVID-19 and otolaryngology. And so I get it. I think a lot of us are a bit tired and there's a certain COVID fatigue. But, you know, I think that for most of us, you know, this pandemic will really mark, you know, a key point in our careers and even really in our lives. And so as we now about hit the third year of this pandemic, I think there are some interesting things that we can talk about and look back and reflect on. And so with that in mind, we're really lucky to have Dr. Zara Patel here. When we think back to 2 years ago, and there was so much that was unknown about COVID-19, and really not really understanding how it might, you know, impact not just our lives, but as otolaryngologists, our actual practices. And so really it was Dr. Patel and the group at Stanford that really were, you know, out there at the very beginning. And I remember listening on, watching their streaming town hall in March of 2020, and really just, you know, hanging on every word in terms of the things that they had already learned in their early experience with it. And Dr. Patel, as you already saw in the earlier session, has continued to be a leader in research in other areas with regard to, you know, the impact of COVID-19 on our practice of otolaryngologists. So we've asked her to give an update on COVID-19, and I'm really looking forward to that. So Dr. Patel.
Thank you so much. And I, like you and all probably of you here, am also tired of COVID-19. But I do think that there is, you know, it is important, I think, to just sort of stay up to date on what's going on. And our dean's office in our School of Medicine has asked me to give them these updates every 2 weeks, so I make them. And so I do put it out there on YouTube and on social media just so everyone can sort of see what's been going on. It disappeared for some reason. Just try plugging it back in. I think so. Yeah. I could try a different one. While he's doing IT stuff. Oh, I don't think so, but I have my charger.
Yeah,
Let me get my charger just in case
'cause
it died.
It's not a... Yeah.
Okay, well, hopefully that'll fix the trick. But yeah, I do put these out every 2 weeks, and you know, you can follow along on YouTube if you want in the future. Hopefully, I'm super hopeful that maybe at the end of this surge, we won't have that much to talk about moving forward. That would be amazing. There we go. But I'll just kind of keep you posted right now on where we are as far as this pandemic is concerned. And so just to give you an idea, when I put these things together, the focus is on global, national, and then I do have a sort of narrower focus on California and the counties right around Stanford, because that's what I'm supposed to keep up on. But I have asked the organizers where you guys are all coming from, and not everyone submitted where they're coming from, but there are some people from Arizona, New York, Texas, and Utah, so those are 4 other states that I intermittently will just show you kind of things that are going on in those areas as well, okay? So this is just kind of an overview about what's going on. Thankfully, globally, the peak does look like it has occurred and that we are coming down, but hotspots still remain, and I'll show you that. Cases are nicely decreasing in the US and California. Hospitalizations are also decreasing. And vaccination, unfortunately, is decreasing. But mortality, because that tends to lag behind the cases and hospitalizations, is still rising. So I'll start with just talking about variants. Now, all of you know that the variant of the day is Omicron, and it's really wiped out all the other variants right now. You can see in the US, definitely over 99.9% of all cases are Omicron. It really has completely outperformed any other variants right now. And you can see that, I don't even know if you can even make that out from in the back, but there are some tiny little slices of orange which are still Delta, but they're almost non-existent in any of these circles remaining. And when you look at Santa Clara County, which is the county that Stanford is in, you can see that although the overall cases of Delta are more, Omicron has had this very rapid surge in just the last month. So, of course, what everyone's talking about recently is this variant, right? Some people call it the stealth variant, BA.2. Now, we in medicine and public health who've been following this know that BA.2 has been there since the beginning. Since the very beginning that Omicron was identified in South Africa, there was BA.1, .2, and .3 all at that same time. And in South Africa, BA.2 did not outperform BA.1. But now, in multiple areas around the world, in particular areas like Denmark, for example, BA.2 is rapidly outperforming BA.1, and we're not exactly sure why it's different in some areas of the globe versus others. But what we do know is that the transmission of BA.2, especially in places like Denmark, does seem to be higher, but that when you are vaccinated, you do not transmit it as easily. So this is just a little bit of information about T-cell reactivity. And the good news is that although, as many of you know, our antibody response, the sort of B-cell immunity part of our response, does not do very well against Omicron, either via prior infection or with just 2 doses of that vaccine, T-cell reactivity is preserved by and large. So you can see just over here, when you just look at the wild type, meaning like the ancestral strain of COVID, the Delta spike and the Omicron spike, these little grayed out individuals are reduced T-cell response. So you can see 21% of people have this decreased response to Omicron and T-cell. That's pretty good. That means 80% of people have continued T-cell reactivity even just after prior infection or two doses of the vaccine. You can see there's actually a great benefit from the booster, the 20% increase in T-cell reactivity, so that wild type and even Omicron, only 9% of boosted individuals had a decreased response. So that basically halves the number of people who will not have a T-cell response if you get a booster. So I think this is just a nice way of showing that the booster is super important as far as Omicron goes. You can see that here also. Here's another paper that was just released, and this is looking at the elderly population, meaning 65 and over, and you can really see that, if you look at days after second vaccination, when you look at Omicron in particular, you're at almost 0 this many days after second vaccination. With a booster, you come up to here. So even holding true 4 months after your vaccination, if you get a booster, you're going to be able to remain immune, which actually bodes quite well for not needing like 1 million boosters over and over. So now that we've talked about that, let's go right into vaccination and what's going on. You can see that, unfortunately, the United States is pretty low as far as first world, relatively wealthy nations. We're not doing so great. We're just over 60%. All of these other countries are doing much better than we are. You can see that at least we do have over 210 million people fully vaccinated. And what that equals is that 67.9% over age 5 and 88% of people over age 65, which is great. But unfortunately, and importantly, based on what I just told you, when you look at who has actually gotten a booster compared to the number of people eligible, only a little over 40% of people eligible for a booster have gotten that booster. So there needs to, I think, be a lot better messaging, sort of translating all these studies that we're looking at showing how important a booster is, specifically for Omicron, and then maybe hopefully getting a booster because, like I said, I hope there's no new surge, but you never know what's around the corner. When you look at administered doses overall, you can see this high variability, and really the spikes come when surges happen, and that's when people feel like they should go get vaccinated or go get a booster. And it's both ways. It's either people who have not been vaccinated before during that Omicron surge, some of them decided, okay, now's the time, and also people who hadn't gotten the booster before decided, okay, maybe now's the time. But now that we're coming down off that surge, you can see that same decrease in vaccination rate. When you look at states overall of who is fully vaccinated, you can see that unfortunately, Wyoming and Alabama are kind of holdouts compared to the rest of the country as far as their percent of residents fully vaccinated. And then there's a sort of smattering of different rates of vaccination. The Northeast and Hawaii are obviously doing really much better than all of the rest of us with really high rates of vaccination. When you look at California in particular, you can see that, again, it's kind of like stabilized and then continues to drop. And then here's where I just put a couple other states where some of you guys are from right here. So you can see the same thing has happened, really big spike in Texas right during that surge, and now it's in New York during that surge, and now it's come down. Little spike in Texas, and smaller little spikes in vaccination rate in these other states down here. When you look at how much of California is fully vaccinated, it's 73.2%. And when you look at that compared to the rest of the United States, you can see that overall California is doing a little bit better than the average overall nationally, but in our elderly population, we're not doing as well. And so again, messaging needs to happen. I think communication, there's been so much terrible, poor communication during this entire pandemic from multiple government agencies, doctors. Some doctors are doing great jobs, some doctors not so much. And it's all about really communicating what the facts are and being transparent about the things we actually know and the things that we just don't know. I think that helps. Here in Arizona, you can see when you look at by age, you can see you guys here are doing really, really well, 96.3%. Down low, less than 20 years, not doing as well. When you look at Santa Clara County, which is kind of this kind of bubble of really highly educated, really wealthy individuals right around Stanford, you can see we have a very high vaccination rate overall in the overall age group, and even very high booster uptake, 65%. When you look at the elderly population, thankfully, even though all the rest of California are not doing as well as the national average, Santa Clara County is doing better. So let's just start looking at global cases. These numbers can kind of make you go numb after a while, where you just see the numbers rising and rising. And I think what I take away from a slide like this is just that, close to now 400 million cases, but thankfully the number of deaths has not, skyrocketed with the same number of cases. And you can see this here, there's just been a 2% increase over the last 2 weeks, and really that's just because 2 weeks ago we were right around here, then it spiked up, and now it's come down. So thankfully we are decreasing off the peak globally. When you look at where our hotspots, still a lot of hotspots remain. Definitely the US, Russia has come up quickly, Australia, Brazil, a lot of South America, and Europe remain hot. And when you compare us to the EU, and the reason I do that is that when you look back over the pandemic, a lot of the time what happens in the EU then happens in the US, just with a little delay of about a month or two. And you can see that the EU was coming down off of their surge, and then they had another little spike here. Some people are theorizing that may have to do with the BA.2 variant. Some other people are theorizing that may have to do with their difference in vaccination timing and the difference in timing when they got their boosters. But thankfully, you can see at least over the last 2 weeks, we're coming down much more nicely off of our peak than they seem to be doing. When you look at particular countries, I'll just draw your attention right up here to Denmark, because that's the one I mentioned to you, that definitely they have a majority of their cases now being the BA.2 variant versus BA.1. And so although BA.2 is present in the US in most of our states, it has not yet started outperforming the BA.1 variant, and we'll just have to wait and see if that does. You can see the United States is nicely coming down, as is the UK. India is another area where the BA.2 variant is starting to rise, and you can see they have this small slope, but really nothing like Denmark. So we'll have to see what happens with that. You can also see that some other areas like Russia here and Brazil are continuing to rise. So we don't know if that's coming down off of a surge and they just haven't hit it yet, or there's a new surge starting. When we look at national cases, thankfully, this is a really nice curve to look at. Decrease of 49% in the last 2 weeks, that's great. When you look at hotspots here, I think it's, most interesting to see that these areas, especially Maine, have been relatively spared, and they are definitely the most highly vaccinated states. You can also see some areas in here that are less populated counties, which have been spared, or at least are coming down off of their peak. When you look at California, we have a really nice decrease off of our peak as well, 44% over the last 2 weeks. And then here's those states that some of you guys are from. And you can see nicely, Arizona's coming down, Utah's coming down, New York is in front of us because they were the ones that had the surge first. So they're almost all the way back to their baseline, although they have not hit their prior baseline yet. Interestingly, in South Africa, they never went back down to what their prior baseline was. They stopped a little bit above it and have a sort of endemic amount of COVID-19 going. And Texas, you can see, has a little bit of a more shaky spike, and they haven't come down as far yet. When you look at Santa Clara County, those cases are coming down nicely, as is San Mateo, which is where I live. And then if you look at Stanford, I'm showing this to you guys more as an example of what different undergraduate and academic institutions might look like, because this is mirrored pretty well across the country. And you can see that right in that first week of January, it's the red number, that's the number of cases. The blue bar is actually just the number of tests. But then the red number, you can see, really spiked up to, close to 500 that first week of January, and then sort of slowly but steadily has come down since then. And you can see that almost all of our cumulative cases were just within the last month. When you look at faculty, postdocs, and staff at Stanford, it's very similar, where right in that first week of January, we spiked up, and then it's slowly come down. And again, the majority of the cases that we've seen overall have been just in the last month. So a lot of people have asked me about pediatrics and how, this virus affects pediatric cases. And many of you might have heard of this multisystem inflammatory syndrome. I think this is a really nice graphic from a study that was just released from the CDC. And it basically just shows that no vaccinated patients who actually developed MIS-C required life support. And really 95% of the patients even hospitalized with MIS-C were people who were unvaccinated. So really only 5% of the overall patient population with MIS-C were unvaccinated. So vaccination goes a long way to preventing this in your pediatric population. Also, you may have heard of this possible increased risk of diabetes. There was first a sort of survey study put out by the CDC to sort of market survey databases where they were starting to just see higher rates of diabetes in the pediatric population. And I think this is a really nice follow-up study that was done by UCSD, specifically looking at new onset type 1, right? Because there's a lot of different confounding factors when you think of type 2. We're all much more sedentary during the pandemic. Kids are just sitting around at home. They're not going outside to play. They don't have school and like all their sporting activities during the pandemic. So all of those things could confound type 2. But type 1, there's really no reason other than an actual effect on the immune system why that would change. And you do see this very sharp rise in type 1 diabetes since the onset of the pandemic. So definitely something to be aware of and keep an eye on. When you look overall at pediatric data, up until August, really kids only made up about 15% of all total cases. And that has kind of risen up and down with the Delta and Omicron spikes. Right now, we're right about 22.8%. Thankfully, the hospitalization rate and the actual mortality rate remain very, very low. So let's go into hospitalizations overall. You can see that thankfully now we're finally coming down off of the hospitalization peak in the US as well. And in California, you can see really nicely coming down off the peak, both overall hospitalizations as well as ICU hospitalizations. And then here's those states. Arizona nicely coming down. Utah, not quite at the same level. It's right in the middle of their decrease. And New York is coming down. And Texas is just off the peak, hopefully. When it's so early, so near the peak, you can always go up again, but hopefully this continues to come down. And in Santa Clara County, we are also plateauing to decreasing. And same with San Mateo. In San Francisco itself, which had this very, very sharp spike finally, just over the last 2 weeks, we've been able to see a little bit of a decrease in those numbers, so that's really great too. And then finally, mortality. You know, there's been this continued rise because there, like I mentioned, there's always this lag behind hospitalizations and cases. So unfortunately, mortality continues to go up. And like I said, it's easy to sort of become numb to these numbers, and huge numbers like this, it's hard to kind of put into words. So about a week ago, if you look at total deaths in the US, about a week ago, that number became more than the population of the city, the entire city of San Francisco. So that gives you an idea of the number of people that have died from COVID-19. This is just sort of showing that unfortunately the US leads in deaths and lags in vaccinations among high-income nations around the world. And this sort of just mirrors what I showed you earlier as far as, you know, our cumulative deaths per capita throughout the pandemic, during the Omicron wave itself, and then the share of population fully vaccinated. Unfortunately, we're way down here compared to all other large high-income countries in the world, and share of population with the booster dose, we're even further down. In California, you can see, unfortunately, we're continuing to rise, and you can see that in all these other states, again, there's the rise there. Kind of difficult to make out what's going on with Utah. I think this is like incomplete or erratic reporting, these big spikes that go up and down. And then in New York, you can see, thankfully, they're coming down off the peak. Texas looks like it is still rising. And Santa Clara County, thankfully, is finally coming down, but it did have 36 deaths over the last week. So just to end out, you know, interesting new information about COVID is coming out every day. And, you know, this is just a really nice sort of review article that has come out in Nature, and I would sort of direct you to it. I can send you this link if you guys like, but it really goes over really nicely the entire immune response. So both that initial immune response, that is our first line of defense, our innate immune system, and hopefully what more and more people are developing with either having had the infection or getting the vaccines and boosters, but also what happens once it sort of goes overboard and what causes all this systemic inflammation and multi-organ failure and eventually possibly death. So if you guys are interested in really understanding that underlying inflammatory mechanism, this is a really good review. And then interestingly, there just came out this article in Cell, which shows this autonomous disruption of nuclear architecture as a potential cause of COVID-induced anosmia. As you know, I really love thinking and talking about anosmia. But this not only explains anosmia, but may also show the underlying underpinning mechanisms of how the organ failure happens across the board in the system. And it really has to do with these inflammatory molecules and cytokines entering into the cell, and not just the cell, but into the nucleus of the cell and disrupting the architecture of that, which is really interesting to me. So I'll leave you, with this. I have fatigue due to COVID. I certainly do. I don't know about all of you guys. And he says, I didn't know you had it. And they say, I didn't. I'm just tired of COVID. And that is definitely how I feel. And I'm sure that's how all of you feel also. But hopefully we are in the last days, seeing the end of all these things. If not, I'll keep telling you guys about it online.
So if I could get our panelists to come up. If you see your name on the program as being on the panel, please come up here. We have enough chairs for everyone. And as they're getting set up, does anyone have any questions for Dr. Patel?
I can't hear you, Eugene. I'm so sorry.
Is this?
You can just tell me now. Now I can hear you.
So we see this on the east, the west transition,
Yes.
like New York,
Yes.
California. I mean, it almost feels like really,
Yes.
why do we see that? And what can we like learn that from us?
Yeah. So for anyone that didn't hear, he's just asking about this east to west transition where we see the surge happening in New York and East Coast, and then it slowly moves across the country like this. And the most likely reason is that we have, when these variants arise outside of the U.S., the entry points into the U.S. are the areas where we see this most. And so New York happens to be one of those entry points. And it does happen to be one of the most densely populated areas in the entire country. So if you're going to see entry and you're going to see rapid spread of a variant, you're going to see it in the most densely populated area where that virus enters the country. And that's most likely why we see that sort of New York's first, and then it spreads to the rest of the country. If you recall from the initial ancestral strain, it actually first hit Northern California. That's where we first saw it, and Washington State. And that's probably because it was the Asia to the US entry of the virus in these more densely populated areas like San Francisco and Seattle. And then we saw the sort of wave, and then it finally hit in New York where it was the most densely populated, and no one was prepared at that time, no PPE, no vaccination, anything like that. And so again, we saw a really large surge.
Well, terrific. So we'll definitely have more time for questions, but let's go ahead and get the panel started. And so I think you've met most of the people up here, but let me introduce a couple people that you haven't met yet. So just going across here, obviously we have Dr. Patel, Dr. Helena Yip, and then next we have Dr. Sheetal Borelli, who's you'll see more of tomorrow at the head and neck oncology session. We have Dr. Audrey Baker, who also will be tomorrow morning in the head and neck session. She's also our residency program director, so we may have some questions about the residency training aspect of the pandemic. And of course, Dr. David Lott, and Dr. Chris Lay, and Dr. Eugene Chang, who you just met as well. So I wanted to start out by talking about tracheostomy for COVID patients, and really, I think, reflect a bit on perhaps, I don't want to put words in people's mouths in the panel, but perhaps how our thinking about tracheostomy has evolved over the past couple years. These are photos of Dr. Baker and myself doing the first tracheotomy that we did on a COVID patient. I think this was around in late April of 2020, and we went in with full PPE and PAPR gear. I think that's an interesting story itself, but let me just skip to just talk about like indications for when it's appropriate to do tracheotomy on COVID ventilated patients, and start with anyone here. How about you, Dr. Baker? Because you kind of led the team here at Banner on this, and actually, I mean, that could be a whole story in itself, but I mean, I think it was actually a great way of how we worked, with across the hospital. So it's actually across the whole Banner system in developing a protocol and developing a team. But tell us a little bit about that story, Dr. Baker.
Well, in the beginning of the pandemic, when nobody really knew what was going on and nobody was vaccinated, and at least personally, I thought we were all going to die a horrible death. There were some funny things happening in our hospital and also Banner, nationwide, that there was, pockets of, I think, very safe practices and other pockets of less safe practices. And at the time, we didn't really know what we were dealing with. So I think the indications for a COVID tracheostomy in the setting of COVID pneumonia have changed. Now that we have vaccines and now that we understand that maybe these aren't as aerosolizing procedures as we thought they were after somebody has been infected for so long. But in the beginning, our department stepped forward and said we would really like to lead this charge. We think we can do it safely. We think we can do it efficiently. We don't want to drag these patients through the hospital and, fling their virus particles all over the elevator. So we'll just come up to the bedside and we'll do it there. And we all felt pretty good about that. Our interventional pulmonologists and our trauma surgeons were also on this team deciding that, yes, that sounds good. Our ear, nose, and throat colleagues, yeah, you do that. That sounds great. And we were happy to do it. At the time, I had read this really wonderful article by Atul Gawande in the New Yorker at the very beginning of the pandemic. And he attached all these pictures of Wuhan, China, and all of these people in like head-to-toe gear. And he called it going full Wuhan. And I said, yeah, that, I want that. So we're gonna arrange our group. We're all gonna be in full Wuhan, and we're gonna wake up at 5 in the morning and trach all of your ICU patients. And that's what we did. At the time, we thought, okay, let's not trach anybody who has a pretty good chance of dying, because we don't want to like trach them and give everybody COVID and then they die. That sounded bad to us. But we don't want to trach them too early either, because at the time we thought they were really severely like infectious. So we waited 21 days, and we were hopeful that their COVID test would clear at that point. But now we know that none of them clear. None of them clear for weeks and weeks and weeks, and they're probably not even infectious after 5 days. So I think that time point has rapidly decreased. And now, if we get a consult for COVID pneumonia, we're happy to take care of it like any other tracheostomy consult. Like probably 3 to 5 days of being intubated is probably correct. And I know Dr. Yip will talk about some of the late effects of tracheostomy and some of these prolonged patients that I really sat on for a long time. Me personally, I said, no, we can't do it before 21 days. And I probably caused those patients a lot of unnecessary tracheal stenosis. But again, historically at the time, we thought that was the safest thing to do. So at this point, performing a tracheostomy on a patient with COVID pneumonia is very different. First of all, it's almost always the pulmonologist. They've, again, taken over the trach care in the ICU if they have a problem, or if the neck is very thick and they don't, for like normal trach consults, they'll call us. And we're happy to roll them down to the operating room. We're happy to have their virus flinging all over the hospital, because we know now that doesn't happen. So at the time, we were really proud of our team and what we offered to the hospital in full Wuhan. And in hindsight, it was totally and completely unnecessary. And that's my story.
Anyone else on the panel want to share their experience in terms of the early days? So, I think it sounds like, and feel free if anyone disagrees, but I think our thinking has evolved on this. I think another important point is that the reports of the mortality rate on people with COVID who got ventilated were really bad in the early days. We're talking about, in some cases, 80% in terms of those reports coming out of New York, for example. And so, I think in some sense it's reasonable. Just like we are always been with trachs, and we don't like traching people who, end up dying the next day. So we wanted to make sure that we were choosing candidates that were going to make it, and I think that's also another point.
I'll just add, even though I'm a rhinologist, I'm just going to add one thing, which I think this story really demonstrates really nicely, is that doctors and scientists work with the information they have at the time to do the best they can. And there's so much criticism out there looking back, like, oh, did you really need to do that? Or what happened to all these patients? They got stenosis. But really, I think everyone did the best they could at the time with the information they had at hand. And that's really how science works. We change what we do based on new incoming information. And thankfully, people, aren't as sick now because of all these other things that science has given us. So I think that really demonstrates that well.
Well, Audrey, I don't think you need to feel guilty. I don't think there's any true correlation between the length of intubation and the stenosis. I'm seeing patients that are intubated in July or October. This was like 11 or 12 days of intubation. They're still coming in with awful subclinic stenosis. And I'm not sure if it's the underlying morbidities, they have diabetes, or maybe they had to be lay prone, and maybe it's all this positioning thing. And at the beginning I thought there was, but I didn't have a large enough collection of patients to work on. They tend to have multi-level stenoses. Their stenoses are very, very hard to treat. So they're not even tracheal resection candidates. I'm jumping the gun a little bit, huh? So anyways, their lungs are shot. So they're, no, I don't think you should feel bad. You did what you could.
Well, so that kind of leads to the next kind of issue question I wanted to pose. But, I think probably all of us are seeing a lot of now fortunately COVID patient survivors who are having issues because they have a history of either intubation or tracheotomy. And so I want to just talk a bit about some of the post-COVID complications that we're seeing. And I think a lot of times we don't know. I mean, I actually start out with the question of, are we seeing this simply because a lot of these patients got intubated and trached, or is there something specific to the pathophysiology of COVID that seems to, at least in terms of what we seem to be seeing, a lot of folks having some of these complications. I borrowed these from Dr. Yip, but this is an example of one of the a very typical patient we're seeing of someone who had a history of intubation, and then here they have, immobile vocal cords. I think in this case it was due to scarring. And then another example here of a patient with a tracheotomy and a complete stenosis of the subglottic airway. So Dr. Yip, want to share your experience with this and your thoughts on it?
All I can say is I'm swimming in these pathologies. My practice has changed completely. Probably half of my practice is made of these patients. And I'm thinking about shifting those patients to Dr. Lott so that I don't have to deal with them anymore. They can all get 3D printed laryngotracheal complexes. They don't have to beg me to decannulate, and then they come in a few days later, striders and about to die. So anyways, no, I don't know. It's a good question. I'm seeing so many of them. And I don't think our standard of care has dropped. The length of intubation certainly has come down. And yet, even with just a limited amount of intubation, they're coming in with horrible, horrible stenoses. And they're not amenable to debridement. I mean, theoretically, you could debride grade 2 and grade 3 subglottic stenoses and maybe manage them that way. But these patients have florid granulation tissues. And the problem is, if you want to use laser and you want to lower the FiO2 on these patients, they do not tolerate any lowering of the FiO2. You drop it to 50% FiO2, and the SAT starts to go down. And I have no time to work on these patients at all. Even a trach change, a simple thing like a trach change, the other day I had to do in the OR on this patient, and she dropped her SAT quickly, and I tried to do a DL on her to work on her total subglottic stenosis, and then even the act of putting the laryngoscope in her mouth led to desaturation, so I couldn't do anything. What about your experience, Dr. Lott?
Yeah, I would say that our experience is similar to how you're describing it. It's a different disease process, I think. With the virus affecting the airway and lining the airway, it is a unified airway, right? So that's why sinuses, trachea, lungs, everything is affected to some degree. And then you add intubation trauma. You add turning the patient prone, which I think has a significant effect on different pressure patterns than we typically will see. Higher incidences of post-ergotic stenosis or diastases, like you mentioned earlier in your talk. And so it's just a different beast. And so I think we have to try to understand again, what is the disease process? You have an inflammatory disorder that has traumatic components to it, and it's going to act very differently, and they're not going to respond as well. I don't know how long it would take. If you waited 5 years until they were completely cured of the inflammation or whatever the disease process is gone, then maybe they act normal again. But you can't have patients wait 5 years. And so what do we do in the meantime to try to get that to come across? And nobody knows.
I'm wondering, listening to you guys, at Stanford we have a post-acute COVID syndrome clinic. I don't know if you guys have something like that here. And it's really interesting as an otolaryngologist. I'm just part of it because of the smell aspect, but listening to our cardiologists and our pulmonologists talk about all the different tests that they are running on people and all the ones that are normal. And the review article I was just mentioning about this nuclear inflammatory disruption that happens, I think may explain a lot of the long-term inflammatory effects that may not necessarily be explained by just duration of trach and things like that. And also, as I think all are seeing, there's a post-viral effect on all cranial nerves, so things like vocal cord paralysis. I had a vocal cord paralysis when I got COVID. That's something also that you see.
Well, obviously, you've recovered very nicely. So we do have a long COVID Center for Excellence. So I'm on it, Dr. Chang's on it, and Dr. Wong's on it. I guess
Just what you want your hospital to do to declare themselves a COVID Center of Excellence.
So I'm actually not sure what I can do for them. But so they get sent to me for dyspnea. So that's after the patient has been through all the other subspecialties and they can't find anything wrong with them. So then they come to me. So some of them already have a trach in and they're very short of breath. I really don't know what to do for those patients. So there was a woman who came to me with bilateral cord paresis with the cords fixed kind of in the open position, but with a very small glottic gap of maybe, 2 millimeters. She was only 45. In a normal situation, people could get by with that kind of glottic gap, but she was so short of breath. She begged me for a trach, so I did it. And then even after she got the trach, she said she was still really short of breath. She's getting pulmonary rehab. She's slowly getting better. She said she could work herself up to walking the grocery store now, but that's more than 18 months out. So yeah, there's still a lot we don't know about it. But I would say in these patients, you don't stress them to the limit like you would for a normal patient. So if someone is telling you they're dyspneic and they're dealing with a limited glottic airway, I would say go ahead and trach them. Even though I hate doing trachs, I wish I would never do a trach again. If I trach somebody, I would never decannulate them again. So anyways, what other pearls? So I have patients with tracheal stenosis. I want to refer to Dr. Borelli for tracheal resection, but they would not be able to withstand any kind of being off the ventilator for even a microsecond. So forget about it. So these patients, I just tell them, look, this is your trach. You got to live with it. And if you don't have a voice, I'm talking about patients with total subglottic stenosis. Those are highly frustrating cases. You tell them, look, you need electrolarynx, or you need to learn esophageal speech. They're like, no, I want my larynx out. I was like, do you understand what that means? They're like, no, not really. There will be a hole in my neck. Can you sew that up afterwards? I was like, no. So, anyways, I think there's so many aspects. There's a cognitive aspect too. So people talk about brain fog. So I think, you definitely need a multidisciplinary approach, but someone's got to be managing these patients. And I'm not sure who's really taking charge and managing all the different aspects. So that remains to be seen.
So this is kind of what I'm hearing. When we look at these patients that have some of these intubation or upper airway complications, perhaps in the early days, maybe it was because we were leaving them ventilated too long. I know some of the management of the vents was done differently because of safety issues. Dr. Lott mentioned the proning, and so those may have contributed. But what I'm hearing is it seems like it's more than that. There definitely seems like there's some COVID viral specific damage that seems to occur with the upper airway, and it really leads to a couple other topics of long COVID that I want to talk about. One we've somewhat dealt with already, but there is those folks who have symptoms that don't actually have anything anatomically wrong. I showed the vocal cord immobility, and I showed the subglottic complete stenosis, but perhaps the more challenging and frustrating patients are those that have dyspnea of unclear etiology as a post-COVID syndrome, and anatomically we can't find anything wrong. So does anyone have any thoughts about that?
I can just share with you what the pulmonology and cardiology colleagues in our long-term COVID clinic are sort of zeroing in on right now. They, in some patients, they'll do an echo, they'll do EKG, they'll do, chest CT, and everything is totally normal. And these patients are just like panting in the office. They're so out of breath. And I am not good enough at VQ physiology anymore to explain what the actual finding is, but there is a finding if you combine some of these tests together that basically demonstrates the same thing that patients with mitochondrial myopathy show. So they think that maybe that is something like a pathway that's happening. They're using mitochondrial myopathy patients as a sort of testing ground for what helps and what doesn't in these COVID-19 patients. And so we don't have enough data yet to know if that's something that's a good lead to follow or not, but that seems to be the closest thing that this dyspnea of unclear etiology mimics.
Yeah, one of the other things I always, again, I have no way to prove this or know if this is true or not, but just always thought, is this also maybe a sensory disorder? Where, again, if you have the lining of the airway, you have inflammation, you're going to have some resultant scarring. You're going to have some damage to the nerves, just like your vocal fold paralysis, temporary. And you see the same thing. So if the sensory nerves are damaged, then you're not going to sense that airflow quite as well, and you're going to get a sensation of dyspnea. Everything checks out well, you're breathing fine, things look good, but you just don't sense it. So I wonder if maybe there's a sensory component to that also.
Yeah, that definitely could be a component. And actually, there's this global chemosensory research community that I'm part of, and one of the things that they actually showed was that it's not just the olfactory nerve in the nasal cavity that's damaged, it's the trigeminal nerve as well that shows. So the chemesthesis is actually damaged. So that totally goes along with, it's trigeminal all the way through here, but also sensory nerves down in the upper or in the lower respiratory airway also, I'm sure, are having effects.
I like how you describe the larynx and upper trachea as the lower airway. Only a rhinologist.
All right. Well, we talked a bit about anosmia, and I did not even realize what a love you have for anosmia, Dr. Patel. But you mentioned a little bit about some of your ongoing research. As someone who doesn't know anything about anosmia, I asked a sort of more simple question. Is there hope for these folks?
Yes, in general, I think there's hope. I think you all probably know 70 to 75% of people with COVID-induced anosmia will actually spontaneously recover. So it's this last 25 to 30% of patients really that we're talking about that don't have a resolution. And the most unfortunate thing about this particular group of patients is that not only do some recover but then have a secondary loss, but also people in much larger numbers than prior post-viral losses are showing parosmia and phantasmia, so distortion of smell. And that, as you can imagine, is much more sort of crippling for people. They stop eating, they stop drinking, they stop going outside, they can't wear half of their clothes because of the way they smell to them. They really become almost agoraphobic, like they cannot interact or deal with their normal lives. And so I know that's kind of a downturn from your is there hope, but I will say that the silver lining of COVID for me and for all these patients is that now there's so much more interest in anosmia and parosmia and hyposmia, and so many more people are doing research in it, not just ENTs, but neurologists, basic scientists. And so yes, I think there's hope just based on the entire world of scientists that are now focused on answering this problem.
So, that sounds, it's very good news to be able to assure patients that the vast majority of them recover. Is it pretty much spontaneously, or is there a role for interventions in anything that you recommend?
Yeah, just from my prior talk, the things that I tell people to do as soon as possible, even within that first month where a lot of people will spontaneously recover because you don't know which one you're going to be, you don't know which way you're going to go, and the sooner you start definitive intervention, the more likely you are to be able to have an effect. Olfactory training, budesonide irrigation. I mentioned the omega-3, although I do explain to them that that's an extrapolation from the other patient population, and it has to be high dose. And so if they have bleeding disorders or are on other blood thinning agents, they shouldn't do that. And then, I'm currently doing this PRP trial, which maybe that will offer something in the near future. I don't know yet whether that's going to show benefit. And then in the far future, maybe, different sorts of gene therapy, stem cell therapy, electrical stimulation, all those things are maybe going to be there.
So Dr. Lay and Dr. Cheng, I know you two fight over who can see the anosmia new console patient, but any pearls you want to share?
Honestly, I think it was a lot to listening to Zara's talks and her prior manuscripts on this, but really it's smell retraining and then budesonide irrigations. And I think the one thing with budesonide irrigations, and we all do it for our POL patients, sometimes it's hard to get approved for our patients with anosmia. So I tell them a lot of times, you know, your insurance probably will not approve this for anosmia, so we have to go to a third pharmacy or a third-party pharmacy or a compounding pharmacy. That's the one thing I tell them, because then they're like, oh my God, it's $600 from Walgreens, I'm not going to do it. So I tell them up front, you know, here's a pharmacy that could do it, and you may not get it approved. So I think that's the one thing when Eugene and I are probably telling them that.
Yeah, and I'd like to mirror that. I think although olfactory training I think is very hopeful, what I tell patients is olfactory training is not going to get your sense of smell back. I think what it does is it helps your appreciation of smell. And so it helps you to be more insightful about it, and then potentially to be able to pick it up at an earlier stage in my thoughts. We've been trying to couple olfactory training with also other senses, so potentially if there's lavender or rose, you know, having people take that item as well and then smelling it at the same time. I think there's coupling that potentially helps. And then to go back, I apologize to go back about the trachs, but I think what Audrey had mentioned, I think she's really downplaying your folks' role in trachs. So again, you know, to take us back to when this first started, there was so much information, and you know, Zara had come out with a report of patients and people who were undergoing surgery, and then the surgeon got COVID, and then the med student got COVID and died, and we were all freaking out, and we were going nuts. My wife is an ICU intensivist. She had started her new job 2 months prior, and every night she would come home, and she'd be crying and telling me stories of, like, you know, 26 patients, 30 patients, you know, talking to patients about letting go of people. And so what I would say is that when you're exposed to an incident like this, there are people that like run to a fire, and then there are people that run away from a fire. And I always thought I was a person that would run to a fire. But then when this came about, I was like, holy crap, I'm going to run as far away as I can. But what I will say is that Audrey, Chris, Sheethel, Steve, and other members that I probably don't even know about, they ran to the fire. And it was, you know, it opened up certain possibilities for me. I mean, I am really interested in viral research. I'm really interested in pathophysiology. This was a cool opportunity. But when it came to that, I don't think we should discount the real efforts that you guys made. I remember seeing Chris, you know, you were all suited up, and you were doing trachs in an ICU with no light. No light. And these patients were like 400 pounds, remember?
No headlights, you see there.
No headlights. So I mean, I think that it brings out the best of us. It also brings out the worst in me. But yeah, I mean, I would say
the room lights were on.
The room lights.
Just no, we mean no headlights. But that's how Dr. Baker operates anyway. So it's yeah.
But yeah, what I would say is, you know, we're seeing the long-term outcomes. But yeah, I mean these people were truly heroes. I mean, you guys did an amazing job, and it was pretty inspiring to see. And if I just to mirror Helena, and the residents know this as well too, if I never have to do a trach again, that is the happiest day of my life. I always try and avoid those things as much as possible. But yeah, I mean, it was something that was life-saving for a lot of people, and thank you again for doing this. Yeah.
Eugene, if you think that speech will get you out of taking call, you're wrong. You still got to take call. Let me open up the audience and see if you have any questions, or if you want to share any experiences that you may have with this patient population. Yes, please.
I could just speak loudly also. So yeah, so for the parosmia or phantosmia, if there's any particular option. So unfortunately, there has not been a lot of research into that area. I am currently running a trial for those patients also. It's basically a 3-armed trial looking at the use of neuromodulating agents. So for example, amitriptyline, gabapentin, or placebo. And I'm just starting that trial now, so I don't have any data to share. But anecdotally, from my past, post-viral phantosmia and parosmia, there is a select group of patients that do seem to benefit from those neuromodulators. Not all of them, and I don't know yet how to separate those out or select for the ones that will respond. But in general, if it's something that you are going to try, you would just pick one of those. You would start at the lowest dose. And then for all patients, as you guys probably know, there's a wide dosing range for things like gabapentin. So I start at 100 milligrams TID, and then I slowly ramp up, and I have them message me basically once a month to let me know, are they having any improvements or are they having any side effects? And in some patients, you can get to that sweet spot where they are starting to have improvement, but they don't yet have any side effects. So again, that's sort of a very small, anecdotal sort of summary, but there isn't a lot of good data yet. But hopefully, as more research continues, we'll see more.
Yeah, Tom.
Yeah, so you guys can feel free to chime in at any point, so yeah, I basically tell them they can get it anywhere. They can get it online, they can get it at an aromatherapy store, they can get it at Whole Foods. I emphasize the fact that it doesn't have to be a kit, and it doesn't have to be like expensive or pure or anything like that. There are lots of organizations that are selling kits in order to make money, but you don't need to pay nearly what those kits are going for to just get some essential oils. I do have a handout that I give patients, and I do take a lot of time. These patients take a ton of time, unfortunately, to talk to. That's why I limit my smell loss clinic to just 1 clinic a month. Otherwise, they would just overrun my practice, and I'd always be behind. So basically, it's just you start with them with those 4 odors, the rose, lemon, eucalyptus, clove. You tell them it just takes 15 seconds, just breathe in and out. What's the most important part of olfactory training is that they focus their memory on what that smell is supposed to smell like to them. That's, the part of retraining the brain, recreating that pathway. And then I have them do that, twice a day, and I have them do it for 6 months. And I do emphasize the fact that they're not going to be able to smell it for many, many months, and that it's going to be only towards the end of those months that they're going to start really getting a benefit from it. So they have to stick with it, because again, if they fall off and then want to start later, they've lost that time, and time is of the essence in getting the smell back.
So Tom, what I do is, I think Amazon has all of these kits available, but what I do something a little bit different. So I tell my patients, I say, what are 4 odors that you remember the most, or what are the 4 odors that are most important to you? And then I have them use those. In regards to the phantosmia and the parosmia, this is, I think of it as a synkinesis issue. So what happens with the virus is it creates this massive inflammatory cascade. All the olfactory receptor cells or supporting cells, not necessarily the neurons, but the supporting cells die. Then those neurons die, and as they regenerate, as Zara so thoughtfully or so eloquently talked about, typically in 2 to 3 weeks, those connections can then get miswired. And so every odorant is actually, it's not like you don't have a rose odorant, right? Rose stimulates olfactory receptor 1, 34, and 75. So it has to stimulate all 3, and it's that combination. So if one of those are off, then it's a weird odor. It's not a rose. But that's where I think olfactory retraining is really important, because similar to facial reconditioning and facial rehab with synkinesis that you see, if you can get your brain to start thinking, yes, now it's not 124 and 45, it's 124 and 36, but this is what a rose should be like, and you can start retraining. I think that's where that rehab, I think of olfactory training as rehab, not necessarily regeneration.
Yes.
Any comments on the hysteria or COVID vaccine, and more specifically,
We have no otologists on the panel, but I think it's a thing, right? Tinnitus, that's a thing after vaccination. And then since renewal hearing loss from just what I've heard from friends, it's a thing. And I certainly have heard patients coming in telling me that other ENTs have told them that it was attributed to the vaccine. So I don't know enough to comment, but I would hesitate to attribute anything to the vaccine. People have mentioned all kinds of side effects, like infertility and all that stuff. So I would just try to squash it.
So I'll just say that, again, I agree that there's not a lot of good data that we can actually point to. I would say almost every single symptom that you could potentially attribute to the vaccine and your body's immune response to it is 10 to 20-fold more likely from a COVID-19 infection itself. And so really the vaccine is, preventative for the vast majority of people. Now, is any intervention without risk? No. And so you can't tell a patient that, no, that wasn't from the vaccine. I don't think that we have that data to say that definitively. And certainly our immune response to the vaccine, an immune response to anything can cause inflammation in around nerves and cause things like that, right? We know that. And so I would just be as transparent as possible and just say, this is what we know, this is what we don't know. I would still recommend getting another dose because the incidence of that causing that again is highly, highly unlikely.
So we're actually going to come back to the topic in just a bit, but first I want to move on and talk about maybe a little bit of practical things, and this would be also great to get some people from the audience to share, but certainly this has been one of the most challenging times in my job as a department chair in terms of the multitude of challenges that we faced early on. I think it was characterized by just figuring out how we could even safely see patients in our clinic and do procedures. As we learned more, then there were many more practical challenges in terms of our otolaryngology practice. Whenever there was a surge, we kind of got hit by two sides because our hospital, the first thing they did was shut down elective cases. Well, we do a lot of elective cases. They said, but you can do the urgent ones, you can keep going. But many of our urgent cases required trachs and free flaps and ICU care, and they said, well, we don't have any ICU beds for you. So it felt like we were getting hit on both sides, and this is where I wanted to bring in Dr. Borelli and share with us some of the ways that we dealt with some of those challenges I just mentioned, and yet tried our best to take care of our head and neck cancer patients.
Yeah. You hear me? It's working.
Speak quickly.
All right, yeah. So, that was a pretty tough time. I think Chris Lay and I had a case probably in April 2020, and it was right when our hospital shut down, and it was a big cancer free flap, and we knew that we had to do it. There was a nut carcinoma, which is extremely rare and really aggressive, so we didn't have a whole lot of time to kind of just figure out how we can delay things. We had to find a way to make it happen. And so it was, I think, very challenging initially just to kind of talk to people about the necessity of these cases, but also at the same time talk to leadership about the protections that we were requesting in terms of these so-called high-risk aerosol generating procedures. And so something like an 8-hour sinus surgery, maxillectomy, free flap, certainly in somebody who, has COVID, would put everybody in the operating room at risk. And so, I think it was a lot of lessons learned in terms of trying to explain to people what we knew about COVID. We watched your talk initially and learned a lot from that, and we relayed a lot of that information and convinced people about how important it was to take certain precautions, masking, just testing, certain things that we thought were important that others did not understand. So we sort of quickly came up with a testing protocol and We were, I was testing people in the parking lot, learning, trying to just get things going quickly so that we can get our patients quickly treated. And so as sort of this became a bit, as people realized this issue was not going away anytime soon, the hospital then, came up with a lot of different protocols and procedures in place, a lot of which I think we helped with primarily because we were starting a lot of those protocols. So fortunately, I think things are a lot better now. We've come up with a way to treat these patients urgently and not delay anybody. But I think there was a good 1 or 2 months where we were triaging cases, we were delaying cases. Yeah.
Yeah, I mean, it was definitely a tough time. But I think, everyone sitting at this table really helped us at U of A and Banner to really continue to treat these head and neck cancer patients that, honestly, that were sent by the community. So there's patients that you guys sent to us to take care of, and fortunately we were able to get through it and with the information we had at the time. And it's crazy. It's almost 2 years later, and, we've learned so much in the last 22 months.
Anyone else want to? How about at Mayo? You guys have lots of resources there, I bet. You never have to cancel any elective case.
Yeah, I wish that was the case, yeah. Yeah, exactly. No, it's the same thing, though, as we actually are testing in the parking lot. But we went through the same thing. We actually just got approval to start back to full numbers again, just because the hospital is always full. And so with those same spikes, you're seeing cancellation of elective procedures, same things we saw everywhere else. I think it was one of those things where resources or not, nobody really knew what to do. And so we were all, it seemed like every single day there was some new guidelines, new we had to follow. And honestly, nobody really knew what we were doing. We were just moving forward. The one thing I do remember is we did have a patient who donated gas masks to us all. And so that's actually what we started off doing to try to push through with our cases. We had big ski masks and then these big gas masks. And then we went to the OR and none of us could hear the other person talk. We did not think that went through. So that did not last very long. So that's about a week or so. That was about as far as we got with that, yeah.
Okay. Well, picking up on an audience question earlier, I did want to take a few minutes to talk about, for me, which has really been something that is, really something different in my life. I mean, I as a doctor, as an otolaryngologist, I think there is this certain, level of respect that people have, but really, I think that role really came to the fore during the last couple years, and to me, I think it's an important topic that I wanted to spend a few minutes talking about in terms of what is the role that we have, specifically as otolaryngologists, or even just as physicians, for being advocates for public health, for being a source of facts in the face of, in some cases, overwhelming medical disinformation. These are just some of the few, and you could fill up slides worth of various conspiracy theories or false facts that are out there. As physicians, I think we're in a very powerful place, and I think we should recognize that, and I think it's important to, like I said, reflect on it and think about it. We have, it's almost every week that I actually, I'm a head and neck cancer doctor, and yet I get asked questions just like that one about vaccines, and not just from the patients, but from their families. And I recognize, because in many cases they're my patients that I've been taking care of for several years, that they may come from a very, very different perspective than me, but they'll listen to you. And I sometimes can't even get my own, family or friends to listen to me, and sometimes because of the fact that the reality is our society has become so divided on so many different tribal lines. But that special, environment where the patient is in the room with you, particularly if it's a patient that you've been treating for a while, and that's an opportunity that may be the best opportunity to ever reach that person that may have been influenced by, misinformation. And so I just wanted to get, some of our panelists, if they want to be willing to share some of their experiences in the past couple of years, similar to what, this gentleman had said about, having to deal with patients and trying to help them separate fact from fiction.
We have one microphone left. I'll start, and I'm sure everyone has very sort of similar stories, but I'll say that because I was asked by our dean's office to create this COVID thing that I do every 2 weeks, it has really sort of made me put myself out there, and so that's why it's on YouTube. I post about it on social media. I didn't even have a doctor Instagram. I just had my personal Instagram before the pandemic. Now I have a doctor Instagram. I was never on Twitter before, and now I'm on Twitter. And it really is the fact that, like, if there is a void, it will be filled. And it just depends on who you want to fill it. And so I felt a sort of responsibility. I'm looking at all this data anyway. I have to for our School of Medicine. And so I might as well put it out there at what the facts are. And so that's part of what I do, is just try to fill that void, sort of push back against this huge wave of conspiracy theories and misinformation with just some facts. And I don't, share a whole lot of opinions, but I will say when my own patients ask me about it, which many of them do, and as I'm sure yours do, some of them are just curious and want to know because they trust you. And some people are definitely already in a separate camp, and they are testing you. They want to sort of see how they can find a hole in this conspiracy theory. And what I tell those patients who really are coming from a totally opposite place, and if I met that person on the street or in the bar, I probably would not even try to engage in conversation with them, because it's so rare that you can actually bring someone like that over to your way of thinking. But if they are my patient, and we either are building a relationship of trust or have already had that, I just seriously ask them, do you trust me about this? Do you trust me about that? Are you going to listen to what I want to do with your sinuses or your smell loss or things like that? And if you trust me on that, why would you not trust me about this other medical or scientific issue? And not only that, why would you not trust in the over 99% of physicians in this country who have been vaccinated? Because if you really think that all of us are in on some conspiracy theory, I mean, that's a whole other issue that you're not going to be able to breach with anyone. But once you sort of tell them, we're not all on some pay accounts from big pharma or whatever they think. We're not all just brainwashed because of this or that. If you can really just start to talk to people about the facts of, what we believe, who is saying this or that, and just try to relate to them, that's what I do.
Well, it's kind of along the same lines, but I think in a patient-doctor interaction, you still kind of have the upper hand because you're the physician in the office. But early on in the last school year, I became involved with other moms to try to get masks for our school district. So I actually went to an actual in-person school board meeting where we were overwhelmed by these anti-maskers. So we felt very intimidated. But I mean, we still got up there and spoke our points. Because before that, the school board just heard from these people over and over. I mean, they were there for their CRT stuff. They weren't expecting us to be there. And yet we had our little organization going. So I think at the end, even though I think the school members were ready to give us the mask mandate, but certainly I think our presence and our emails and our very, very long and detailed write-ups, I think that definitely helped, because amongst all the different neighboring school districts, counting a Foothill School District, where many of our children belong to, we were able to uphold the mask mandate, whereas a lot of the other school districts did not. So then there were a whole lot more infections in those districts, leading to some shutdowns. And so far, we've been fine. We've only been having in-person schools. So anyways, it got me involved on a grassroots level.
I try to tell my patients how awesome it is to have a microchip in my deltoid. I mean, it really just has opened up a whole new world of Wi-Fi. I never have cellular problems. And, you know, I'm a head and neck cancer doctor. All my patients smoke. And I kind of look at it as the same way. You know, there's really good, I'm not joking anymore, there's really good research out there. I mean, my microchip is telling me what to say, but there's really good research out there that says the more physicians, the more times a physician tells a patient to quit smoking, like don't ignore it. Like every time you come to me and I know you're smoking because you smell like smoke, I'm going to say, hey, can I get you to quit smoking? And they say, oh, doc, I don't want to quit smoking. I said, that's okay. You let me know when you're ready to quit, and I'm going to ask you about it next time. And the more times you're able to interact with that patient, and that's all you have to say, and then you can leave it and go on to, you know, how's your laryngectomy? How do you get the cigarettes in there? You know, you can go forward and you can continue the relationship with the patient, but you just meet them where they are, you agree to disagree, and that's kind of how I've been approaching patients who don't want to get vaccinated. You know, they want to tell me about all the conspiracy theories, and I say, stop. And I do say, I'm like, I love my microchip. And being vaccinated is the safest way I know how to protect you from hospitalization from COVID-19. And I'll tell you that next time too, but let's move on. We're going to agree to disagree, and we're going to move on. You know, a lot of our patients, you know, go to Mexico and get these IV aloe treatments or IV vitamin C. I have one guy who takes like rectal ozone. I don't know what that is. I will say he's cancer-free. There's lots of stuff out there. It's crazy being a doctor. It's the best part, actually. But I think it's hard. You know, patients have their ideas in their head, and maybe one day they'll change, and maybe one day they won't. But I think it's a wonderful opportunity as a professional and in a patient who you have a trust relationship, just to say, yep, okay, I agree to disagree with you, but I'm going to say it again next time, you know, and throw your cigarettes away and stop putting that up your butt.
Yeah, I guess, you know, the only other thing I can think of to add, you know, there's, you know, to your point, you have this great trusting relationship with physician and patients, and you've a lot of these patients you've known for a long time, but this is very specific because it's so emotionally and politically motivated for people now, and it almost doesn't matter per se what you say or what your belief is on, hey, this is vaccine. By the way, we are all on the payroll. I don't know, you missed that memo apparently, so you may want to get it caught up. So, and like what I guess I try to do is share some of my experiences, you know, basically being on the inside. You know, I've had a couple of patients that have died during COVID in the ICU, and the family could not get in to see them. And that patient died alone. I mean, I remember, like it was yesterday, a patient was in the ICU for a couple of weeks and died, and I remember as his heart stopped and we watched him pass away, shaving him, because his family hadn't seen him and he hadn't shaved, and then we didn't want him to look like that. So, you know, those kind of things really, I think, stick with people and know, hey, this is real. You know, there are people that are dying. We've experienced it. We've seen it. And sometimes hearing that personal story from your physician, who they trust, kind of gets away from the chips and those types of things. So I tend to share those experiences with people.
Anybody else? Well, so then let me get on my soapbox for a moment and just share my own, you know, personal thoughts about this. I think that we have to acknowledge the reality that in some sense science is under assault, and so we play an important role because our patients in general trust us, and so that's an opportunity. Because if we don't, then, you know, we're going to see that, in a sense, that respect that society has held for us start to get eroded. And, you know, sometimes in my pessimistic moments, I worry actually the inverse of what you just said. I mean, the fact that if people start questioning the CDC and the NIH, are they going to start questioning the recommendations that I make in terms of treating their head and neck cancer? And so I don't want that to happen. And so this is, like I said, I think it's a bit of a wake-up call for all of us to, this is why we became physicians, and we do have, I mean, even with vaccine acceptance, I mean, there really is, in terms of increasing that, it's really the personal conversations with people's physicians seems to be the most powerful way to, more important than any public service ad or anything like that, or any politician saying something. It's really their own doctor telling them that is what's going to be the most powerful. So, our time is up, but I want to end with one more. Just for fun, I'm going to go through and ask everyone to complete the sentence. 1 year from now, the pandemic will be. Let's start on the other end. Let's start on the end, and we'll come back and we'll let Dr. Patel close us out. So that's how we'll do it.
It's like Mad Libs. So 1 year from now, the pandemic. I think we'll learn a lot about ourselves. We'll learn a lot about the science. I think a lot of people are probably going to burn out from our field, just with all the things that you were talking about. But then I think we'll probably get an influx of new people that really want to do medicine for the right reasons. Talking to medical students, you see them volunteering to give shots, the vaccination clinics. So it will be interesting. It'll still be here, probably to a lesser degree, hopefully. We'll have learned to manage it. But yeah, those are my thoughts.
Yeah, I mean, healthcare burnout is a whole other topic that's a big deal right now. But on the hopeful side, medical school applications are up. So, go figure. But go ahead, Dr. Lai.
Yeah, in 1 year, I think we'll just be better educated and better prepared to deal with the pandemic and evolve like we've done in the last 22 months. And hopefully, we have some people on the other side, camps who come over and join us.
Yeah, well, I'd say 1 year from now, the government is going to reveal it was a conspiracy.
I think 1 year from now, the pandemic will be raging, just like it is today. And I think that a year ago, the pandemic was raging, but some would argue it's raging even hotter right now. But our comfort level is much different. And I think as a society, and especially as a medical society, we not will make friends with the virus, but we will learn to cohabitate with the virus. And, the virus is teaching us a lot about who we are as scientists and who we are as doctors. And I think we're going to continue to learn over the next year. But the pandemic is raging today in a very different way than it was raging a year ago. And I think a year from now, we're going to be learning some new things that we don't know today.
So in 1 year, I'm hoping that we'll say what pandemic. So I think that obviously the virus will still be here. We're learning to live with it. We're getting vaccinated. It's milder. Our hospitals are becoming less full. So I think hopefully in a sense we'll be saying that because we'll be moving on, and that we found ways to live with it. But I think we've a lot of practices that were developed during the COVID era are likely here to stay.
In a year's time, I think there still will be ups and downs, but we won't be nearly as afraid. It'll probably already have infected everyone. It'll be in a much, much milder form than it is now.
So
take us home, Dr. Patel.
A year from now, the pandemic will have become endemic in the U.S., but will still be at pandemic levels in other parts of the world where they don't have the same vaccination ability. But all of us will have learned a valuable lesson about what's really important in life, spending time with your loved ones and your family and your friends and not working yourself to death. And that's where we'll be.
That's great. Well, I want to thank all the panelists, and I hope you enjoyed this last session of the day. Do I have to say something too? I just actually saw this now. So a year from now, I think we will all be wearing masks when we do in-office procedures. I think that's a practice that's here to stay. But hopefully they will be wearing masks a lot fewer places other than outside of that scenario. That's my prediction. Okay, well, thanks so much. I think this has been a terrific day, but it's not over yet, because at 6 o'clock, actually just next door, we'll have a reception, and you guys are all welcome. But feel free to take a break for about half an hour, and then we'll reconvene at 6 o'clock. So thank you so much.